Okay, got it. And then to say got it. You'll probably say got it too.
There's one in the file. I'll make do with that. Okay.
I think it's going to be better to
Yeah.
maybe right because they have.
Yeah. Thank you.
Oh, thank you. Hold on. You guys already had breakfast?
Yeah. Well, I don't know if Kayla did. I came down and like right at 6:30, but the toaster caught on fire.
Oh, that's why it
Smells
smells.
weird. Yeah, the toaster caught on fire. And I was like, it's awfully smoky. And there was a lady walking along.
Oh my
Did it
god.
work for you?
Yeah, I haven't started recording yet.
Yeah, don't bother until.
Should I jump in like side by side?
Yeah. So I pinned the speaker. But then look, that's the screen. So what do you think that means? Maybe I need to, sorry, I'm distracted.
Please do it.
Maybe I need to, see, I pinned it. Maybe I need to spotlight. Spotlight for everyone. Continue.
Oh, it's also, I think there's like 3 seconds.
Okay.
Wait,
There's
it might
us.
also be in different, maybe like.
Oh, look, there we are.
Yeah.
It's still small. Yeah.
I want to try it.
People are messing around with it, obviously. Yeah, it works. It works. And then I'll minimize this, but then I can also go record to the cloud. So I'll do that. So
Yeah. And I'll record here.
yeah, and then I'll, like, that way we don't have to.
Yeah,
And it's one stress.
The thing is though, I don't think we'll be able to upload it during the day tomorrow.
No, I think we might do it tonight. So we're gonna have to make this space, aren't we?
I just don't have to edit it.
Yeah, it's true. Let's see how we go.
I like walking streets and I love it.
Are they too big? What's our speed do you have?
5.5.
Oh yeah,
Maybe that halfway.
so you go to 6.
And 6 is fine sometimes. Maybe it like goes like.
Yeah. You just sort of like distinguish it.
Yeah.
I used to work in a shoe store when I was in college. Why can I never put these ones in? I can never get this in. Oh man. There we go. Alright, if I would just wait out there now and get them across the register again. That's my only method. I'll try. Hi, good morning. Hi. Good. Just getting everything set up in here.
Yeah, this will use the bilingual one. Yeah, I do. Okay. Terrence. Good morning. You don't want to play around. You're looking all over the right. I know. I want to come over here. Just like that ball. How you doing? COVID, for various COVID reasons. We don't need help. This is another one. Yeah.
Okay. Really? That way, I've always appreciated your invitation a couple years ago. Sorry I couldn't go. So, no. There are days when I can't go. Yeah.
I'm kind of the type where I want to sit.
No, there's some.
I feel like there's like a trade-off between like coming to the door for me to like not have something for like
Yeah. You guys are pretty much
How are you traveling?
Good. Oh, yeah.
I got to wait for me to
Which airline?
United.
Right. What is this? I mean, are you a 30-year-old flight get that?
Yeah, I was supposed to, it was like really kind of small too, and I was like, just thinking like in December, I was going to fly with my, like an infant, and I'm like, man, this is going to be a tight fit, like keep this kid on. Yeah.
$12 on the plane.
Yeah.
Wow, you can't see that at all, huh? That's not good.
Yeah, we're just like,
We gotta get this light off here.
like,
We
there
can
is a
shut
way.
these lights off. You can't, we have to go secret.
We're gonna turn the lights off.
Oh, okay.
Yeah. I just left them on now because I don't want people to. Oh, sorry. I just left them on now because I don't want people to get lost.
Yeah, that's like,
If we have to worry about people getting lost.
You know, like I don't want them to spill their coffee and not be able to see what they're eating and drinking. Yeah.
No, it's fine. I was just saying, it's fine. It's just like, we might get lost.
How's that, Bill? Is that a bit better? Should I do it a little bit more? Bit more than that?
What are you doing?
Turning the lights down?
Oh, that, I didn't have like that.
Yeah. Does that look better for you?
Well,
Yeah. This middle one,
I
yeah.
would go now.
Okay. I'll see.
So,
Sorry, I'm new to this. I'm new to this lighting system, so I can't see what I'm doing in the polls at the
like, do you think it's getting or?
It's not going off? I might have to I'll your just in charge of the room. You're right. This circular one, this is.
yeah, so you had that off. So,
Okay, I'll call them.
Yeah, I should have used that.
No, I don't know,
Like,
yeah. Listen, this wedding day, yeah.
I don't know, I didn't have a difference. Yeah, very much accurate.
Keep up with this stuff.
Well, it's over. I think we have very good backyard, so. Yeah. And that too. We're getting. And I'm. I think I'm gonna deal with like the actual wedding.
Yeah, all for me. It's not.
None of us.
Oh, you don't want that. Listen, I thought that's I thought that I mean, you can see, I mean, that's fine. You have to do that too.
Yeah.
But there's just something about how
I just like on my yard, I like the Catholic. I feel like for myself, like I want to grow one for myself.
So, but you're one, that's just.
Well, also, yeah. We got married.
Yeah.
I think,
I believe the 15% is
I'm sorry.
that being last year, yeah, you know, I'll feel a lot better. Can't have any like, want to be, I guess after high school, I was like, I went to a place where I never failed for a job, so it didn't have anything like definitely no fun. I'm pretty sure that basically was a return person, but then part of it is yeah. Yeah. That's so cute. Well, you should get to work. I'll be
Oh yeah, there's no wood on this one. Yeah, that is kind of important.
I know. I'm like,
Omar's supposed to be coming back shortly because I asked him, this light is just a bit too bright. And I don't know how to, I don't want to mess around with it.
of course.
I see that we talked about the same thing. The minutes.
Oh yeah, so I made these. I didn't know whether you wanted to do this. I just like, I got 1 minute, 5 minutes. Oh, yours is clearer. Yeah, so yeah, there you go. Extra copy.
Extra copy.
So this is the easiest thing just to go like this, right?
That's what I thought.
Yeah. If you want, I can do it from here if you want me to thing, but maybe
Not gonna use too much of your time.
I don't think so, because I'll just be watching the time anyway. 15 minutes per person, but in the opening, how do I do it?
I think the opening you're gonna be okay.
Okay. Yeah, I'm fine to do that.
Yeah.
Because then they can see me, that's all. They can see me
Yeah, I
right
was
here.
thinking about like these,
I don't know how I'm gonna do it for the online people. That's gonna be the hard part. I might send them a message when they log on saying, I'm gonna write a message in the chat.
Yeah.
You know what I mean?
Yeah.
You can't exactly hold the thing up and be like, stop talking. Yeah, so this light's gonna go off. I'm just waiting for Omar, who's gonna show me how to do it. I'm not entirely sure. Mine are later.
has the least amount of weight to hang on there.
Yeah, it's certainly not me.
Blank.
Maybe Summer, she's quite light.
All the eyes.
How are you?
Yes, and there's.
I know. It's a little weird. That's strange.
Yeah, that's what he does a lot of it. That's what he's needed.
Or just special.
You're right.
Yeah.
Do you have that list? Can you please send that list to Tatiana and me and say, urgent Tatiana, just add these people to their badges. Yeah, let's find it out. We're trying to find that list.
I'll find the list on board.
Yeah. Wait a second. Where is it? So, Kayla is I'm wondering if there's sharing schedule additional questions. This one. I'm CCing you in, but then I said something like these people don't have accounts or something, and she never responded.
Yeah. Yeah, there are also some where she's like,
Yeah, sorry.
I actually posted a CR. Yeah. Yeah, there's three ones. There's an open one. I'll let you say.
Who guys got the best?
Be careful.
All right.
I'll just get water. I promise water. I'm good. Well, thank you. You know what?
This is my biggest issue. I want to be up. Do you have like a little podium step?
I don't, but we can ask for one.
We're trying to get rid of this light here because it really blocks
Oh,
the way
okay,
it really
thank you.
sees screen.
Okay, when they come, what, I gotta.
It's supposed to start in about 10 minutes. So.
Oh, well, you gotta get going.
Yeah, the other. I'm trying to think if they don't have.
Yeah, just a couple books we have, but,
Yeah, just
well, I'll stand on my tippy toe.
Or we could so we could just hold the line.
Yeah.
It's up to you.
That might be, well, we'll figure it out. Yeah, so we're all set.
Okay. Is it possible for me to get a copy of the presentation?
Yeah, how are you doing? That is true. It's good, yeah. Right.
Yeah.
Nobody.
George.
They're gonna turn this light up. Light up.
Yeah. Well, there's some. I'm back at social work. Nice to see you.
Sorry. Oh, I'm the director for the consensus building session, but I was wondering if I could also get a copy of it. Yeah, so actually, every single person slide is on the next meeting. So
Yes.
yes, I pressed everything. I should stop pressing. Oh, no, yeah.
It's very.
I know, I was just giving out like I'm gonna make everything worse if I keep doing this. But this is just, oh, that, no, that's the top one. Nice to meet you. Oh, it's definitely going down
There
now.
we go. This one.
Okay. Okay, perfect. And I think that's, in fact, that's fine. We don't. Yeah, okay, that one's on. That's the main one.
Yeah, this is like the last one.
Okay.
And then.
Yeah, back there. That's perfect. Oh no, but now it's too bright here, sorry.
Okay, no worries. Okay, so.
Sorry, Emma.
No, you're fine. I got some still fine.
It made it much worse. And there was like people watching that. I'm like, I'm just gonna wait until someone else comes.
I guess that's true. So it's like try.
Thank you so much. There we go.
Well, yeah. I mean, it's a whole flow of things.
Thanks for that. Sorry.
Is this lights okay for you?
I think that should be fine. Yeah, that's
Okay, let me show the other one.
if anyone asks. Oh, they're back on. Yeah, no, all of the circle ones.
Agreeing over us.
Yeah.
My son stated,
That's me.
Oh, sugar, more than she wants over there. I'll tell you that. It's so sunny. It's like being in summer. It's okay. You know, the Russians back there because they're on the coast of DC.
Yeah.
It's on the coast. Great spots.
Yeah.
Where's she at?
It's on the yeah, a lot better. Yeah, so I appreciate it. And then not just the music I just haven't made it back. Yeah. Do you just walk? No. Oh, okay. I know. I was like, okay. I'll put on the music.
But then you're gonna go sing. You're gonna have a pretty hot out there. But you're not in the sun. Clear. Quite nice.
I'll just do it behind. And this is 619. Oh my God. And just so you know, my number is 917 number, so you can get a thing from a 917 that prompts me. You're right, thank you, sorry. Just have the house right there. Oh, now. Oh, well, that's everything. Okay, so he just read the timings. So, Elise is really, he's not sharing.
Then I'll come back. So next weekend yes, right. Yep. I'll just get my. It's officially 8. Let's get started. Is it good now, Tamsin? Right here? Because I'm short, right?
It's not on. It automatically turns off after a while. There we go.
Hello, everyone. Good morning. And welcome to the 2022 International Conference on Aging in Americas. We are so happy to host you here. After all this pandemic, it's so good to see faces, give you hugs. It makes a huge difference. And welcome to the city of Chicago, this beautiful city in the state of Illinois. Chicago has continually welcomed many immigrants, and its neighborhoods tell stories of hope and resilience that we are going to be discussing during this conference. This year, we also have a hybrid format that allows us to welcome colleagues from many places around the globe. And believe me, we have people all over, including Japan. So it's really like go all around from Latin America to Asian and every other continents included, and to participate with us. At this time, I would like to introduce you Dr. Jackie Hell, who will introduce you to the conference series. Jackie.
Thank you, Flavia, and welcome everyone. We're so glad that you're here. I'm going to give you a background on our conference series. And if you want to begin by looking at this QR code, you'll be able to access the program. But a little bit more about our conference series on aging in the America and all of the different iterations we've had for the last 20 years. Over this period, we've been guided by the Lamar, the leadership of our team, to investigate important dimensions of healthful aging. We've taken a transdisciplinary approach and done this looking at very important mechanisms that will determine not just at one point in time what the health and well-being outcomes are, but also looking at this over time and the dynamics of it. Roberto Salas was the artist that put that beautiful logo together for that. And it has provided guidance since 2001, when we began our boutique conference, I should say, looking at intergenerational support with Dr. Beth Solos and the MHAS team, and with Doug Wolf. And we have, you can see from all these different areas, we've looked at different aspects of society in which the Latino population and people of Hispanic origin and in Latin America operate in these different contexts. That's very important for us in the work we do in our transdisciplinary approach, both in Mexico as well as in the United States. And you can see here these issues that we have addressed and interrogated together and collectively have been guided by many different institutional contributions, including mostly in the Southwest, but we've had 3 bridging conferences in Mexico, 2 actually in Mexico, 1 at UT Austin, when we've been without funds, and we've had to take a year to put our application together. Mark your calendar now to save the date for our 3rd conference, which will be in Los Angeles on the 14th and 15th of September. We're going to be focusing on the implications of our longevity and life expectancy, both in the US and Mexico, and more to come on that later throughout the conference. We have, throughout these years, these 15 installments, been guided by our amazing advisory group. The co-investigators are Dr. Mikides, raise your hand, and Dr. Vega, raise your hand, Bill Vega, and also Dr. Torres Gill, and this most phenomenal advisory group team. We have also had previous members, which includes our very close friend and scholarly colleague, Steve Wallace. I want to thank all of them. Many of them are here today in person, but also through our hybrid platform. And welcome also our UT Austin students who are logged on as well. We have been very productive throughout the years, throughout the meetings, and we've stayed in touch. We meet monthly, our advisory group, and we also have a very heavy focus on working together, both at the senior level, as well as our emerging scholars and our early career investigators. And we have a publications committee where we alternate both edited peer-reviewed collections as well as peer-reviewed journals. And the most latest project that we have, which will come out of this installment, this iteration, will be funded in our, will be published rather in our Aging the Americas series. This will be our 6th volume. And you'll be able to take a look at this work in the back of the room. And please reach out and let us know if you have any questions. We want to have everybody involved. This has been an important part of our approach to this, and we've embodied the Lamar gut to make sure that we can tie all of these important ideas and all of our work together. And just to take just one more moment here to really highly underscore the importance of our mentoring program. NIA has been very supportive of this from the beginning of our collaboration and our institutional partners. And it's extremely important to know how well they have done. And many of them also are here today. If you could raise your hand. For those of you who have been emerging scholar, you've been an early career investigator, and keep your hands raised. And for those of you who have been involved in the mentoring of our students and who are now assistant professors, associate professors, and full professors, yeah, we have it. Our NIA postdoctoral fellowships our NIA traineeships. They're all over the country and in Mexico. And we're really, really proud of them. And now I want to turn this over to Flavia, now that you have a little bit of background on where we've been. And she's going to be able to describe to you our goals and objectives this year.
Thank you, Jackie. Sorry, I'm moving to applaud Jackie. So I've done so much for this conference and everyone that's in this room. Thank you, everyone. And many of you also online, joining us online. So for this year, our topic is cognitive aging in Mexico and Latino communities in the United States. And our focus is really like trying to further understand the concept of resilience that we started a few years ago. It's part of like this project. So the objectives for this installment, we have these 4 questions that are guiding us, and we hope to actually put in the volume that we are preparing for this springer. So the first one, what's the meaning, theoretical and practical usefulness of the concept of resilience and understanding important aspects of cognitive aging. And in this conference, we're really going to look from the individual to the societal level, really talking about all the implications about the interactions and how they can affect the concept of resilience and how we measure it and apply it. We're going to be talking about interventions and how they can be introduced early in life to increase cognitive reserve. We have a full session actually on interventions at the end, the day tomorrow. How cognitive research can be enhanced throughout the life course in later life, and which cultural and social resources can be mobilized to promote brain health and enhance quality of life. And we're going to devote a whole session also to it. So I'm really looking forward to all these presentations. Of course, it takes a whole village, right, to put an event like this together. And I could not have done it without the support of my wonderful co-organizers. And so I want to thank you. Sylvia, please raise your hand for supporting us during this process. Thank you. Marta Davigus could not join us today. She's actually at NIH, but she asked me to welcome all of you on behalf of the University of Illinois, Chicago, to this area of the city. We also have Fernando Riosmena. Fernando, please raise your hand. Thank you also for your continued support this year. This year we have a very special poster session in honor of Steve Wallace, who passed last year. I'd like to thank Terence Hill for chairing that group. Terence. And Adriana Reyes, thank you so much, Adriana, for the wonderful organization. Emma Aguilar is joining us online. Thank you so much. We're also going to have the early career mentoring that's going to happen at the end of the day today, and we'd like to acknowledge Phil Cantu. Phil, please raise your hand. And Vero, that is Montes de Oca, that's joining us from Mexico. Thanks, Vero. In the consensus building that we're going to have tomorrow, I would like to thank the leadership of Sunshine Roads. Sunshine, please raise your hand. Thank you so much. And Angela Gutierrez. Angela, por favor. Thank you. And of course, I'd like to really thank our NIH R13 external reviewer, Bob Wallace, that has been doing this work for so many years. Thank you, Bob. And of course, there's so many other colleagues assisting us in the organization of this conference. And I really would like to also acknowledge our poster sessions, Emma Aguilar, Terence Rio, David Marquez, and Adriana. We have for the consensus building moderators, Lisette, raise your hand. And Mariana, por favor, raise your hand. Julie Bobbitt is going to come tomorrow. Iram, Fernando Riosmena, and Mark is going to be joining us tomorrow. For the consensus building, rapporteurs like we have Kylie, Felipe, Emma, Jennifer, and Jose. Thank you so much for helping us. I could not have done this without the assistance of my PhD student, Summer Shi Chen. Summer, thank you so much. She caught all the problems in the preparation of this event, and she was there all the time throughout this last year. She put together this beautiful document that is in front of you that you can also access to with your QR code in the back. Thank you, Summer. And the staff at the University of Illinois in Urbana-Champaign in the School of Social Work, Amy Harles, Crystal Watson, and Lynn Ewan, I could not have done without you. I would also like to thank the hotel here and Omar and all the people that helped welcome us to this place, and everybody working with the catering. There's a lot of people behind the scenes that usually we don't acknowledge. So, I really want to say that's a lot of people that actually take work. And of course, the people from the Common Ground, they are also here helping us with all the ITs and with the website. Let me call you attention to the brief highlights that we have. We have 2 consensus building and 2 keynote sessions and 1 consensus building. We have many invited speakers. We have presentations from the Alzheimer's Association research initiatives at the end of the day today. We have the poster session. And I really welcome to stay with us throughout these 2 days. We will have a special issue in the Journal of Aging Health, as Jackie mentioned, that will come up soon. And at the end of this event, we want to put together a volume. So please come talk to us. We have already a contract in place with Springer. And next year, I'll see you guys, of course, in LA. I want to acknowledge all the funding that we have. To fund everyone, to bring you here, to really engage in this collaborative research. It takes time, but also takes resource. So thanks all the funders that we had here. For this year, I would like to acknowledge the support from the National Institute of Health, the Alzheimer's Associations for their generous support, but also funding from the School of Social Work at the University of Illinois-Champaign and the Center for Health, Aging, and Disability at the University of Illinois in Urbana-Champaign. I could not have done without your support, and also the consistent support at the University of Texas. But all of these have provided enormous support throughout these years. Thank you, everyone, for taking time for your busy schedules to be here with us today. I hope you enjoyed this conference. At this time, I would like to introduce Susan Martinez, the Vice Chancellor for Research and Innovation at the University of Illinois in Urbana-Champaign, for remarks.
I'm just going to put it back on that first slide so that we have something nice. Okay. Sorry to be. Well, good morning, everybody. What a pleasure it is to be here to welcome you all to this binational venue and with global impact. I want to thank you for joining us today, whether you're here in person or joining us from elsewhere. I know how much the pandemic weighed us down, but it also helped us expand our vistas because we have developed this wonderful hybrid form of meeting where if we can't be here in person, we at least have the opportunity to engage. When Flavia asked me if I could be a part of this event, I was absolutely delighted that I could be here in person to welcome you all. And I'm already very much appreciating the wonderful sense of warmth with this research community. And I'm very impressed by the way you mentor your young and how the young have grown up to pay it forward. So it's really terrific to see that part of your community. If we've learned nothing else over the last few years, it's that when we think about living healthy lives, we know that our human connections matter. So I hope today and tomorrow are a really good day for you to be connected. Champaign-Urbana is just 2 hours down the road, a little bit south. And when I learned about the longstanding collaborations in this 15 plus years of the conference series on aging in the Americas, I knew I had to really arrange my schedule to be here. We are so delighted to welcome those of you who are here again in person. But I also want to thank you for tuning in from around the globe, no matter the time zone. I know Japan, it's probably in the middle of the night, so I appreciate you being here. We are grateful to the conference organizers for their incredible work to bring so many scholars from around the world together. I know you poured hours into this, Flavia, and your organizers have poured hours into this, and it really shows. So For those of us gathered here today, as well as you attending online, again, welcome. It's really incredible to be in a city like Chicago, as Flavia said earlier. It has such deep ties with Mexico as well as the rest of Latin America. And I also want to say on behalf of the University of Illinois, we have been building strong relationships with Central and South America. In fact, I have a team member down in Mexico City right now that's preparing a visit for our president as part of the collaboration. And as scholars here, we know that the best work comes when we collaborate together. But I think we can extend that further because you know that our societies flourish when we acknowledge and embrace the unique perspectives that each of us bring to the table, whether it's cultural or different disciplines. It all makes for a much, much better outcome. So addressing the challenges of an aging population that faces us is intrinsically an interdisciplinary pursuit, or I think the outcomes will be far better as we pull these different perspectives together. We can explore any of the research questions that will enhance our understanding of interventions and technologies and how to best utilize the cultural and social resources that support healthy aging without all hands on deck. That's why it's particularly exciting to be here and see all of you. I obviously am here representing the University of Illinois Urbana-Champaign. And when I look at the research program, I was really delighted to see the superstar researchers from my campus on the agenda, as well as our sister institution, University of Illinois at Chicago. But then I looked a little further. I'm a biochemist, by the way. So, but I looked a little further and I noticed really the breadth of the presenters who are here. And I'm thrilled to see so many experts from so many disciplines and so many institutions across the nation and Latin America. We have so much to learn from one another, and we're catching up after the pandemic with a little downtime. And these kinds of collaborations are vital to addressing these grand societal challenges like aging. We are very grateful to the NIH, the Alzheimer's Association, the School of Social Work at UIUC, the Center for Healthy Aging and Disabilities at UIUC, and the University of Texas for making these collaborations possible. You know that the best part of our job, this is the best part of our job as researchers, getting together and exchanging, being inspired. Our conversations and our connections mean that we can really change people's lives for better. What you're doing here matters. I think probably the more senior people really know that. The younger people, you're gonna see that as you move through your careers. So thank you again for your dedication and your hard work. I'm not gonna be able to stay the whole time, but I'm just really feel privileged to be a part of just getting this conference started. And I look forward to hearing about your discussions and future research directions. So thank you very much.
Thank you, Susan. Now I'd like to introduce you to Dr. Frank Bandiera, Program Official, the Division of Behavior and Social Research, the National Institute of Aging in the United States. Thank you, Frank.
And you should just be able to use those arrows.
Okay, so just press arrow.
Yeah, right,
Okay.
to go forward, left to go back.
Hi, I'm Frank Bandiera, and I'm a program officer at NI. I'm the program officer for this conference, and today I'll be presenting on NI Behavior and Social Research Funding on Hispanic health and health disparities. So let me say that we're an extramural research program, which means that we're the funder. We provide the funds mostly to academic research institutions. We do have an intramural program, and they're the ones that do the research. We have 4 divisions at NIA, where one of them were the Behavioral and Social Research Division. We have a division of aging biology. We also have a clinical division and a biology division and a division of neuroscience. So we fund social, behavioral, and economic research and research training on the processes of aging at the individual and societal level. We're interested in cross-disciplinary research at multiple levels, from genetics to cross-national research. And of course, we support Alzheimer's disease and related dementia, but we also support general aging research. So we mostly provide grants to research institutions on research projects like R01s. We also fund networks and centers. Networks are formed to form collaborations and networks. And center programs also provide networks, mentoring, and pilot projects. We also fund training and career development awards to diversify the aging workforce. So these are done as an early career awards like K awards and diversity supplements. And we hold workshops to gather information to inform NIA and what we could act on. So we have center programs, and I mentioned this because they're all related to health disparities. We have the Resource Centers for Minority Aging Research, or the RICMARs, which is to increase health disparities research and diversify the workforce. We have the Centers on Demography of Economics and Aging. So that's on demography, comparing, for example, geographical differences. And we have the Roybal Centers for Translational Research in the Behavior and Social Sciences. And we have an AD and a general one, and that's mostly to fund basic research and basic social science research and interventions. So the one I'd like to focus on is the RICMAR, because that's exclusively focused on health disparities. It aims to increase the number of researchers focusing on minority elder health, to enhance diversity in professional workforce by mentoring minority researchers for careers in minority elder health research, to improve recruitment and retention methods to enlist minority elders in research studies, to create culturally sensitive and more precise measures assessing health status of minority elders, and to increase the effectiveness of interventions designed to improve minority elders' health and well-being. So the one I'd like to focus on that is associated with this conference is the Texas Resource Center on Minority Aging. The PI is here, Dr. Martinez. And here are the aims for this study. The purpose of the Texas RICMAR, and I bolded the important information, is to provide an infrastructure that facilitates the development of research on health and aging in minority population, with a special focus on the Hispanic population in the United States and Mexico. So a special focus is on mentoring researchers from minority populations. And it's a great way to jumpstart your career and receive mentoring if you're junior. The center supports pilot research projects and you receive mentoring. And it's also associated with this conference, the ICAA. And they recruit scholars through conferences such as this one. So if you're interested in becoming a scholar, the PIs here encourage you to talk to him. So we do fund research networks to develop new areas. Again, these are all have an overlapping theme on health disparities. We have the midlife reversibility of biobehavioral risk associated with early life adversity, the reproducibility in the social and behavioral sciences, life course health and disparities at older ages, dementia care and services research, AD, ADRD, data harmonization, rural aging, stress measurement, genomics and omics of behavioral and social sciences, and integrating animal models to inform behavioral and social research. So the one I'd like to focus on is the one that's folded here on life course health and health disparities. I'm the program officer for that one, and it's focused on health disparities. The PIs for this one are Dr. Montes, Bergard, Humber, and Alshire, and it's called the Network on Life Course Health and Health Dynamics in 21st Century of America. So life expectancy in the US has been decreasing, and this varies by where you live in the United States. And in comparison to other countries, other developed countries, the US is lagging in life expectancy. So here are the aims for this network. The overarching objective is to strengthen the network to generate new evidence and disseminate data and analytic resources to better understand trends and disparities in US adult health and longevity across the life course and geographical context. So I bolded the important parts. Like, this is similar to centers. They have an interdisciplinary network that's emerging underrepresented scientists. And they also provide pilot funding, and they also, through this pilot funding, you can receive mentoring, and they do hold annual meetings or conferences. And I know I've attended, they have information sessions on analytical techniques, and they also have data resources. NI is interested in receiving feedback from the research community, so we hold the workshops and we collaborate with the national academies. So we've had reports on different racial, ethnic disparities, immigrations, international comparisons in Latin America, and structural racism. So they also suggest that we should establish research agenda for behavior and social research on Hispanic and health disparities. Like this conference is focused on, it calls for multidisciplinary data, and it considers the sources and the mechanisms explaining racial ethnic disparities instead of just description. And it focuses on social mobility among different immigrant groups, and it encourages cross-national comparisons such as US and Mexico. So we do fund Hispanic health, and here are some studies that we have funded on Hispanic health. We have the longitudinal study of Mexican American elderly health. The PI is Dr. Martinez. We have the Mexican Health and Aging Studies, or MHealth. The PI is Dr. Wong. We have the health of aging of Mexicans on both sides of the border. The PI is Dr. Rios Mena. And we have the influence of social and cultural context of life course pathways for Alzheimer's disease related dementia and care resources for older Mexican adults. And the PI is Dr. Downer. Some of them are here, so if you'd like to collaborate with them, I encourage you to talk to them. So we also have our own data to support Hispanic health and health disparities. We have the Health and Retirement Study, the Midlife in the United States Study, the National Health and Aging Trend Study, the National Social Life Health and Aging Project, and the Panel Study of Income Dynamics. We do have funding announcements here. These are some that we have. We have one on immigration, and I'm the contact. We have a notice on health disparities in Alzheimer's. I'm the contact. We have one on policy and Alzheimer's disease. Dr. Fazio is the contact. And we have one on measures and methods for Alzheimer's caregiving, and Dr. Carricker is the contact. So I should mention that you don't have to apply necessarily to one of these RFAs. You could apply to the parent program. So I'm here today and tomorrow. So if you wish to talk about NIH funding, I'm here, and I'd be happy to talk to you about funding. Thank you.
Thank you so much, Frank. And now I'd like to introduce Luis Miguel Gutierrez Robredo, who is the director of the Mexican National Institute of Geriatrics in Mexico. Luis, I know that you're online. Welcome.
Thank you so much, Flavia. Good morning, everyone.
Luis,
I'm
just
very...
give me 1 second while I make sure the sound is working here. Sorry.
Okay, thank you. Is it all right now?
Sorry, everyone. Just 1 moment while we transition. We cannot seem to hear you, Luis.
Now? Do you hear me?
Nope. Sorry. Give me 1 second. Let's switch here and go turn the sound up here. Sounds always. Can I ask you to just quickly say something again? Sorry, Louise.
Yes, I don't know if you can listen to me now.
Oh dear.
Now, do you hear me?
Let's change to this one. Could I ask you to say something again, Louise?
Okay, maybe now. Now, do you hear me now?
Sorry about this, everyone. Just 1 moment. Got this connected. Might have to go in.
Is it working?
What is...
Do you hear me?
No, sorry, we can't hear you. Sorry about this. 1 moment. It should be this one. We might have to go and get the tech person to help us here. Yeah. Okay, do you want to speak to Luis?
Does it work now?
Luis, I apologize.
Apologies
to everyone. That's one of the challenges sometimes of doing hybrid. Luis, will you be okay? Maybe joining us maybe tomorrow.
Don't worry, I will be following the
earlier
conference.
on. Maybe you type, you say yes, or like with a thumbs up, like so we can see it. We can really hear you. Okay, I'll be in touch. Thank you so much for joining us, at least in, like physically, like, you know, in Mexico. And I apologize for like the tech, like this entire hybrid go back and forth. We're still learning it. I'll be in touch so we can get it tomorrow. But on behalf of Luis Robredo, I would like to welcome all of you here. And you know, like it's a binational conference, and you know how important it is for us to have these collaborations with our colleagues in Mexico. Thank you, Luis. And again, my apologies. Everyone, I wish I could change it, like put it here, like everyone is waving and saying hello. During the time, I'm gonna invite the first panel to join us. Actually, before that, we have our keynote speaker, Sylvia Mejia. And Sylvia, please welcome us.
Can I use my laptop here for the script? No, my script.
Your script? Yes, let's move it. Why don't you put it here?
Okay.
Right?
So I assume that you cannot hear me, huh?
It's not going to work.
I emailed my introduction to Flavia.
Okay, I'll present myself.
My apologies. It was working, you know, 20 minutes ago, but as soon as when someone's in front of you, it doesn't. So give me 1 second, I'll bring up the PowerPoint. Sorry, I will just make it bigger for you. Okay, and I'll just, oops. So you can just use those arrows there to go along.
Which?
Just that's to go
Okay.
forward, and then that's to go backwards. And I'll hide this so it's not in your way.
And what is the best way? I have my script here. Do you think it's better to have it there?
We can put it next to you if you prefer. It's up to you. It might not fit. Just go like this, and then you can scroll down this way. Okay.
Okay, good morning to everyone. Rebecca was going to make my presentation, and she was going to moderate my talk. I think she had to stop me at some point, so please stop me because she's not being able to connect. And Rebecca was perfect for the presentation because I've been working with Rebecca for many years. I have been working with the MHAS data, specifically with the cognitive data for MHAS, and it's a long journey. We're now working on the MEXCOG, this subsample from the MHAS that was assessed and reassessed for specific cognitive performance. We have now a lot of things going on with the HCAP and the MEXCOG, but MHAS is still giving us a lot of work to do, and MHAS has now a lot of information that I want to bring out in this talk, especially to show most of the students who are here, how do we take advantage of all these survey data that we have about older adults in Mexico, in the US, but I'm being concentrated in the Mexican population. So first of all, I want to tell you that when I was thinking about the name of the talk, the only thought that came to my mind was Mexican population needs to be resilient to many things, to many conditions. I am not from Mexico. I am from Colombia. I came to live to Mexico 20 years ago. And as a psychologist and as a neuroscientist, I was aware of the so many factors that affect the health of the Mexican population, which many of them they are not aware of. And I think that's a very important point, because we need to understand that it's not that they cannot change that, but sometimes it's that they don't know that those factors are affecting their lives. And one of the scenes that I always have in my mind when I arrived to Mexico in the year 2000, the last time I came back to Mexico, I was working at the hospital where Luis Miguel Gutierrez was my boss. And the hospital is located in an area which concentrates many other hospitals. And on the road to the hospital, what you find is a lot of food carts, not food courts, it's food carts, street food down there, offering a lot of food, which if you look at them, I hope you're not hungry, because if this was around 12 or noon, we would be very hungry because all this food is so good, so good. But anyway, so this scene of watching this lot of street food down there in the middle of all the hospitals, because you walk to the hospital and all these stands are there. And guess who's sitting there? The patients. The patients who have obesity, who have diabetes, who have cardiovascular disease. And they are sitting there eating while they are waiting for their appointment to happen, or they are finished with that appointment and they're having their breakfast or their lunch or the food, the meal between lunch and the next time. So it's permanently. You see people there eating and eating and eating. So if we look at this scene, you think, does Mexican population need to be resilient to their own eating habits? Eating habits that are definitely defining their health, but that they are not going to change them because of many factors, one of those being poverty, being health inequalities. So that's what they can eat, that's what they can afford, and guess it's the best food we can have. So is exercising a way of coping with this type of eating habits? Maybe for us, but not for them, not for them. Exercising will, if we explore exercising, we will have to move into other areas and understand that exercising is not available for them. It's not available if we think of parks where they can exercise. For example, Mexico is not full of parks for exercising. Anyway, so we can go on and on and on, and we will leave in this type of exploration. That will show us that being resilient in Mexico for the Mexican population is very hard. However, if we are trying to understand what is that makes the people resilient, we need to understand there are many factors that are playing a role, and that these factors are important in their own way, but they are important together too. And this is my review of the literature. So I'm not going to talk anymore about the review of the literature, because if you look at this slide, there are all the papers, well, not all, excuse me, some of the papers, many of you who are sitting here have written, many of you have been here in this meeting telling us about the results. And we have a lot of sources of information that will tell us how many factors are playing a role to define the health of the Mexican population. Many of these papers have been done using the MHAS data, and all the titles are very suggestive, and it's not one or the other that I want to point, but many of them, which I'm gonna go on further mentioning the factors, can be read in these papers and understand how are they playing this role in resilience. But let me go into the theme I have been working on during the last years, that is cognitive aging. So if we look at cognitive aging, now that I have presented all this, my point of view about Mexican population, and I think it's also your point of view, this social ecologic model of cognitive aging is as complex, we can make it as complex as we want. So I am mentioning a lot of factors that are influencing cognitive aging. And the model has a big benefit because it's talking to us about the different levels in which these factors are influencing the individual, who's most of the time the one we are studying. So if you look at the model, you can arranged these factors that I am just mentioning there and that are part of the papers that I just presented, but factors which are part of the individual's own health, but they are also part of the family and social surrounding of the individual, or we can go up and find some factors as part of the environment. And finally, the government or the public policies that are the ones that will let us understand how government changes, as we will see further, are impacting individuals' health. So there's the list, and that list, I'm sure every factor that I am mentioning has been studied and has an impact on cognitive health. But the picture is not static, the picture is moving. We cannot think of the factors affecting individuals' health as something static. It's moving through the years. And this is a paper we wrote recently trying to understand what has happened between 2001 and 2015 with the MHAS data, and understanding how the cohorts that participated in 2001 and 2015 were different. And although many of those that are in 2001 are still in 2015, the cohorts have changed a little bit. So what has happened in these 14 years? The arrow is showing us what has happened. Everything has increased. The access to health has increased, but the BMI also has increased. The treatment for cardiovascular diseases has increased, but the cardiovascular conditions have also increased. And finally, education has increased. So all these forces that are like in different directions have, what we were going to do is to look at the impact on cognitive aging. We wanted to see what happens between 2001 and 2015 in cognitive aging. But in this slide, the cognitive aging is not considered. I am only mentioning what is happening with these trends. And just take a look at education. Education has increased in the population 60 and over. If you look at the mean, it was 3.6 years of education in 2001. And in 2015, it's 4.9. Is that increase considerable? Is that increase significant to see a beneficial effect on cognition? No, it's impossible. So when we were discussing with the HRS team, which they published that prevalence of dementia decreased along the years, and they attributed a big part of it to education. Many of us thought, yeah, our education is also increasing, but it is increasing this amount, and a change from 3.6 to 4.9 years is not going to be beneficial for cognitive aging. Cardiovascular conditions, especially hypertension and diabetes, have increased incredibly from 2001 to 2015, 10% increase in hypertension approximately, and diabetes has increased terribly. But then we look at treatment, and we are so happy to see that treatment has also increased, and maybe it has increased because of two things. First, people are more aware of the diseases and they are consulting, and because there was a reform in the medical system and the government opened access to health to this Seguro Popular at that moment, which everyone had access to, with many limitations, because now Seguro Popular has been greatly criticized. But anyway, it did the job. People had some kind of access to health that they didn't have before, as you see in the light in the last line, where you see that 56%, 56.9 or 60% had access to health in 2001, and in 2050 it was 90%. And lastly, BMI. BMI is very, very bad because, as you see, obesity has increased from 16% to 20% in these 14 years. Okay, so this is the picture and how it is moving. So how is this impacting cognitive aging? And I'm not going to stay and talk about the rest of the paper and the results, but I am only showing you a little summary of our results. And they are showing that the overall prevalence of dementia in 2001 was 6.1%, and it increased to 7.3 in 2015. For males, the increase is 4.6 to 6.2, and for females, it was 7.3 to 8.2. So at this point, we have to think about a gender effect, sex inequalities, and anyway, the paper is there if you want to review it. It's very interesting what has been happening. But what I wanted to show is that the picture is also moving. Anyway, so to tell you what I did with the data on cognitive aging and to get into directly into the results about the analysis that I did, I want to briefly mention how we measure cognition in the MHAS. MHAS has this battery. It came from originally in 2001 from the cross-cultural cognitive examination that has the tests that are on the top. It measures constructional praxis, verbal memory, visual scan, constructional recall, and delayed word recall. So we are measuring memory, attention, visual spatial abilities. And what we have been doing is adding some other measures to try to capture many other things that are important for the classification of cognitive status in the older adults. And we added some questions on orientation, verbal fluency, backwards counting to measure speed processing, and the test of serial 7 to measure executive function or working memory. And the MHAS also has a proxy assessment, which is the IQ code, the Informant Questionnaire on Cognitive Decline in the Elderly, to measure cognitive status in the population, which because of health problems cannot answer the survey directly. And with all of this, with these two sources of information, the direct assessment through the battery, the IQ code, and the information about their activities of daily living, we construct our classification of cognition into normal, CIND, or cognitive impairment, no dementia, and normal. And this is the way we construct the variables. The variables are already constructed and in the data in the public place where you can access the data. And in the part mentioning constructed variables are the variables for cognition. So we have 5 waves. All the waves have information about cognition, classifying all the subjects in each wave. And we have a lot of individuals who have been followed up. So longitudinal analysis for all you students here is open in the MHAS data. It's there to be explored. So that's what I want to tell in the rest of my talk. They are all classified and you can work with them. I'm doing on the time. Perfect. Okay, so what I did was a sample. I selected a sample from MHAS. I started in 2001. I selected all the subjects who were normal, and then I moved through 2018, selecting subjects only that were normal. Normal in 2001, 2003, 12, 15, and then I stopped in 2018, which is the last public available data that we have. So how many people are there? How many follow-up individuals do we have? We started roughly with 9,000 people normally classified there. And then we move and we end up like around 2,300 people in 2018. However, the analytic sample was reduced from those 2,300 that I last mentioned to 1,308 because I needed them to be consistently normal. And if you look at the data, you see that people move from one cognitive status to another because of many factors that are influencing the assessment of cognition in that day. Anyway, so they are moving, so we needed them to be consistently normal so that I can talk about resilience. I didn't want to mix people there who were not all the time normal. And this is what I get at the end. Normal was a trajectory where I have 1,097 subjects. Those who were normal all the time, and in 2018, they converted to CIND, 125, and 86 subjects who converted to dementia. The next step was selecting the variables. And this is very, very difficult because you have a lot of variables. So you need to understand which are the variables that are really important from the conceptual point of view and from all these results that we have mentioned before. And I selected 35 variables recorded using data from all the waves. Remember, I'm watching the people, the 138, the 1,038 subjects, all the waves. So these 35 variables were recorded. Only one thing, 7 of those 35 variables were not considering all the waves because they were only introduced in MHAS around 2012. So I didn't have the information of them for 2001 and 2003. And then I organized these variables in 4 dimensions: health, stress, psychosocial, and cognitive reserve, and constructed 4 indexes derived from the sum of the individual variables in each dimension. These are the indexes that I used. I named the first one a health risk index. The second one is the psychosocial index, a stress index, and a cognitive reserve index. I cannot stop to explain each of the variables because I would need like an hour more. But I can talk to you if you're interested about the constructing of these indexes. And then I went directly to see what these indexes were gonna show us about the sample that I selected. If you look at the descriptives, I don't know if you can see the numbers, they're very small, but you can see them. Very small, okay. So the numbers are showing the obvious from the descriptive point of view for sex, age, and education. So normal, 56% were women, 36.8% were men were women for the normal CIND trajectory. Most of them are men. And for the dementia, 62.8 were women. And then education follows the trend that we expect from higher education to lower education in the dementia group. And there are the descriptives of the health, the psychosocial, the stress, and the cognitive reserve index. But I'm going to move to the regression analysis. When I did the multinomial regression analysis, obviously age and sex adjusted, not education adjusted, because education was in the reserve index. So I didn't want to adjust for the variables that we were including. We wanted to see how the sex, the reserve index worked. And what I did was regress all these indexes on pathological cognitive trajectories. So if you look at the trajectory in normal dementia, you see what is the role of each index in the prediction. So it's the health risk index is associated with a higher probability of being in this trajectory. The psychosocial index is protecting people from being in this trajectory. Stress tends to be high, but it's not significant. And the cognitive reserve index shows the protection effect that we expected. And for normal and CIND, what we find was the health risk index showing the same high probability of being in this trajectory. The psychosocial index did not show anything. Stress showed less association with being CIND, and this is because the normal group had higher stress levels. And the cognitive reserve index showed the protection. If we look at it at the normal trajectory, so it's the same results, but concentrating on the normal trajectory, this is what we see: a health risk index that is lower, a psychosocial index higher, stress is not showing us anything, and cognitive reserve index is high. So what do I conclude about all of these things? One important aim that I was discussing with Rebecca lately is that we as researchers have to concentrate in the development and testing of the methodological approaches that will help us to predict. We have to move on to a prediction level, thinking to have all the information that we can to talk about who are the most vulnerable, who are the most resilient, and how these predictions can be tested further on through the other ways. Longitudinal analysis is the strongest research design for this aim. I know it's also the most difficult and time demanding, especially when you're working with survey data and you have to analyze all the information and be consistent, because it's not the same if you say being married is protecting people from cognitive aging. No, because if you look at the data, there's some people who are getting married and then they are getting divorced and then they are getting married again and then they are widowed. So selecting and concentrating the variables with an effect of the time is not so easy. I think MHAS and the Hispanic EPIC are gold mines. I don't know if the term is the same in English. We use it a lot in Spanish. They are gold mines because they have a lot of information open for further exploration, and we now have a lot of information which has been gathered by us and other researchers. I think that indexes have the benefit of integrating different sources of information which otherwise will be analyzed as individual indicators. That's most of the papers that we have are working with these indicators individually, but this doesn't have an ecological validity because life in the surrounding people is not one thing, like I'm married. No, I am married and I have these stressful life events and I have these other conditions, and they are all moving in this picture that I showed, or I tried to show. The better indexes are those constructed with longitudinal data. I know the selection of the variables for the indexes is controversial. I know if I ask you all of you here, how will you construct an index for stress? You will have a lot of ideas, and maybe they would be different from my ideas. But the results I've shown are an example of how to approach the analysis of different dimensions that constitute the challenge of multi-resilience in the Mexican population. Thank you.
Thank you so much, Sylvia. I want you to stay here just for a second. Jackie, would you like to join me? Just give me 1 second. We were trying to get Rebecca to come in to say a few words. I know that she sent me the message that wasn't opened to open. Sylvia, it's with great pleasure that we want to thank you for being a strong participant of this series, for being such a great scholar in the field of cognitive health, like so much dedication and try to do all these methodologies, all these tests, try to get the best measure that we can. So we really want to thank you, Jackie.
Yes, and we're so honored to have you present this opening keynote address. It's a great way for us to begin our discussion of all these critically important issues. Dr. Mejia has been so instrumental in teaching us and elevating our sort of sensitivity towards measurement issues, these predictive models, which will be our big challenge as we move forward with this. So congratulations. Thank you so much for all of you, what you do for our conference series.
Thank you.
And we would like to
Thank you, Jackie. Thank you, Flavia. Thank you, everyone here, because I've been part of this meeting for all the installments, I think, since the first installment. I came from Mexico. Now I live in Tijuana, so it's a little bit nearer. But anyway, so it's been a pleasure to be here since the beginning and receiving this recognition and being invited as a keynote speaker was great. Thank you very much.
Sylvia, you're going to be on.
Yes. We have a 2-minute break if someone wants to go get some water while we set up for the next meeting. I would like to invite the first panel, paper session 1, Cognitive Resilience and Aging, to join us here in the front. So please, Sylvia, Miguel, return, and Angela's already here, and then I think Miguel.
All right. Sorry, sir. I'm just going to. Okay, so I'll show you. I've got you can see. Just look up there. You can see.
I'm just going to mute this.
Yeah, go ahead. So you can see it's connected to Epson. There's actually 2 Epsons. It says 1 Epson and 1 Samus system. And when I click on either, neither worked before. I'm going to just ask Kayla to unmute so that we could test that out.
Yeah, but do you have sound coming out of your presentation?
Yeah, we need it to come out of the Zoom and out of a presentation.
So it's not coming out of your computer at all?
Let me just test to see. Sorry, I'll just open that up. Sorry. Also, I'm a Mac user, so anything that's a bit different is a little tricky. Just press OK to that. So let's just play this video and see if it works. I've got the sound on. No, it doesn't seem to be coming out of the computer.
Yeah. Okay. So it's,
Where would I go to settings here?
yeah.
It was working yesterday, wasn't it?
Yeah. Sound. There you go.
Oh, Epson. It's on Epson. Could I be? See, it says Epson right there.
Yeah.
Should I do something else to get the sound out of the computer here?
How long do you have? You don't mind me?
Literally like 2 minutes.
Oh, okay. Gotcha. Right.
Do you want to just switch it to speaker and see what happens? Test.
And I'm just going to go to the wall really fast. Make sure.
Oh, you know what? I know exactly. You can hear it. Oh, fun.
Okay. Is that loud enough for you?
We might. It's hard to tell with all these people, isn't it?
I mean, the thing is, what I think is going to be easier is, are you going to be controlling this?
Yes.
Because if I have it louder there, and then you can just press volume down.
Okay.
On that.
If you don't mind, turn it up, and then I'll just turn it. And then as I'm up here, I can just volume down. Okay, great.
Do you want to change the order a little bit, or it's better to keep as it is?
I think Melissa's last, and I think that works best. And then I can communicate with Melissa in the chat.
Do you thought that his presentation would make more sense going to this, or it's better to keep it?
It's up to you. If you want to change the order, just let me know.
Okay.
So I've got this order right now, yeah. And so I've got Melissa's video here to last. Would you like to do it first?
He feels that it would be better. So Eileen and Miguel are here. Miguel is here, and Eileen Graham.
I haven't seen Eileen. I don't know Eileen.
Turn the overall volume up. I turn the mic down. Just make sure turn
that off when I play it. Turn that off when I back
up.
Oh
no, we tested that. Yeah.
Oh yeah. Okay.
Right now it's muted. So
okay, perfect.
Sure
Yeah, I will.
Okay.
I no doubt I'll have some stress and call you back here again. Okay, so are you happy to go in that order?
Eileen?
Yes.
Eileen, perfect.
Okay, so you want me to sit over here for the?
Yeah.
Just give me 2 minutes, Flavia.
Yes.
Just give me 2 minutes.
So let's go in the order.
Yeah, I think that's easier for me because I've already labeled everything in order. If you don't mind. You know what happened? When, Omar music on so people could enter, and he didn't change it back to this. And I told him, I was like, no one needs music on to enter the room. I was like, it's really important. And I knew something like that was going to happen because I was like, that just confuses me because I don't know how to work that over there. That's not part of my. Okay. So we're ready to go now.
Hello everyone.
I had turned it off, sorry.
Hello everyone. May I have your attention? We are about to start panel 1. At this moment, I would like to introduce the chair of this session. You already know her very well and her work, but I would like to reintroduce you to Sylvia Mejia, who comes from El Colegio de la Frontera Norte. Sylvia, the floor is yours.
Thank you very much. So we're going to start the session on this is Eileen. We're going to start the session on cognitive resilience and aging. And I'm very pleased to present the 4 participants who are here. Each of them have been chosen specifically to talk to us about one of the things that are happening in this area of cognitive aging. And the first one is Eileen Graham. Eileen is associate professor for Northwestern University. Then we will have Miguel Arce Renteria. He's from Mexico. He's from Tijuana, but he now works at Columbia University Medical Center. He's an associate research scientist and clinical neuropsychologist. We have Bill Vega, who is known by all of us, and Bill is a distinguished professor of community health at Florida International University. And we're gonna finish with Melissa Lamar, who is a full professor from Rush Alzheimer's Disease Center. She's gonna be connected through online. And we have a great discussant, who is Anya Solden. Is that the way I have to pronounce? Okay, Anya is an associate professor, and she's in Johns Hopkins University School of Medicine. So welcome to the session, and Eileen, you're the first.
I'll let you know. 5 minutes left. Oh dear, got the beepers. Well, first of all, I'd like to thank you all for having me here today. It really is an honor to be invited to speak with you all today. Before I get started, I'd like to thank all of my close collaborators. I know acknowledgements kind of gets stuffed off to the end, but I just want to thank everyone that I work with, all of my close collaborators, in particular, Graciela Muniz-Torreira, who by total surprise is here today. I haven't seen her in like 4 years, so I'm really excited to catch up with her later, as well as my funders at NIA, without whom this work would not be possible. So the bulk of my substantive work fits into this broad theoretical model. Broadly speaking, I'm interested in the interplay between psychosocial factors in early adulthood, health behaviors and lifestyle factors in middle adulthood, and then various health outcomes in older adulthood. So today my focus is going to be on cognitive functions, specifically personality traits as predictors of various cognitive outcomes. So just in brief, the Big Five personality trait taxonomy is one commonly used tool for capturing an individual's typical patterns of thinking, feeling, and behaving. Personality traits have previously been linked to a number of health behaviors and health outcomes, sometimes with conflicting results in the literature, prevalence of single study papers. So I've sought in my career to systematically test these pathways using the coordinated analysis framework. So we do a lot of large scale conceptual replication work, doing conceptual harmonization of the various measurement tools across the studies that are designed to test the same constructs. So we use many data sets, identical models, and then the tools of meta-analysis to synthesize these results to give hopefully a more robust body of work in the end. So just to give you an overview, oh, that is really blurry, I'm sorry. So I'll just tell you what it is. So we, excuse me, my work has shown that personality traits in early and middle adulthood are related to consequential health outcomes in later life. So this particular paper was a conceptual replication of 15 studies. We found that individuals who are higher in conscientiousness are found to be consistently less likely to be smokers. They're less likely to be heavy drinkers, and they're more likely to engage in regular to vigorous physical activity. All of these things, of course, have strong potential to lead to better health in older age. Personality is also related to several health outcomes, including general cognition, which I'll get to in more detail later. The findings from this paper suggest that neuroticism is associated with poor self-reported health, particularly in midlife. Conscientiousness is associated with less general disease level, particularly in older adulthood, and being high in openness is associated with better cognitive function, particularly in younger and older adulthood. So this particular paper was a conceptual replication as well. These findings were consistent across 3 independent data sets, although what I'm showing you here is just from the health and retirement study. So then to connect this to more downstream, the ultimate health outcome, mortality, we've also linked personality to how long an individual is likely to survive. In the interest of space, I'm only showing you a forest plot from one trait. So this is just for conscientiousness. You'll see conscientiousness is kind of a theme as we go. We found that in several independent data sets, upwards of 15, I believe, that conscientiousness and openness were protective against mortality. So people who were higher on these traits tended to live longer, and that neuroticism was a risk factor, meaning that people higher in neuroticism tended to die sooner. So all told, this body of work has suggested to us that personality traits, in particular conscientiousness, openness, and neuroticism, are associated with a breadth of health factors, health behaviors, and health outcomes, including self-rated health, disease, and mortality. And these findings have been robust across many data sets using identical models. And I'd like to preface this by saying that a lot of the work that we do has been using what, I don't know if you guys are familiar with the term weird samples. They tend to be white, educated, developed countries. So some of the work that we're doing, I'll get to this at the end, is looking to diversify the samples of people that we're looking at so that our findings are more robust and generalizable to the true world population. So then what about cognitive function? So that's really why we're here today. So the following findings that I'm going to talk about are from two of my most recent papers, and then another that are some preliminary findings from an article that is hopefully soon to be under review. And these two papers here were funded by an NIA administrative supplement that we received a couple years ago to bring our work on personality and well-being trajectories in older adulthood into the ADRD research world. Which is really where my heart lies as far as research goes. So just a couple quick definitions, just so we're all on the same page before I get into our findings. We've looked at cognitive function and change. So when I refer to these things, we're talking about cognitive ability at a single time point, or on average over the course of the study. So if we're looking at multiple measurement occasions, we're looking at the intercepts. And then also we look at the rate of decline, cognitive change. So this will be referring to the calculation of slope over many measurement occasions. When we refer to risk of dementia, this is the odds of being identified as having dementia at some point in a given study. And this is in reference to the clinical syndrome only. So mostly as diagnosed by a neuropsychological evaluation within the context of data collection, not referring to any underlying pathology. We do have a couple studies that used self-reported dementia, which I realize has like major limitations to it, but we found really consistent results, whether it was dementia identified by neuropsych eval or by self-report, which we were surprised by, but that was kind of cool. So next, when I refer to cognitive resilience, this is a very specific term that we use, and it is only when discussing the relative discord between an individual's cognitive function as observed while they were alive, while they were collecting these cognitive batteries, versus their neuropathologic burden. Any study that I described that uses this term has analyzed data from studies that acquired autopsy data from their deceased participants. And interestingly, all of those data sets were collected right next door at Rush we've collaborated extensively with the Rush ADRC, with David Bennett and Brian James and all those guys using their autopsy data from the Ross and MAP and Mars study. So then lastly, compression of morbidity is a framework that we use to contextualize. It describes an overarching goal in the field that is to optimize the health span of an individual or population. So we all recognize that we can't fully prevent the accumulation of neuropathology. We've identified as many as 80% of people after they die have this accumulation to some extent, but not everybody observes clinical dementia. We can't fully stave off cognitive decline or even dementia completely. But there's hope that we can identify these psychological factors that are associated with maintaining relatively high functioning for as long as possible and compressing that state of poor function into as short a window as possible, so that the aging population can maintain a higher quality of life for as much of their older years as possible. So there's a body of literature that's already linked personality traits to various cognitive aging outcomes. There's a number of single study papers, a bunch of meta-analyses. The most robustly linked traits are lower openness, lower conscientiousness, high neuroticism have been linked to worse overall function, steeper decline, and higher risk of dementia. So of course, we wanted to replicate all this work and extend it further to questions of compression of morbidity and cognitive resilience. So when thinking about why personality might be associated with cognitive health, this figure is helpful. This is just a theoretical model. It's not based on any real data. But personality may be influencing cognition in one of two ways. First, using the theory of preserved differentiation, having certain traits is linked with higher cognitive levels overall, and this advantage is maintained throughout old age. So even though the same amount of decline is being observed roughly for everyone, so this is more of like an intercept model. Then in the model of differential preservation, this suggests that individuals with certain traits are able to differentially preserve their cognition over the course of their lives, meaning they experience less cognitive decline than others. So in other words, the left hand is predicting, personality would be predicting the intercepts, while in the second, personality would be predicting the slopes in addition. So this project here, the first paper I wanted to show you, explored the associations between personality traits and cognitive decline, both before and after a dementia diagnosis. The goal here was to see if we could find evidence for the compression of morbidity, and indeed we did. So this paper was a coordinated analysis of 4 data sets. We needed a lot of cognitive data in order to do it. And then it was also a registered report. So if you're not familiar with the registered report format, it's kind of cool. You submit all of your materials, it's like the protocol of what you're going to do, that gets peer reviewed and accepted. So then they publish your results regardless of what you actually find. So it allows null findings to more easily enter the record, helps mitigate file drawer effects. So we found that personality traits were linked with overall cognitive function. So this was evidence for preserved differentiation, but not with overall decline, not differential preservation. However, once we partitioned those slopes for pre and post-dementia diagnosis, we found evidence for associations between openness and post-dementia slope, suggesting that people with higher openness have better overall cognitive function, but steeper declines if and when they develop dementia. So we consider this potential evidence for compression of morbidity, but obviously more work needs to be done to continue unpacking what this really means. So a more recent project that I've been working on with my colleagues at UC Davis and some of our postdocs in our lab, we're using 8 independent studies to look at the associations between Big 5 traits and dementia risk. So here are preliminary findings. This is the piece that is hopefully going to be under review soon. We found evidence that's really consistent with prior work and also really cleanly showing replicating evidence that high conscientiousness, to a somewhat lesser extent high openness, are associated with lower dementia risk, while neuroticism is associated with higher dementia risk. So this is supportive of this idea of the pathoplasticity of personality, such that personality may be a protective factor against neuropathology, but only as observed via the clinical dementia diagnosis. So put differently, personality isn't necessarily related to neuropathology itself, but it is related to the clinical manifestations, which when we talk about optimizing function in older adulthood, that is almost what we care about the most. So then the last piece I want to talk about goes beyond these clinical observations of cognitive aging and then links us directly to those neuropathological indicators that often underlies cognitive dysfunction. So the correlation matrix you see here on your left is the beginning of some work that my team and I are doing to explore the complex links between personality traits, chronic inflammation, socioeconomic factors, neuropathology, and cognitive function. So the correlations I have here are from a single data set. I believe it's from the religious order study, and we'll extend this work to include other studies that have that postmortem autopsy data. But those studies, like I mentioned before, are few and far between. So doing a full-scale coordinated analysis is pretty tricky to come by. You really have to wait for a lot of people to die also, which, you know, you don't want people to die, but, you know, as a researcher who needs autopsy data, is what it is. So the evidence here that I'm presenting, this forest plot on your right is just, it's actually not a true forest plot. It's showing traits and well-being and how they're related to just one neuropath indicator, TDP-43. And we find really consistent evidence that personality is not related to neuropathology. So that is just in and of itself empirically interesting to me, because personality is so consistently linked to so many observed cognitive outcomes, but it's not related to like the accumulation of the neuropath that like drags down our cognition in older adulthood. So what does this mean? So it suggests the possibility that personality doesn't necessarily predispose us to that direct brain maintenance, but it's related to resilience via possibly this pathoplastic model. So to back up just a little bit, in spite of all the evidence for these average patterns of cognitive decline in older adulthood and all the individual differences that come along with that, that's what we're studying when we look at personality. There's also this observation in the field that there exist individuals who maintain high levels of cognitive function in spite of the accumulation of substantial neuropathology. And conversely, there are people who decline starkly during their lives, yet have relatively little neuropathic burden upon autopsy. So we use what we call the residualized approach. This is just the statistical modeling approach that we use to study cognitive resilience, where cognitive function was on the left side of the equation, regressed onto all of our neuropath indicators, of which the Rush RODC has many. And then we extracted the residual. So that residual is an indication of how much of your cognitive function is not being accounted for by neuropathology. So a higher score indicates better function than expected, given the amount of neuropathology. Oh no. And lower scores indicate worse function than expected. So cognitive resilience on the one side, vulnerability on the other. So we found that high neuroticism was associated with lower resilience, and conscientiousness was associated with higher resilience. So here's just a brief summary of the key findings that we have, but in the interest of time, I'm going to move forward. In addition to continuing to unpack the underlying mechanisms of why, in particular, these three traits are so consistently related with all of these outcomes, we also need to continue diversifying the samples we use. As I mentioned earlier, I was priming you for that. Even though most of the work I do is these large-scale replications, so we have really robust evidence, we believe it's fairly generalizable. We're limited by the composition of the studies that we have access to. So using what we have, moving forward, we'll focus on diversifying the nature of our questions and our analyses. So for example, we'll continue examining how socioeconomic status influences these various pathways. We have preliminary evidence that individuals from lower SES backgrounds have worse overall function, lower resilience to neuropath accumulation. So this suggests possible support for cumulative disadvantage theory or maybe resource substitution theory. So we're going to test those competing hypotheses, continue on unpacking how these pathways unfold over the lifespan in the hopes of identifying earlier in life who's at risk for poor cognitive health than in later adulthood. So thank you very much for listening. Hope I didn't go too far.
I feel bad. I'm a bad guy. Silly me closed that folder before when I needed. Let's do this. Oh, I won't do the PDF actually. I'll do the PowerPoint since we already have that open. Sorry, forgive me. I'm clicking here, trying to do things too quickly. There it is. Oh. I'm going to just change it to just able to just click forward like before.
All right, hello everybody, buenos días. My name is Miguel Renteria. I'm an assistant professor in neuropsychology at Columbia University Medical Center. I want to say this is my first time here at this conference, and I want to say thank you so much for inviting me. It's an honor to be here. So it's an honor to meet a lot of you. It's a great room with awesome scientists, a lot of them Latino, a lot of you all Latinos, which is very inspiring. So thank you very much for the invitation. I'm excited to share some of my work. And so I'll be talking about bilingualism specifically. So right, deconstructing bilingualism, a little bit about AD biomarkers and brain reserve. Some of the disclosures that I always like to begin with is that I do want to say that I am bilingual, right? Soy bilingual, como dijo Sylvia, I'm from Tijuana, Mexico. So obviously the talk is about how bilingualism may be protected. So obviously I would love that to be true. But I will remain objective and I let the data try to speak for itself. I'd like to disclose that. Obviously, some of my funding sources, I'm funded through the NIA with the K99R00 and through the Alzheimer Association. I forgot to mention, I'm also funded through the Columbia RICMAR as well. And I do like to plug as well. So I'm also the co-chair for the Bilingualism, Literacy, and Language Special Interest Group of the Alzheimer's Association, the iStart group. We've been meeting since October 2020. We usually take summers off when we meet once a month. We're going to meet once every 2 months now. And if you're interested in discussing bilingualism, language literacy with a great group of multidisciplinary scientists from all over the world, you just have to be a member of iStart. But I'd be happy to chat with you more about if you'd like to join these meetings. So, right, to begin with is that there's a lot of studies, right, that suggest that bilinguals may be able to retain similar levels of cognitive functioning in the face of age and or AD-related neurodegeneration compared to monolinguals. Meaning that several studies have found that bilinguals, if they will develop dementia, they will develop it much later in life compared to monolingual groups. We also find evidence for what we call the bilingual cognitive advantage, where bilinguals outperform monolinguals across different cognitive domains, largely executive functioning, language, attention, and some episodic memory as well. So there's several studies to find this kind of support. However, there's a bunch of other studies that do not, right? That don't really find any benefit on bilingualism in reducing the risk of cognitive impairment or reducing the risk of developing Alzheimer's disease dementia as well. There are a lot of methodological design differences between these studies. So some of the ones that find a benefit are largely retrospective and clinic-based. Those that do not find a benefit are prospective and largely community-based. I like to focus on other methodological issues that I'll be working through my work. So I'm going to try to walk us through a conceptual framework that I like to use in my approach of how do we understand, how do we truly evaluate whether bilingualism confers or not a benefit, a cognitive reserve. So there's a lot of methodological factors that can complicate that work. And so first, I'll try to walk us through this, right? So the idea, right, was we have bilingualism, right? You have aging, right? And things happen to the brain, and then it leads to the outcome that we're interested in studying, right? Dementia, cognitive decline, cognitive impairment, right? And so that's a whole lifetime. And bilingualism happens somewhere in the life. And so to evaluate whether bilingualism confers reserve, you really want to evaluate one of these two pathways. The first one on the right is evaluating more of a cognitive reserve, whether the bilingualism modifies the association of brain and brain health on your outcome of interest cognition, meaning that it's weakening. That as we saw from the previous talk about if we have greater pathology on the brain, you would want to see that you're able to maintain cognitive functioning. So some studies would evaluate whether bilingualism modifies that association. On the brain reserve side, you could study whether bilingualism modifies the association of aging on brain health, because as we get older, we get cortical thinning, and so does bilingualism protect that? So we can evaluate that. But in addition to that, right, bilingualism doesn't happen in a vacuum, right? So there's a lot of childhood contextual factors, adult contextual factors, migration history that are confounded with the ability or the opportunity for someone to become bilingual, right? Because people don't just randomly become bilingual. There's a lot of life force factors that we need to keep in account, especially because some of these same contextual factors are also associated with our outcome of interest, right? Such as brain health and late life cognitive health. And so the last thing I like to also mention is also what is bilingualism? What about bilingualism can potentially provide a benefit? Most studies really, either there's no consistent way to define bilingualism, and they really just treat bilinguals as a monolithic group. So just comparing bilingual against monolinguals. And if several of you here are bilinguals, you'll know that it's more complicated than that, right? It's important to understand, well, how old were you when you acquired the second language? How proficient are you in the language across different modalities, writing, speaking, understanding, reading, and how much are you using the language, right? Because if we're thinking of it, for instance, like with the literature on exercise, right? That, exercise can be beneficial for health. It's not whether just you did it or not, right? It's, well, how much is it? What type of exercise is it and for how long? And so we really need to start to deconstruct bilingualism to look at these different aspects and how they may relate to the outcomes of interest. So for my talk today, I'll be providing some evidence evaluating whether of more of a brain reserve side, whether bilingualism modifies cross-sectionally the association of age on brain status, looking at cortical signature, cortical thickness, while trying to account for several of these contextual factors and deconstructing bilingualism into these three different components. So my aims and hypotheses, I hypothesize the bilinguals will have better cognitive functioning compared to monolinguals, but then within bilinguals, better cognitive functioning will associated with active bilingualism, here defined as using two languages every day. This is going to be through self-report again in more detail, compared to bilinguals who only use their second language every once in a while. It'll be associated with higher L2 proficiency and with an earlier age of acquisition. And then lastly, whether bilingualism buffers the effect of age on cortical thickness. Specifically, I'll be looking at the 80 cortical signature regions. These are 9 cortical regions that are associated with greater thinning over time, are associated with an increased risk of developing dementia. So I'll be focusing on a composite of these regions. For this, I'm using the study from, participants come from the Offspring study of racial and ethnic disparities in Alzheimer's disease. It's a community-based study of dementia and of the social determinants and genetic risk of dementia in the Washington Heights, Inwood, Columbia area of New York City. We'll be using participants who self-identify as Latino or Latinx, who are, for the study, they're 30 or above. To try to account for the differences between the lived experiences of being an immigrant or not an immigrant, how you learn the language, we'll be focusing only among those who were born outside of the United States, who completed a language history questionnaire for where we're able to define whether they're bilingual, whether they learned another language or not. And then from there, whether they use both languages daily to define active bilingualism, getting an average self-reported proficiency across speaking, reading, writing, and understanding, and then also self-reported the age that they start to learn their second language. In this case, given that all the participants are Latino, they're all immigrant, their second language is English. All of them, their first language will be Spanish. All the participants completed a comprehensive cognitive assessment where we evaluated the domains of episodic memory, attention and working memory, executive functioning, processing speed and language abilities, using several different measures from like the NAC and as well as the toolbox. And lastly, a subsample participants completed a neuroimaging visit from where cortical thickness is derived from T1 scans using Free Surfer. And as I said, an 80 signature average of the 9 cortical regions. So here, working with a sample of 521 participants, here grouped between bilingual and monolingual. Here just describing the differences between the two groups. They largely differed in terms of age. The bilingual group tended to be a little bit younger than the monolingual group. They were both about mostly women in both groups. In terms of education, there was a slight difference where bilinguals had a little higher education compared to the monolingual group. Here we're using parent years of education as a proxy for childhood socioeconomic status. And there's also differences, but it's about the same. The bilinguals, their parents had a little bit of a higher years of education compared to the monolingual group. Given the area that we're working with, I am Mexican, but the group that we're working there are primarily Dominican. It's a Caribbean enclave there. And as you see, the majority are Dominican, but from both groups. Both participants can be tested in Spanish or English. As you would imagine, the monolingual group here, all of them were tested in Spanish, and within the bilingual immigrant Latino group, the majority were tested in Spanish, but some participants chose to be tested in English. And now then within the bilingual group, I think some characteristics to mention is, as I said, so for the bilinguals, most of them, their first language was Spanish. Those that didn't say that was their first language, it's because they said both English and Spanish was their first language. They were primarily Spanish dominant, meaning that that was the language they would prefer to use more regularly. In terms of how much they're using in a daily basis, about 60, a little more than half said that they use both English and Spanish. And their English proficiency was rated as a 5. It's a 7-point scale. 5 means good. And a pretty late age of acquisition, which is interesting. So they all on average said that they learned their second language when they were 17. In the bilingualism literature, outside of like cognitive aging, early is usually before 7 years of age. So this is pretty late. Okay, so now for some of the results, what I'm showing here is the estimates and the confidence intervals of the differences between bilingual and monolingual, accounting for the covariates below. It's just for differences between these big two groups. Here you'll see that bilinguals are performing better than monolinguals on measures of simple auditory attention, semantic fluency, letter fluency, visual working memory, and set shifting, so several domains. But now when we then look within the bilingual group to try to understand what aspects of bilinguals may be driving that, you'll see here we have active bilingualism on the left. Using 2 languages daily was only associated with better performance on processing speed. Greater L2 proficiency was associated with better working memory, semantic fluency, letter fluency, language abilities. And then a later age of acquisition was associated with worse semantic fluency and worse letter fluency. So finding some evidence that these different aspects of bilingualism may be associated with different cognitive abilities. And just for the last a bit of work, mentioning the cortical thickness, this is a cross-sectional association, which here on the Y, we have the composite for cortical thickness. And on the X-axis, we have age. We have bilinguals in the blue group and blue line and monolingual in the green. We had a significant interaction between bilingual status and age and cortical thickness. Largely a simple slope discomposition indicates it was driven by the right side of the figure, indicating here that monolinguals at later ages had lower cortical thickness compared to the bilingual group. So this would be suggestive of either a brain reserve or brain maintenance. But again, this is not the most convincing results. It's also cross-sectional. We need to look at this over time. But then when we look within the bilingual group, again, seeing if these aspects are related to any of these, and it's not. So neither being active or proficient, more proficient, or earlier age of acquisition, we're associated with different, we're not associated with different relationships between age and cortical thickness. And so just to conclude, so bilingualism was associated with better cognitive functioning across several domains, largely more in the language and executive functioning aspects. Active bilingualism, proficiency, and earlier age of acquisition were associated with better cognition, but we do see it, we get more bang for our buck with proficiency. It seems to be the case. And that bilingualism may protect against age-related structural declines in 80 cortical signature regions. However, we still really need to now understand the joint relationship of all these different aspects of bilingualism to the cognitive outcomes, both cross-sectionally and over time. We need to include as well objective assessments of bilingualism, given that all of this is self-report. And so we are also right now collecting objective assessment of proficiency. And as well, we need to generalize this work to other bilingual populations. So for instance, I'm excited, I'm working with the MPAS team to collect some of this data, hopefully in Mexico as well, to start to look at this in different populations, both within the US and outside. And right now, I was just looking at cortical thickness, but we need to look at also more traditional biomarkers of Alzheimer's disease, such as, more looking at the neuropathology like amyloid and tau. So I'd like to acknowledge all my colleagues and collaborators, and obviously the staff and the participants. And that's a photo of everybody in the lab, and my Twitter, if you have questions, want to message there or anything. Cool, muchas gracias.
Sorry, don't just give me 1 second. Just move on, you just need to press that to go forward and that one to go back. So right to go forward and left to go back. Sorry.
So what are your stop points on your time thing?
5 minutes left, 1 minute left.
Okay.
So 15 minutes, sorry. I'll try not to terrify you. So I'll just move that out of the way.
Well, it's a pleasure to be here once again. And I think the last time I gave a talk for our group here was about 11 years ago in Austin. So it's been a while. So, but it's a pleasure to be back again. I just wanted to begin by saying that I think that one of the most critical things that has happened in the whole world of cognition, of course, is the enormous exuberance that we have had in funding research associated with anything having to do with aging, but specifically with the brain. And there's been tremendous opportunities, as you all know, and I think this is a golden opportunity time. And I want to speak to that golden opportunity a little bit in the way I go about this, because I'm going to focus on the question of what has happened from the standpoint of understanding cognition as a phenomenon, both as a phenomenon that affects the normal process of aging as we get older, what really goes on, and is there really a normal aging, or is there really something that we can't call it quite that, because we know, frankly, it's hard to characterize what it is, because we have very different approaches to it. We have different measurement approaches in terms of what we've actually considered to be a serious marker of deterioration, for example, and what is disease. So it's a question of what is normal and what isn't normal from the standpoint of disease versus non-disease from the standpoint of Alzheimer's. Now, I'll get into that now and have to push through it. This used to be a 1-hour presentation, so it's going to be a little shorter now. So, but I've cut it back. Okay. So the goals, and I just want to say, first off, I have been an advocate for more money for research in the Congress of the United States, representing us against Alzheimer's, and also I've done work for Alzheimer's Association and technical groups. So I've been there, and believe it or not, they want to fund it. Both Republicans and Democrats want to fund more and more, and we're up to $3.2 billion for aging research now. So I think that's wonderful. So my point here is to primarily look at the question of, how is cognition, let me go back one here, of understanding the Alzheimer's disease and why developing a cure to reach the disadvantage is going to be an arduous journey. And distinguishing health and cognitive aging and unhealthy cognitive dysfunction leading to dementia, and understanding why a life course approach is important, and understanding just a little tiny piece of the management problem, especially without a cure. So as we move forward in this, it's really a history lesson of the last 7 years and the excitement that's taken place in the history of science in the world of cognitive understanding, and what that opportunity presents for you. Now, what is cognition? Cognition refers to mental functions involved in attention, thinking, understanding, learning, remembering, solving problems, making decisions. Obviously, it's a gradual ongoing process. It's highly variable. And you can see that as people get older, they have very different phases that they go through and different capabilities that they retain and that they lose. So I understand the notion of cognitive health, but it's hard to understand normal, because from the standpoint of aging, we're all born with different cognition. We all follow through life with different cognition. We have a whole series of experiences in the environment and social experiences that changes all of that. So it's very difficult, really, from the standpoint, not just research, but you can imagine what clinicians are up against when they're trying to understand what they're looking at, and say, oh, this person has a problem or not a problem, or what level of severity is the problem, unless it's extremely marked. So that's where we've been in the field coming up to this point. Now, we know that any cognition measures we come up with to determine whether people are so-called normal or abnormal really have to do with a lot with the same problems that we face with testing an IQ test and with testing with SATs and anything else, because it is going to be socially based on what we pick out to decide that these brains are not doing well, especially in the absence of clear-cut biomarkers where we know something's going on in the brain that's causing a disease. So we really have to put that unity together, and we haven't had it in the past, and so we're still searching around for the best way to assess and to do it efficiently and to do it in research, et cetera. As you can see, cognition performance, it combines knowledge acquisition, performance level, and skills, variously defined literacy, verbal processing, working memory, vocabulary, verbal fluency, world knowledge, word recall, text recall, and actually problem solving, which is a big piece of it, being able to solve common problems of everyday living. So let me just say that to me, this is the core of what I really want to get across to you, if I said nothing else to you today. What has been going on in this arena in the last 7 years of the history of Alzheimer's disease research. Because up until about 7 years ago, we were heavily influenced by the entire genetic influence, I think, of early onset Alzheimer's disease, which affects people really earlier in life, like in their 40s and 50s, usually dead by the time they're 60, because it is a fatal disease. Now, that's a very different thing. It affects about 7 to 8% of the total Alzheimer's group, and the overall group actually has a quite different picture, but we were very influenced by that work because it's autosomal in the sense that if you have the gene, you're going to have the disease and you're going to die from it. Okay, that's early onset Alzheimer's. That carried over to a great extent. And up to about 7 years ago, people were talking about 70% or so of the liability for the disease was really genetic. Now we're down to 7 to 10%. That's quite a change in science, isn't it? I mean, we jumped from 70 down by a factor that's phenomenal. And now we've opened up the field for you, because the field now is saying across the life course up to and including prenatal time, we're talking about factors that are influencing the brain and developing a brain that is robust against depression and against dementia, which I say depression because there is interrelationships between depression and dementia as well. So the bottom line is now we're looking at something that for a long time, we were stuck with a model that basically said it was dominated by one thing. Now we're saying it's dominated perhaps to a certain extent still in the focus of looking at APOE4, which is the primary gene we look at, which itself is related to a whole region of other genes. And we find that even if you have APOE4, you don't necessarily get Alzheimer's disease, and many people get Alzheimer's disease without APOE4. So it's that kind of a variability, and most of the effect is interactive with all of these other numerous risk factors, including the social, environmental, biologic, genetic, physiological factors that we've been talking about here in the 2 days that we're here. So now we're into a multi-path world coming forward over the entire life course, and which gives us an opportunity to start thinking of, is there a way further up the pathway to start intervening? And what would we do to lower that risk? Now, when we look at the whole question of where we have been stuck for 2 decades trying to find a cure, and that is a cure from the standpoint of something that will stop the disease. We've been stuck in this ATN, which is basically the amyloid tau neurodegenerative framework, right? And this has produced no cure. Okay, we've had a lot of partials that didn't work out, and I don't want to get into the time it takes. I can certainly explain it to you on a personal basis what has happened with that, but we don't have anything right now that looks like a cure or a medication in the field, which means that clinicians have to go back and rely upon psychiatric drugs that were intended for schizophrenia and bipolar and depression, et cetera, and it frankly does not work. So we are in a world in which we now have to back up and say, are there earlier stages, both outside the body and inside the body, and the way disease gets inside the body, where we can now begin to understand mechanisms. It's not just genetic, but mechanisms that in fact link social experience, environmental exposures to toxins and things like this. So and my last point there, to me, the analogy is much more like a river. Each one of us represents our own individual river of experience from the time we were born, going forward across our lifetime, the exposures that we've had. As I indicate here, the risk factors that we experience include things like cognitive reserve, exposure to toxins, diabetes, heart disease, serious mental illnesses. People with serious mental illness have 3 to 4 times the risk of moving on to Alzheimer's disease. Traumatic brain injuries, the dementias, about 30% of all Alzheimer's cases are made up of previous dementias. Vascular dementia especially, but there's a full range. Lewy body, Parkinson's disease, et cetera. So you can see, and then of course, things that happen in later life, emergencies of various kinds of medical emergencies, surgeries, et cetera, traumas, physical traumas, not just psychological traumas, which are also very important. So you can see what I'm talking about here, that this is an opportunity for us to think in an open frame. Now, what kind of interventions will work, but what can be sustained? Who's going to pick it up? And I think that's the critical thing. I mean, we all talk about, well, cognitive reserve, it's not, obviously we have a problem there. We can perhaps do interventions later in life. Who's going to do those interventions? Who's going to sustain those interventions? We need to start talking about interventions in this group. There's no way to get better knowledge about the disease and stopping the precursors than doing interventions. And I know it's a lot of work. I've done them. I've done interventions a lot of my career, and it's hard to do, but it's very, very important. So Alzheimer's disease is fatal. It affects 40 to 50% of 80 cases, which could have been prevented. Actually, in Mexico, they say it's really higher because they have more risk factors, probably 50, I think 56% is what I hear in Mexico when I've gone there, because there's so much obesity and of course, cognitive reserve and a lot of other poverty-related issues and stress issues. And as I've just mentioned, underlying biology is not well understood. Now, I wanted to show you this because this is very interesting. It gives you a different way of understanding what happens to cognition over time. This is a panel study taken from the Health and Retirement Survey from 60 to 90 years of age. And what this shows you is that orange line that goes through there is the trend line for the entire sample, okay? The upper one is for those who are above that trend line, so you can see the decay in cognition over time is gentle. It really doesn't go down seriously until about 80 years of age. And then you see the bottom trend line, which goes down precipitously, and it starts at quite a different point as well. So already by 60, you can see a vast difference in groups, and you can see that there's a serious decay in cognitive performance after the age of 80, going all the way on. And that's just about what we see with every measure that we use. 80 is a critical point for every organ in the body. I'm about to be 80, so I know about that. So anyway, here you can see a marker, which is memory, which of course is much more to Alzheimer's disease and dementia than just than memory. But this is memory and serious impairment with memory. And you can see at the bottom here, this is color coded. It's not pink for women, but it's orange. So we have blue and orange. You can see the very low levels at the bottom in bold are the levels of serious memory impairment 65 to 69. And you can see how it starts jumping up. And by 85 and over, it's a third. It's a third of just about a third of both groups have serious memory impairment by that point. Now, what this is all about really is the fact that memory, as I indicated, is one serious marker, but in Alzheimer's disease, you actually had a higher rate for women than men because most of the men have already died. The attrition to mortality has taken them out of it. So you actually get a shift here where you get about 60% of the cases would be among women over 80 years of age. Okay, so that's what happens there. And this is basically what you've probably seen this before. I hope you've seen this before. This gives you a picture of what is happening. And this is, of course, a relative issue because what we're talking about is different populations with different risk factors are obviously going to have normatively earlier or later starts in the neurodegenerative process. The neurodegenerative process is approximately a 15 to 20 year phenomenon for most groups. Some people can go on and on. I mean, I see cases where in the Mexican population where people can go on with dementia for a long, long time, but it's very rare. Most of it fits into this picture. So this is normative. So what you're really seeing is you really have the earliest stages of the disease beginning. This is the loss of neurons in the brain with neurodegenerative disease beginning in about the age of 60, okay? And normally what we see is a preclinical stage of 12 to 15 years. Then we see MCI, and then with MCI being diagnosed, which of course is not diagnosed for everybody, but I'm saying if it is diagnosed, what you normally see is within 3 to 5 years, you're going to see Alzheimer's or the dementia diagnosed. And of course, people usually live depending on how early they were diagnosed. In California, with Latinos, we find that after diagnosis, they only live about 3 years because it's late diagnosis. So it really depends on, and other studies show 5 years, 7 years, depending on their good fortune or bad fortune. I don't know, because it depends upon finding out, and you're not necessarily able to do anything about it. So I think that really gives you, I think, the clinical picture. And you can see the problem here that we have and the great challenge, because we are going to be struggling to come up with a medication to work with this, but how will it work if the neurons have already been lost? And really the difference between what we would call dementia in the Alzheimer's context is that between that and non-dementia and non-Alzheimer's disease is the loss of neurons in the brain. That's a physiological difference in the brain of these concentrations, the loss of neurons until you hit a level of dysfunction. It's really serious. And for most people, literally 2/3 of the, well, probably about, let's say 60% of the population, they will not experience that serious decline to that point. But we're talking an enormous number of people who will. And this is going to be an increasing problem, obviously, with aging in the population. And I just put this up because you got to realize that for our population, they're the last ones that are going to get any cure. They're the last ones that are going to get into care. And these are the reasons why. Disease understanding, this is how far we are away from it. Disease understanding, preclinical development, clinical trials and biomarkers have to be developed, which we do not have as yet. We have a few, In Australia, they give older people, they take samples of their cerebral spinal fluid, and they can find it that way because they can find the amyloid in there that way, and they can actually do very solid prediction. We can't do that here because people are so afraid of doing that, right? Spinal taps, it's kind of like that was a movie. Then you have the need for regulatory and access issues. The FDA had that one drug from Biogen, and they said, do another study. So that's another 5 years down the road. So at least 5 years. The big data and precision medicine, because there's variety across all these populations. You can look at the Indian population in Mexico. You look at APOE4, it's distributed completely differently into different groups. And its value, and we don't even know what its predictive value is for the disease. I mean, these are issues that we have to decide with higher technology. And the last point is, the whole question of market readiness. Who's going to deliver the therapies? Primary care physicians, or are you going to look for a neurologist? So you can see those are all issues that point to the fact that we need to do something to prevent this as a public health issue. And all the things you're going to see presented at this conference, potentially those are areas for intervention. And if nobody does the interventions, we're going to have those outcomes. I'll stop there.
Yep, so the last presenter we have is Melissa, and I have her video, so I'll just bring this up so that we can, she's there, but she's ready for questions, but we just decided to be safe and have the video.
Hello, my name is Melissa Lamar, and I'm from the Rush Alzheimer's Disease Center. I want to thank the organizers for the invitation to speak at this conference. It's such an honor, and one that I'm remiss that I cannot experience in person. Today, I'll be speaking with you about acculturation in context, cognitive and cardiovascular health in older Latinos. Before I get started, however, I want to acknowledge all of the people that I work with at the RADC listed here, particularly those highlighted in green who contributed to this work. I also want to acknowledge and thank our funding source, the National Institute on Aging. And last but certainly not least, I want to thank the participants of our cohort studies as well as the staff, without whom none of this work would be possible. I don't know that I need to tell this audience, however, to put us on the same page, just want to review some statistics. Latinos in the US are about 1.5 times as likely to develop Alzheimer's disease as non-Latino whites. This health disparity may arise from multiple influences, including the disproportionate cardiovascular disease risk factor burden known to exist in Latinos in this country. However, this and other traditional risk factors for cognitive decline and Alzheimer's dementia do not fully account for the health disparity that we see in Latinos in the US. Therefore, many of us, including many of you in this room, have been investigating culturally relevant factors that may confer either risk or, more importantly to this conference, resilience to health disparities in Alzheimer's disease and related dementias. One culturally relevant factor that has long been investigated is acculturation, traditionally defined as a process of adapting to a new environment and potentially adopting its values and practices. It's often focused on individual levels of language-based or social-based acculturation. However, increasingly, the idea that the acculturation is a one-way street in which the individual has to adapt or adopt new things doesn't really take into account that it is a more dynamic exchange, actually, between new and host members of a society. And it emerges from and is reinforced, for good or for bad, by broader contextual factors. And we've been calling this kind of more nuanced concept, acculturation in context. And the context is very much in line with the NIA Health Disparity Research Framework that talks about not only sociocultural factors, but environmental factors and other behavioral and biological factors that may impact any one individual on the course of their aging. So for this study, our objectives were to investigate culturally and contextually relevant contributors to level up and change in cognition, as well as cardiovascular health. and to further test whether cardiovascular health modifies the associations between acculturation and context and cognition. At the time we started this work, we had 10 different measures of acculturation and context, as you see here. And we looked at them in roughly 200 individuals from our Rush Alzheimer's Disease Center cohort studies. On average, folks were about 70 years of age, primarily female, and had an average of about 10 years of education. Over on the right side of the screen, you can see those acculturation and context metrics, and you get a sense of our participants. Basically, the vast majority of them preferred Spanish as their language for their annual evaluations. And 80 to 90% of them were reporting not only their nativity, but their parents' nativity outside of the 50 United States. We also looked at social and language-based measures of acculturation, traditional Latino-centric aspects of familialism. We asked about everyday discrimination as well as social network size and loneliness in these participants. We subjected all 10 of these items to a principal component analysis, and that PCA actually returned 3 orthogonal factors in an unrotated solution. The first of those factors was those social and language-based acculturation-related measures. The second factor, the loadings, were more contextually related, so socio-environmental things like experience of discrimination, social network size, and feelings of loneliness. And the final factor was the single loading of that Latino-centric ethos of familialism. We created composite scores for these 3 factors and looked at them in relation to not only global cognition, but 5 cognitive domains that were encompassed in our global cognitive measure: episodic and semantic memory, as well as working memory, perceptual speed, and visual spatial ability. For our 200 individuals, we had on average about 4 years of annual follow-up, but the range was between 2 and 12 years. So let me go through some of those results of our regression, of our mixed regression models, which adjusted for age, sex, education, time and study, depressive symptomatology, as well as cardiovascular disease risk factor burden, and interactions of each of those variables with time. So what we found was that overall acculturation and context metrics were associated with level, but not change in cognition. So if we look at the top 2 panels on this screen, what this is showing is that levels of acculturation, that acculturation-related composite, those that were in the 10th percentile, or excuse me, those were in the highest percentile, so that 90th percentile shown in this frustratingly light green dotted line, those in the highest levels of acculturation-related composite scores had the highest levels of semantic memory at baseline, as well as the highest levels of perceptual speed at baseline. Now, when we turn our focus to those socio-cultural contextual factors of higher levels of discrimination, higher levels of reported isolation and loneliness, as well as lower social network size, what we found were those folks in the highest percentile of that of those categories showed the lowest levels of episodic memory, working memory, as well as faster changes over time in visual spatial ability. Although our results for visual spatial ability did not reach our threshold for significance. So again, acculturation and context associated with level more so than change in cognition. When we turn our attention to cardiovascular health, we defined cardiovascular health in roughly the same sample. We lost a few folks who didn't have particular aspects of the American Heart Association's Life Simple 7 score. We had to modify that score because we didn't have dietary patterns in our entire analytics sample. So we had basically a Life Simple 6, a maximum score of 12 and a maximum score of 6 for the lifestyle behaviors as well as the biological factors. Here we had an average of about 3 years of annual follow-up that ranged between 2 and 8 years for any given participant. Now for these metrics, what we saw was that acculturation in context was associated with change more so than level of cardiovascular health. Specifically, we saw that higher levels of that sociocultural contextual related composite was associated with slower rates of decline in cardiovascular health. We also saw that higher levels of familialism, again, were associated with slower rates of decline in cardiovascular health. Now, interestingly, when we looked at the effect modification of cardiovascular health on our associations between acculturation and context and cognition, we saw that it in fact did modify a lot of those associations and also unmask others. So here's just an example. So for individuals in the highest levels of cardiovascular health, shown in the red and black lines, those red and black lines represent the lowest levels of acculturation-related composite scores. So individuals on the lower side of acculturation, but the higher side of cardiovascular health, were showing slower changes in working memory, suggesting that perhaps regardless of acculturation, or particularly for those with lower levels of acculturation, increasing cardiovascular health may also serve to increase cognitive reserve over time. So to summarize, acculturation and contextually related factors differentiated from each other. They differentially contributed to level more so than change in cognition, but change more so than level in cardiovascular health. And when you looked at all of these three variables together, you could see some some suggestions that perhaps cardiovascular health could serve to promote cognitive reserve in those with lower levels of acculturation. So clinically, this means we need to be asking our patients not just about which languages they prefer or kind of their language-based levels of acculturation. We should also be talking about the context and the lived experiences of our patients to understand how these things might affect their cognitive trajectories over time. Empirically, I would argue that acculturation and context factors, as well as many other factors about the lived experience, should be incorporated into our research with older Latinos. If you want more information about the two kind of findings that I showed you during this talk, one paper was just recently published in the Journal of Gerontology, and actually it just received, I'm very proud to say, the Diversity Professional Interest Group's 2022 Most Outstanding Paper Award at the recent Alzheimer's Association meeting in San Diego. Our second study looking at cardiovascular health that was originally spearheaded by the wonderful and talented Dr. Mayra Estrella is currently under review, so hopefully that will be out shortly. Next steps for our work, in addition to cognition, we've been collecting data on brain health through neuroimaging to get at those other aspects of successful cognitive and brain aging. We're also looking not just at individuals' lived experience, but also looking at individuals' neighborhoods to understand how where people live might affect how they live. We're doing this not only at the RADC in our cohorts, but I'm very happy to say that we've partnered with Dr. Martha DeViglis and the Hispanic Community Health Study of Latinos, as well as the ancillary cognitive and neuroimaging studies that are led by Dr. Hector Gonzalez and Dr. Charlie DeCarli. And we're going to be doing much the same, looking at acculturation and context across brain imaging, cognition, and multiple sites in the US for kind of a larger generalizable finding of our work. I want to thank you so much. Muchas gracias. It's been a pleasure telling you about our work. If anyone has questions or comments, you can reach me on email or by Twitter. Certainly, if you're interested in collaborating, please reach out. And also, if you're interested in looking at this data for questions you may have, all of our data is freely available at our Research Resource Sharing Hub. So thank you so much. And thank you again for allowing me to speak with you today. It's been a real pleasure.
Hi, I'm Anya Solden. So I want to thank all the presenters for their really excellent presentations, really enjoyed them. And I think what this session here really has shown and brought together is really shown the complexity of the issues that we're dealing with when it comes to the cognitive and brain aging and resilience to various age-related disorders. We've seen that there's so many, how should I put this? I think the challenge is really to for research going forward to understand the various risk and protective factors and how they impact cognition over time. So, and I think what you can see too from these various presentations is that the data that has to be collected to understand the complexity of these issues is going to be very challenging, right? You need good cognitive data that covers different aspects of cognition. We've seen, for example, from the bilingual presentation by Miguel, that effects differ depending on what cognitive domain you look at. We need to collect brain measures, so measures of pathology, but also of non-pathological measures of the brain, like structural function measures. There are more and more emerging of those, things like blood flow in the brain, functional connectivity, structural connectivity. All of these things play a role in cognition, cognitive aging over time. The data we collect will have to be ideally longitudinal. I think that's become clear. And you have to collect all these different, risk protective factors that play a role in individuals' lives, presumably starting when we're even in people's womb, right? So it's a really challenging task. I think, we've making good progress. So thank you again. Oh, and genetics as well, right? Can't forget genetics and all of that. All of these things interact. So with that, maybe I'll open it up to questions from the audience to our speakers. Yes.
One of the hardest things for immigrant families to do is conserve bilingualism in their young children. When we know that there are only not only positive benefits, but benefits to the societies we join here in the United States and then historical families as well. How do we move the socio-political context to recognize that bilingualism benefits everybody?
Great question.
Could everybody hear that?
Oh, should I? Use the microphone.
Yeah, sorry, this one seems to be a little funny. Let's use this one.
Thank you. That's a great question, and you bring up another good point, right? Because I still, in terms of the benefit of bilingualism to cognition, there is also as well, we need to really understand is the benefits that we're potentially seeing on cognition through these other social benefits, right? As well as you're mentioning, increasing different types of social networks, higher or different occupational opportunities, and so forth, and also different types of leisure activities, and et cetera. I think the more, hopefully, I'm writing that up, this should be published soon, hopefully things like that, communicating. I think having outreach efforts with the community to hopefully dispel some of those myths, because I think those started from myths from years ago, that if you learn two languages at an early age, that will stunt like your development intellectually, which ended up being completely false. I would at least say, at least in New York City, from my colleagues, at least that I know that have kids, have mentioned how in some of their schools are doing bilingual learning environments and different things. So hopefully it is moving more towards a positive way, but I would think it's more outreach with the community about these issues to hopefully dispel myths. Because exactly, like, even if it's not just a cognitive potential benefit, but just, it won't do any harm. It's socially hopefully more beneficial.
I think you were going to just one response, Chris? Is that Bill wanted to add something? Oh, do you have something to add? Sorry. Sure.
Well, I would just say that I believe that a fundamental issue is obviously we have to do a better job of supporting the early education of our children in the bilingual context, but they have to have support from programs that don't exist right now, so the situation is not going to change. We've had educational flop for decades after decade after decade. If we don't do something to address that, I just wrote a paper on that. If anyone's interested, I'll send it to you, on the impact that education has on health overall, including dementia. And I think that we just have to recognize the historical context of all of this. If you want to talk about social economic issues, the historical context of this, and realize we have to move that agenda.
Yes, sir.
We'll get a line.
Oh, okay, sorry. I can't see it.
Sure.
Is somebody else going to go? Oh, there's a lineup.
Okay. Thank you for your really wonderful presentations and keeping with the theme of context that seems to really emerge from this conversation. In terms of bilingualism, has there been any kind of thought about the experience of learning the second language in a context that can be hostile to learning a second language when you're not in an educational context? And especially for people who may be coming from lower levels of education to begin with, where their own native first language is not exactly high level. And so you get this kind of complexity. It's one thing to learn a second language when you're a college student studying abroad and all the pain that's involved in that, versus being someone with low levels of education in a context that really doesn't understand, really just, you know, the adage, what do you call somebody who only speaks 3 languages, trilingual? What do you call somebody who speaks 2 languages, bilingual? What do you call somebody who speaks 1 language? Thank you. So I mean, it's a hostile context for a particular group of people. You know, it's if you are a well-educated immigrant and you're a professor and you're struggling with English, it's a very different experience. So to go back to those contextual factors, if you see it in acculturation, it's got to come through with language, and those have to have an impact on cognition. So anyways, I'm going to be quiet and let you guys speak.
I'll hand it over, sorry. We're doing a bit of a rock.
Thank you. That's a wonderful question. Yes, and that opens a whole other can of worms, exactly, of like how it is important, like at least through the bilingualism, language learning literature, environment is really important. Exactly, the context in which you're learning, the purpose for which you're learning a language is incredibly important. So I do agree, like it would be really important, for instance, to collaborate with Dr. Lamar about how that plays a role with acculturation. And so I do know, I have not looked at that right now myself personally. I am collecting data as well about bilingual participants' attitudes to learning their second language and using their second language because of that same reason, right? Because, for instance, working with a lot of the immigrant populations that we have, you know, there is a stigma for either not knowing your second language as well as, you know, people think you should, and how does then that impact your use of the language, and as another additional source of stress that might just, any potential benefits of bilingualism may just be erased because you're dealing with these additional environmental stressors. And so the data is being collected, and I'd love to, you know, collaborate with people to think about how to work with that data. I will have, I think, plug, I will be looking for postdocs. And so if anybody knows people, feel free to talk with me about it.
Yeah, one quick comment, which is that, you know, look, the typical situation, which I was the typical situation person because my father was a farm worker. This happens to all these Chicanos in California and Texas. You learn Spanish in the house from people that speak workaday Spanish, okay? And that's if they speak Spanish, because these new Indian populations don't even speak Spanish that are coming in from Mexico. So, I mean, you end up then with a stunted growth in your vocabulary, right? And then after the fact, you're going after to clean it up. It took me like 20 years to give a decent Spanish talk in Mexico, after this early stunting that you take, but you have to build your vocabulary slowly over time. How do you overcome that barrier? Because the kids go to school and that's it. That stops the Spanish. And then they get, you know, like the refrain goes, they get a B-, you know, in Spanish.
I think Melissa was going to jump in too.
Yes, thank you so much. And yeah, thank you for the question. I think it's such an important thing to consider. And I want to kind of circle back to what Miguel was saying, you know, in the sense of really kind of what we're talking about is almost a mashup of some of the things I was discussing and some of the things that he was discussing, right? And he had that wonderful conceptual model that brought in a lot of the social contextual factors that I think we do need to be discussing. And I don't know of work looking at that kind of that larger model completely, but I know, you know, as Miguel said, he's collecting data. We're collecting more data. I mentioned in my talk that we have those 10 kind of acculturation and context metrics, but we've actually incorporated a lot more, many of them asking some of these questions that both the individual who asked the question and the panelist kind of mentioned as their experiences or their known experiences of these types of difficulties for some people learning a language over others. And so we're trying to tease that out as well. And certainly I'm happy to share that data and collaborate with anyone interested in answering those questions, because I think the more people we have in this space, the better off the science will be. So thank you for that question.
Okay, I get the last question. Bienvenidos a Chicago to everybody. David Marquez from University of Illinois, Chicago, and a colleague with Melissa at the Rush Alzheimer's Disease Center. I have a question for Dr. Graham about the personality factors, because I think this is knowledge that's so important to have in relationship to brain health. A concern that I have is thinking about personality traits and how they're relatively stable over time. And amongst Latinos, you know, when we talk about like, oh, lower levels of education, unfortunately, you know, puts you at greater risk for cognitive decline than it's, but you can't really do anything about it now. It's important for our future generations, our current generations, to know about these things. So a concern with, you know, as somebody who's more of an introvert, when I hear about the benefits of being an extrovert, I'm kind of like, oh man, you know, like I won't necessarily get that. So, you know, how do you think the results can be useful in terms of I'm in health promotion, so I think about those things. But you know, like tidbits or information that people can use it out in the community or that type of thing, the Latino Latinx community.
I think that's a really great question, and I'm glad that you brought it up. And I hope that I have a couple things that immediately came to mind. I hope I have time to say them all. First of which is that extroversion is not consistently related to cognitive function or cognitive health over time, so I think you're okay. We're also starting to look at, this is a bit of a tangent, but my work is starting to head in the direction of looking at loneliness and social isolation and the asymmetry between the two, which we expect that introversion might actually be of benefit to that as far as like the downstream predictive pathway. So I think you're going to be okay. As far as personality, the relative stability of personality, we've done some work looking at, again, like doing these big conceptual replications, that personality does have potential to change over time. And that could be then related to your cognitive health. And so one of the open questions is whether or not personality change is actually a symptom of like the prodromal stage of the onset of dementia, or it could be a protective factor if we identify things early on enough. So people who are rapidly increasing in neuroticism actually might be starting to enter in and through what Dr. Vega was showing with like that pathway through MCI down into dementia. So from an intervention standpoint, personality might be able to serve as like an early identifier. So if we see somebody experiencing troubling personality change early on, we might be able to intervene and maybe help stave off the effects at some point. Another perspective we can take is like these traits that we know are really beneficial, like conscientiousness and openness, identifying the underlying mechanisms earlier on in life and helping somebody either build characteristics like being more open, engaging in more stimulating cognitive activities, or with conscientiousness, like becoming more organized, more achievement goal oriented, might kind of help somebody preserve like that cognitive reserve stuff.
That's wonderful. Thank you.
Yes. You're welcome.
Okay, thank you very much. We are gonna go ahead with the break, coffee break. Melissa, thank you very much. And everyone who's connected, we're gonna stop for like 15 minutes and we're gonna be back. 7 minutes.
Please help yourself with drinks and food, and there are restaurants across this hallway.
Coffee break and then back on. I just need to find that next presenter. So.
Elise. My family has another name for me. Yeah. Are you ready? Because you're the first presenter. You'll be fine.
So I'll just show you the 5-minute sign. 5 minutes left and then 1 minute. So just so you know, I don't get a word. Are we all going to sit here?
Yeah, yeah.
Hello, everyone. I know that you really wanted to stand up, stretch, get some coffee and water, but we are about to start the second panel. I promise you, we're gonna have time in the lunchtime for like longer conversations and bigger hellos. At this moment, I'm gonna ask the presenters, I think they're all here already. All right, so at this moment, I would like to introduce you to Rogelio Sáenz from the University of Texas, San Antonio, who very kindly accepted a very last minute invitation to chair this session. Thank you so much, Rogelio. Welcome.
Okay, good morning, and I'm very honored to be playing the role of our dear friend, Fernando, here today. We've had a great set of papers in the prior session, as well as the excellent keynote address that our colleague Sylvia Mejia presented. And the theme continues here because this next set of papers is another excellent, very interesting papers that continues the theme of resilience and aging. And let's see here. And what I'll do is I'll introduce the speakers. We have first Elizabeth Munoz from the University of Texas at Austin. Then we have Sara Aguilar Navarro from Universidad Nacional Autónoma de Mexico. And is she on the, okay, perfect. And then we have Iram Beltran Sanchez from UCLA. And then we have Gladys Maestre from University of Texas, Rio Grande Valley, my alma mater, when it used to be Pan American University. And then we also have, we're providing the discussion will be Elizabeth Vasquez from SUNY Albany. Okay, and we'll go ahead and start, and it'll be Elizabeth will go first.
Okay, I hope you can hear me. I tend to speak low, but I try to project. So thank you for the invitation to present some of my work here today with you. I'm excited to share this today. So yes, my name is Elizabeth Munoz. I'm an assistant professor in human development and family sciences at UT Austin. So I'll kind of glide through these slides because I don't have to convince everyone here that looking at the effects of predictors of cognitive health in Latinos in the United States is an important effort to pursue. We know that our population is growing. We're also at higher risk of cognitive impairment and ADRD or Alzheimer's disease and related dementias. And Also, acknowledging that there's diversity within the Latino population in the United States. So we are diverse in terms of multiple factors, including country of origin, and Mexican origin individuals make up over 60% of US Latinos. And we're mostly concentrated here in California, in Arizona, and Texas. And so in this study that I'll be presenting in another set of results, I'll be focusing particularly in Mexican origin individuals in the United States. And so even though we know that in general, racial and ethnic minoritized individuals are disproportionately exposed to social, environmental, socioeconomic adversities, objective indicators of these factors do not always explain differences in cognitive health outcomes, right? So growing evidence points to psychosocial stress factors as relevant mechanisms of racial and ethnic disparities in cognitive health. And specifically thinking about psychosocial stress, which I refer to as individual level subjective perceptions of stress that are shaped by our environment, social and structural and economic structures. And a whole number of studies, including work by myself, has shown that psychosocial stress is associated with poor cognitive health outcomes, including cognitive function, cognitive decline, and neuropathological health outcomes. But the problem with the measures, the typical measures of psychosocial stress, is that they're very general and broad and not specific to the source of stress. So they don't tell us anything about the reasons why individuals may feel stress. And one unique source of stress for racial and ethnic minoritized individuals, including Mexican individuals, is experiences with discrimination. And perceived ethnic discrimination basically relates, and specifically focusing on ethnic discrimination. So feeling like you're being treated badly or unfairly in your everyday life because of your ethnicity is a unique source of stress that has been postulated to activate psychological and physiological stress responses that may lead to reduced cognitive function in the moment by reducing attentional resources, but then also over time if it's chronic and consistent. And perceived ethnic discrimination has been associated with a number of mental and physical health outcomes, and increasing evidence shows that discrimination may also be linked with cognitive function in Latinos. So a study that Dr. Lamar just discussed, she found associations with a composite score that included discrimination along with other social stressors was linked with poor cognitive functioning. One of the limitations of this literature is that we only have cross-sectional associations. So single assessments of experiences of discrimination or experiences of stress. But we know if we think about the stress literature and early conceptualizations of the detrimental effects of stress on cognitive health and physical health, we know that thinking about longitudinal exposures to stress experiences is important to consider. So if we think back to Bruce McEwen's conceptualization of chronic stress, which is the wear and tear from too much stress or inefficient stress responses, here he shows that acute exposures to stress, so a single exposure to stress, it's not detrimental if an individual is able to adapt to that stressor. But if the stressor is consistent or an individual is not able to adapt to that stressor, then that can lead to poor cognitive health outcomes, including poor brain health outcomes. So specifically thinking about this condition here that I highlighted, assessing repeated assessments or getting data of repeated assessments of experiences with discrimination could help inform us on the amount of exposure and also the timing of exposure and how that might relate to cognitive health outcomes. And so in this first study, we wanted to look at the longitudinal experiences of with perceived ethnic discrimination across 12 years of assessments. We wanted to look at the trajectories of experiences, but then also how these experiences may vary across individuals. So do they consistently experience high discrimination, low or variable discrimination, like thinking back on McEwen's conditions of chronic stress. And then also we wanted to look at whether that's associated with cognitive function. So this paper was co-authored with Gina Sutin and Rick Robbins at who received funding to collect cognitive data on the parents from the California Families Project. So this is a study of youth and their parents who were living in Sacramento in California, Sacramento and the Woodland, California School District. And here we focused on the parent data, which led to over 1,100 parents at baseline. We had over 60% were female, 85% were born in Mexico. And we captured their data at baseline, they were 38 years old, and then we followed them across 12 years. The data followed them throughout 12 years. And here are some descriptives. So we had longitudinal measures of perceived ethnic discrimination from baseline all the way through wave 11, which spanned 12 years of assessment. So here's 2 sample items. Participants reported 2 items such as you're treated with less courtesy than other people because you're Mexican or Mexican American. And they responded from 0 to 3, never to always. And then we had cognitive function measure, a composite cognitive functioning measure at wave 11. So that's one limitation of this study. We accounted for baseline IQ. So the effects were relative to baseline IQ, accounted for education as well as age. I didn't put that there. And then we also looked at differences by gender, nativity, and language of interview. So in the interest of time, because I just learned I had 15 minutes to talk about this, I won't go in detail about the analyses, but we did growth curve models. And then if we had significant variance in the growth trajectory, we fit growth mixture models to see if we could identify different profiles of change in experiences with discrimination. So here's the univariate growth curve model. We found that over time, experiences with ethnic discrimination declined on average. We do see that we saw a pattern whereby experiences declined and kind of plateaued between the last 2 waves. And we also had significant variance in the slope parameter, which led us to do pursue a growth mixture model to identify different classes of change. So through model fit indices, we found 2 trajectories through what we call 2 profiles of change. We had a profile that was consistently low across time. So they tended to report low levels of discrimination across the study period. And this is the profile that we call the stable low profile. Yeah, the font is low, but we had the stable low profile. And then we had a profile that started off high at baseline and declined across time, like the average trajectory showed, but overall they were higher than the low stable low profile in ethnic discrimination reports. Now we wanted to look at who belongs to these profiles. We found that women were more likely to be in the stable low profile, so tended to report lower levels of discrimination. Those who were born in Mexico were more likely to be in the stable low profile compared to those who were born in the US, who were more likely to be in the high declining profile. And those who completed the interview in Spanish were more likely to be in the stable low profile compared to those who completed the interview in English, which I thought was very interesting and kind of motivated the next set of results that I'll talk about. But to just briefly talk about the results with cognitive functioning, we did find that the profile that was consistently low in cognitive function had a little bit higher cognitive functioning than the high declining profile. The effect size was pretty small, and the effect went away after we controlled for education, which kind of we can talk about that later. But then also at the last wave, we did see that higher discrimination was associated with lower cognitive performance at the last wave. Okay, so just briefly to discuss these results, we found that perceived ethnic discrimination declined over time. We found variability in the change trajectories that resulted in 2 change profiles, the stable low and the high declining profile. And we also had concurrent associations between discrimination at the last wave. And even though that effect did not vary by profile, we did find that the high declining profile had consistently higher levels of discrimination than the low declining profile, of course. Let's see, what else did I have here? Okay, yeah, so one thing that I thought was interesting and kind of pertinent to this session is that those who were interviewed in Spanish and who were born in Mexico and also who identified as women were more likely to report low levels of discrimination throughout the study period. And oftentimes, language of interview can be used as a proxy for acculturation. So in essence, low acculturated individuals reported lower levels of discrimination across the study period, which is consistent with previous evidence that shows that high acculturation is associated with more exposure to discrimination. So those who are highly acculturated experience more discrimination, which led me to two questions. Is lower acculturation protective to exposures of stress? And in order to kind of like, as I was looking through the literature, trying to understand this, I worked with another undergraduate student to look through the literature, and we found this study by Reese and colleagues that was published in 2018, and they proposed a model through which sociocultural factors may protect Latinos against the experiences of stress. So here they proposed that sociocultural factors may moderate the experience of stress through appraisal. So the way that we perceive events, which then has downstream effects on psychophysiological mechanisms. So I was really intrigued by this idea. They proposed this model here, which also draws from a classic theory of stress, the Lazarus and Folkman appraisal model, through which when we're confronted with an event, we appraise it as either stressful or not. If it's stressful, then we have to decide how to cope with that event, right? So what are we going to do about this stressor? In their sociocultural moderation of stress appraisal model, the Lazarus and Folkman model is very individualistic. So is this stressful for me, and how am I going to cope with it? In this sociocultural moderation model, it's really more about Latinos drawing on their collectivistic values and social networks to think about, rather than what am I going to do about this stressor, what are we going to do about this stressor? So it's more of a we question. So to kind of test this model, because it was a theoretical proposition, to empirically test this idea and using ethnicity as a proxy for cultural values, we leveraged the data from the Health and Brain Aging Aging Brain Study, HAPS HD study that Sid O'Brien and colleagues lead. And this is data from Mexican Americans and non-Hispanic whites living in the North Texas area. And they have a measure of chronic stress that asks individuals, have you had an event happen to you? Yes, no. How chronic has it been? And then also this appraisal question, how stressful has this problem been for you? And typically the way this measure is calculated is that it's a sum score. But I divided this scale into three components: the sum score of exposure, and also average course of chronicity, and importantly, the appraisal part. So how stressful do individuals report these stressors to be? And so preliminary results, we found interestingly that Mexican Americans report experiencing the same number of stressors than non-Hispanic whites. So they're exposed to the same stressors, but when it comes to the appraisal process, Mexican Americans report these events as being less stressful than non-Hispanic whites. And then delving a little bit deeper within the Mexican American sample, we leveraged the short acculturation scale and did a medium split and looked at the high acculturated versus low acculturated Mexican Americans. And we see that high acculturation is also associated with higher exposure to stressors and also higher appraisal reports. And then also preliminarily, we found that there are links with some cognitive scores that the HAPS HD data has, but we're still working on those analyses. So in conclusion, we find that ethnic discrimination is a relevant source of stress in Mexican individuals living in the United States. Longitudinal associations of experiences with discrimination vary within Mexicans by markers of acculturation. We find a possible resilience to the effects of stress for Mexican individuals that further varies by level of acculturation. And future next steps for this is that we need to identify sources of resiliency among low acculturation groups. So why do we find, at least behaviorally, more resilience in the low acculturated individuals, and also need to replicate these results with biological markers of stress. So is this resiliency only skin deep, or does it also have downstream effects to our physiological well-being? And with that, thank you for your time.
One, two, three.
Give me one moment, everyone. I'm just going to make sure that everyone else can see that. So.
One, two, three, four. Hello, everyone. I would like to thank Dr. Claudia Andrade and Dr. Sylvia Mejia for the opportunity to participate in this symposium. My presentation is about the Brain Health Index as a predictor of possible vascular cognitive impairment in the Mexican Health and Aging Study 2012-2015 weight. I have nothing to disclose. Ischemic heart disease, stroke, and dementia are leading causes of the death of and disability worldwide, notably affecting aging population. Vascular cognitive impairment refers to a variety of cerebrovascular pathologies that contribute to cognitive impairment. Vascular dementia is the second leading cause of dementia and accounts for up to 15–20% of dementia cases. When compared to Alzheimer's disease and vascular dementia, patients have both a higher cardiovascular burden and a greater level of disability, which in turn led to increase health-related costs. Vascular cognitive impairment are divided according to the level, mild or major. Major vascular dementia is possible to post-stroke dementia, subcortical ischemic vascular dementia, multi-infracortical dementia, and mixed dementia. On the other hand, possible vascular dementia was defined by the combined presence of a positive history of stroke and when neuroimaging is not available and clinical significant cognitive deficit in a less one cognitive domain with functional dependence are present. There is limited information concerning vascular cognitive impairment in countries such as Mexico. The poverty study analyzed 110 Mexican subjects with a first ever stroke and found 3 months vascular dementia prevalence of 12%. Based on the Mexican Health and Aging Study, a prevalence of 0.6% of possible vascular dementia with an incidence of 2.2 cases per 1,000 person-years have been recently estimated. The incidence of dementia has fallen in many countries, probably because of improvements in education, nutrition, healthcare, and lifestyle change. In the Lancet Commission showed 12 potential modifiable risk factors for dementia in the different stages of the life. Hypertension, alcohol, obesity in the middle life, or smoking, depression, or diabetes in the latter life. Modifiable risk factors account for around 4% of worldwide dementia, that the potential for prevention is high in a mild, be higher in low incomes and the middle income countries, where more dementia occur. Brain Health Index is defined as the capacity to function adaptability in the environment, with recent definitions emphasis to meet the need for a broader
perspective and not only referring to the mere absence of disease, such as stroke or as Alzheimer disease. The Brain Health Index used in this study was derived from the previous proposal, the American Heart Association Life Sample 7, the Lifestyle for Brain Health Libre Index of the Maastricht study, and the cardiovascular risk factor age and dementia, the guided study in the Finnish to construct the Brain Health Index. For the CHAS, we select factors where the reader for the question has a medical doctor diagnosis due with diabetes, hypertension, or myocardial infarction to determine the level of physical inactivity. For example, the participant had to answer no to the question, on average, during the last 2 years, have you exercised or been engaged in hard physical work 3 or more times a week? The present symptoms were considered significant based on the cutoff with more than 5, the modified version of the Center of Epidemiology Studies Depression Scale. Obesity was defined as a body mass index than 2025, self-reported body weight and height. History of smoking consisted of a composite score of 2 of the following question. Have you ever smoked cigarettes? And do you smoke cigarettes now? Our research question, in the absence of effective treatment of the disease spectrum, cardiovascular risk factors are a potential target for the prevention of all-cause dementia. This study aimed to establish the association and risk detected by the Brain Health Index as a predictor of possible vascular cognitive impairment in the NHALS 2012-2015. Do you know vascular, the NHALS is a longitudinal core study of Mexican adults than 15 years old. The Brain Health Index considered for the study were diabetes, hypertension, myocardial infarction, depression, obesity, physical inactivity, and smoking. Possible vascular dementia was defined if scored in 2 or more cognitive domains in the gross cultural cognitive examination or for proxy respondents in the Foreman questionnaire of cognitive decline in the elderly EQ code with 1 or more limitation in instrumental activities of daily living and history of stroke. A multinomial logistic regression model was developed to establish the risks of developing age-dependent variables, dementia, history of stroke, and possible vascular dementia. We use covariables age, sex, and years of education. In this flowchart, we show the sample selection in the baseline 2012 and the follow 2050 with participants with history of stroke, participants with new stroke, and participants no stroke, and cognitive impairment in the follow, possible vascular dementia, and possible vascular dementia with a new stroke in 2015. In this table, we show the participant demographic characteristics in 2015 follow. In case considered to have possible vascular dementia, the individual's mean age was 67 years, 35 were family, and the mean education level was 5.8. years. The possible vascular dementia group had a statistical significant higher education level when compared to dementia and the stroke groups. In the dementia groups, the mean age was 74.1 years and 63.7% were female. The history of the stroke group have a mean age of 65 and 48% were female. The cognitive impairment group had a mean age 64, 45 were female, and the mean education level was 5.8 years. Finally, the brain health index score in the possible vascular dementia group were 2.6 and 2.9 points. In the multinomial regression model for the brain health index and the diagnostic categories, the model was adjusted for age, sex, and educational level. In case with a higher score in the brain health index, the model revealed a hazard ratio of 1.63 for development for possible vascular dementia. The male sex yielded a hazard ratio of 3.7. The model show in the history of the stroke group in the even greater hazard ratio 1.7 for brain health index. Our conclusion. In this study demonstrate that the proposed in the brain health index is useful in determining the risk of developing possible vascular dementia. It also showed that the higher score, the greater risk of developing possible vascular dementia and stroke in Mexican adult age 15 years or older. It's important to underscore that the brain health index model revealed greater risks of possible vascular dementia independent of age, sex, and educational level in 3 diagnostic characteristics studies. Multimorbidity has been previously shown to be independent risk factor associated with mortality among other adults with hazard ratios 1.44. Multimorbidity is defined as the coexistence of 2 or more chronic conditions or disease. Since most cardiovascular risk factors are considered chronic conditions, the development of tools to measure the impact of their coexistence rather than their individual contribution could be helpful to determine relevant outcomes like this case dementia. Finally, of course, our study also has few limitations, retrospective survey, the operational definition of the diagnostic categories, the surveys are not correlated with neuroimaging studies, and finally, the cognitive assessment used in the MHAS does not allow use to identify a cognitive profile among the participants, such as non-amnesic multiple domain profile, which could suggest vascular etiology with more certainty. Finally, I have to thank my college. And of course, I show you my team in Mexico City, in the Department of Geriatric Medicine and Neurology Geriatrics, in the Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Subirán. Thank you for your attention.
Oops, I changed the wrong slideshow, everyone. Sorry, forgive me. Changed mode there. So here you can just use the arrow to go forward there and then that arrow to go back, and I'll go ahead and hide this. Sorry, give me 1 second. Oh, it's already hidden. There we go.
Great. Thank you. So thank you, everyone. I'm very grateful and thank you for inviting me to present. Jackie indicated that I had been an emerging scholar a few years ago. So before I actually start my presentation, I just want to take a few moments to thank Jackie and thank the organizers for inviting me to this session. But secondly, I also want to take a few moments to thank and appreciate Steve Wallace. So some of you might not know, but in 2014, Steve Wallace was the chair of the session in which I presented in this same conference. And when he introduced me to the audience, he said that I was had been hired at UCLA as an assistant professor. What he didn't mention, and this is very typical of Steve, was that he was the chair of the department. So he was actually very instrumental in my hiring. And a few years later, he was also very instrumental in my tenure process. So there is a lot that I want to thank Steve for all he did in my career and for where I am now. So I want to take just a few moments to thank Steve, and in memory of Steve, I hope I can live up to his promise, the research career that he had. So with that in mind, let me move into what I'll present today, which is assessing biological age in adult population. This is joint work with my longtime collaborator, Albert Paloni, and my other collaborators, Mary McKinney and Jijue Wang Fu. So the idea behind this assessment of biological age, doesn't want to go forward, so let me see if I can make it work. Oh, there you go. There have been several indicators that are being proposed to assess some underlying physiological deterioration. You might be familiar with some of these indicators, for instance, the metabolic syndrome, like the Framingham Index. And the idea behind of these indicators is to have a sense of whether a particular event might occur into the future. There have been a little more indices recently, for instance, like the allostatic load that not only includes biomarkers, but also trying to include indicators along the lines of stress and those type of experiences. So these type of indicators are relatively simple to compute because the idea is to use them in clinical settings. So that's kind of the idea behind. These are just some of the scores sometimes that they transform or they just add them up, like the metabolic syndrome. Biological age, on the other hand, has been constructed a little bit more elaborate because the idea is to try to get at the underlying biological deterioration or physiological deterioration. This is what some people are being calling like aging clocks, because in some ways what we're trying to address is aging as an indicator of time that might not necessarily go along the lines of chronological age. So under this approach, the idea is that biological age is going to include information of ideally several states. I hope you can see a little bit of this. Biological states like lipid indicators, sometimes like genetic markers, if possible, indicators of some neurodegenerative activity or epigenetic modifications. And however, that's kind of the general idea, but in most national level surveys, which is what I'm usually interested in using at the national level, we have just a handful of these type of indicators. So what I'm gonna focus now is on trying to use some of those handful indicators that we sometimes have at the national level to try to address how one might estimate some of these markers. So here is the idea of other indicators that have been used recently, in particular in the health and retirement study in the US, what is called the aging clocks. Most of these indicators use epigenetic markers, which are quite different from what I'll show you today. Although that is the interesting thing, I believe, about the work that I'm doing, that we can incorporate epigenetic markers, and I'll make a note of that towards the end. So the main methods that have been used are usually based on this strictly linear association between biological age and chronological age. So most people assume there is a one-to-one relation between the two. One of the most typical indicators used in this area to estimate this biological age is by Clemeret-Duval technique, in which they propose this method that is fairly restrictive when one looks at it from a statistical point of view, because they not only assume a linear association, but it's a fairly strong linear association, that there is a one-to-one correspondence between what happens in chronological age and what happens in biological age. It is a one-to-one. What we are trying to do, however, our goal is to try to generalize that approach of trying to link the two. And we are going to do so through an structural equation model, because we believe the use of these type of models renders itself quite easily and clearly into trying to make this type of connections. So for example, under this approach, biological age is not measured, but it's a latent construct that one wants to extract using biological markers. And each biomarker is going to be linked with chronological age. And that is going to be kind of the key, how one links that connection. We're going to try to go beyond assuming a linear association and relax that assumption, but also allowing the possibility that biological age does not increase on a linear fashion with chronological age. And in fact, it might increase exponentially as age goes up. If you think about it, as you get older and older, the increase in biological age, in other words, the underlying physiological deterioration might speed up. And if that is the case, then we will be able to capture it if we do it in this fashion. What is interesting in here is that we do not constrain any of these parameters. Instead, we're going to let the data allow us to test whether those parameters are in fact linear. And if they are linear, then we go back to the traditional model. Even if they are linear, they might not necessarily increase on a linear kind of step fashion. So this is what we mean by generalized approach. So here is the general idea. We're going to try to test and create this indicator. The first is going to assume that there is a linear function, a linear connection between this biological age and chronological age. In the second, we're going to assume there is a nonlinear connection. So to give you a sense of when one uses this type of models, this is kind of how we represent the models. Behind the scenes, we have a series of equations that one estimates, but I don't want to go so much into the details. But the idea is that we're going to use as many biomarkers as one might have available. We're going to try to link those with this latent construct that one is going to get out of the model. And the next step would be, how do we connect that with chronological age? So that's what I'll show you in the next steps, which is how do we connect these underlying factor scores. These are latent indicators that we can think of them as mapping this vector of known biological ages that come from these biomarkers, and how we're going to link them with chronological age. And we propose two ways of doing it. One that we call the outcome free, and the second, which I think is the most exciting one, if one can use that word, exciting. It is exciting in the sense that it is called the outcome dependent. And the reason why we believe it is interesting is because we believe biological age is not unique. It does depend on the outcome that one is interested in studying. For example, one might have an older age, biologically speaking, to cardiovascular condition, and yet be physiologically younger for disability or functional mobility, for instance. Or you can think of any other physiological systems. So that's the idea for now. To test the model, we'll use mortality to anchor this value. So very quickly, as I said, I'm not going to go too much into the details, but here is this basically what goes behind the scenes. When one uses the outcome free, one gets factor scores that in the first case, we are going to link them linearly with chronological age, and we let the slope and intercept tell us how fast that connection might go. In the case of the nonlinear case, in the case of the outcome dependent, we go a little more elaborate because now we're going to use a hazard model. In our case, the hazard model is in terms of mortality. So what we are going to end up getting is biological age that is mortality dependent. But you can imagine, instead of high mortality, we could anchor to any other outcome of interest, not necessarily mortality. So at the end of the day, what we end up having is 4 different results for each individual, from the linear model, the outcome free or outcome dependent, and the same for the SCM non-linear. So those are the 4 outcomes. I'm going to be using the NHANES from the 80s. The reason why, because I have a mortality follow-up in 2015, from which I'll use the mortality to anchor the data. So this is a national representative sample. We're going to be using people from ages 30 to 75. That gives us about 9,100 individuals that I'll be studying. So here are the biomarkers that we are going to include in here, biomarkers from about 6 different physiological systems: metabolic, cardiac, lung function, kidney, liver, and immune function and inflammation. One could include as many biomarkers as one could have in the data. I'm only including these ones for purpose of comparability with other methods. So the results that I'll show you fairly quickly, because I think that's kind of the punchline. The results that I'm going to show you are 3 sets of results. The first one is what we call the age pattern. In other words, how those biological age look relative to chronological age when we compute it. Then we are going to try to link the difference between biological age and chronological age as an indicator of accelerated aging, meaning if somebody is biologically older relative to chronological age, is a little bit older, it's accelerated aging. We're going to try to link that with race, sex, and education. And finally, I'll show you what would happen when somebody has an accelerated aging, what the impact might be on his or her life expectancy at age 65. So let's start with some of the results. First, the age pattern of mortality. For the methods, what you see now on the left-hand side males, on the right-hand side females, this is the line that one would obtain if we only look at chronological age as it comes from the data. So this is kind of the underground benchmark. So here is what it looked like if I were to obtain data from the other prior methods, like the principal components and multiple regression that, as you can see, produce fairly univariate distributions, really concentrated. If one obtains the values from our method, this is the red one, which is the outcome-free estimator, red for the linear model, is very similar to the underlying black line a little bit. In other words, it really represents the underlying age distribution. And here is what happens if one uses the nonlinear model. So in other words, the only difference between linear and nonlinear model, the nonlinear model tends to move the figure a little bit to the left. If we associate this with some of the interesting indicators, so for instance, here is the association between the difference between BA and CA with some markers like age, sex, race, ethnicity, and education. So I highlighted the pieces that I would like you to pay attention to. First, the method that has traditionally been used, which is on the left, the Clemera-Duval. If one links this, it would assume that there is no link between how the difference between biological age and chronological age proceeds as one ages. There is no connection with chronological age. It would assume there are no sex differences between that accelerated aging, which one might think there is. If we, in contrast, use our method, we do find, in fact, that as one gets older, there is a larger difference between biological age and chronological age. And also there are actually large sex differences. Women tend to have a slower aging relative to males. And also, importantly, that if one looks at the most disadvantaged position populations, like non-Hispanic Blacks, non-Hispanic Mexican Americans in this case, or those with low education, they tend to have a higher biological age relative to chronological age. And the last point that I would like to make is, if you look in the line right here, our method fits the data much better if one were to judge on a statistical perspective. The last piece that I'll show you are results on life expectancy. So the idea in here, this is what I'll be showing you. I want to walk you a little bit through the figure before I show you the results. So what I'll be showing you are the relative changes in life expectancy at age 65 for a given change in biological age. What that means is if somebody has age 65 and his or her biological age is exactly 65, that individual would be right in the center. If the difference is positive, meaning the individual is biologically older and falls in this square in here, that means that individual is biologically older and has a shorter life expectancy. In contrast, if the lines are in here, that means the individual is biologically younger because that difference is negative. And if it falls in this square, that individual is biologically younger at the same time that has a higher life expectancy. How high or how low the life expectancy would be is given by these numbers. So far, so good. So there we go. These are the results once we get from all the different methods. So what I want to point out is, if you look at the red and green values, those are the ones that come from our estimates from the structural equation model. In particular, the solid lines, the solid dots that are really high in here, these are the ones that come from the outcome dependent. So to give you an example, if somebody at age 65 is about 5 years younger, that individual would be expected to live about 70% higher life expectancy. In contrast, if that individual is 5 years older, we would expect that individual to live about 50% shorter life expectancy in the case of females. So what that shows is that our method seems to be more sensitive to picking up changes in the underlying physiological deterioration that is translated in either shorter life expectancy or higher life expectancy, depending on the direction in which biological age goes relative to chronological age. So with that, I will conclude with the general ideas that our method, the nonlinear form, seems to be more appropriate. We believe that is not necessarily the case that chronological age and biological age go hand in hand. We don't need to impose parametric constraints, as some of the models traditionally do. We can actually test if that is the case. Our results are somewhat comparable with other methods that have been used. I didn't show you the results, but if one uses some of the methods to test for the prediction, which like the area under the predictive curve, one would find our method is better. And in particular, the outcome dependent allows one to study this from the perspective of using other indicators. As I said, you could use, for example, I'm doing work now to look at diabetes. So somebody might be biologically older relative to diabetes, not necessarily relatively to say cardiovascular disease. So one, it opens the possibility to estimate this for several conditions. Another advantage is that because we are within the framework of this structural equation model, allows one to incorporate many pathway mechanisms that are not traditionally used, allows to use exactly as many biomarkers as one might have. So just very quickly, because I know I'm out of time, here is what would obtain if one uses the HRS. The values are very small. The only reason I wanted to show you this is because the other lines that you see there are from epigenetic clocks. So what I'm showing here is that one uses biological markers who are more widely available in surveys as opposed to epigenetic markers. One still obtains an indicator of biological age that is fairly reasonable, even if in the absence of epigenetic indicators. So finally, if you guys want to take a look at the paper, it was just recently published, like a couple of weeks ago, in the Proceedings of National Academy of Sciences. So here is the reference, but I'll be happy to give you the slides if you would like to have them. So thank you.
Oops. Sorry, forgive me just one moment, Gladys. This keeps bouncing out to the larger screen and I'm just trying to drag it aside. Oops. Once here. Oh, everything's. To move to the next slide, you just click this button here, that one there, and that should move you on.
I can do that.
No.
Buenos días a todos. It is a real pleasure to be here with you. And I have to say, I'm particularly honored to recognize the life and work of Dr. Steve Wallace. And also to have the opportunity to have three of the most important pillars, I think, in the study of Latinos and Hispanics in this country, which is Dr. William Vega, Dr. Geriatrics, Martinez, and Dr. Angel. At least these three have been tremendously influential in my work, the selection of questions, and most of all of the work ethics. And also I want to acknowledge the people that are online. We wish you all were here because the energy in the room is amazing. I have to acknowledge, not only as a disclosure, but with a deep sense of gratitude to NIH, in particular, of course, our RECMAR funding, our South Texas ADRC, which is a new one, the only one in Texas so far. But I'm gonna be presenting most of these from one of my news initiatives funded by NIA, which is a DP1, and also it's possible because of the Texas Alzheimer's Research and Care Consortium. And I do have to declare that I have a small nonprofit working on the area. I don't know where that green, okay.
Sorry. I'm like, I don't think that's part of the design.
No, but I'm gonna tell you a little bit about why I'm doing what I'm doing right now, and also want to recognize the team. It's a tremendous, energetic, positive. It's a new team. I came to the University of Texas, Rio Grande Valley at the end of 2016, and we were able to find questions of interest for a lot of us there. I'm gonna introduce why. I'm gonna tell you about place-based research, which is this new ground for. I'm also going to tell you about neighborhood physical disorder and how are we measuring that. And I'm gonna share with you some of the preliminary results. How do you think of the right question at the right time? Some questions travel around the world for ages and seem to end up in the minds of different people right at the same time. This question in particular elicited our group to think, are our cities perpetuating isolation, inequality, apathy, and passivity? And we were able to bring together a team that actually this slide's not as current as I want to, but I want to highlight, you know, I don't know how to, but here in the picture, we have in the top file, we have our RECMAR scholars. In the second line, we have our most of our faculty, and in the very last with the mustache is Noe Garza, who leads a lot of the collection of the data on our programs with the promotoras in the Valley. In the third row, also at the very end, we have a philosopher, Dr. Angelica Potempa, and next to her, Dr. Michael Miner, who is actually from the business school. And in the last row, second to last is Dr. Gina Lovasi from Drexel University, and the last is Dr. Asura Seshadri, who are all implemented. And here embedded are some of the most important raters that we have for our neighborhood physical disorder. So we know that the type of big data that we get to use, it's could be either what we call biological, including everything that we can measure in the person, geospatial, geographically based, electronic health records, personal monitoring, and we also have now what's called effluent data, like Google search results and that type of things. And the traditional way is that you go deep in one of these and you make yourself an expert and you get the funding from the right institute and then you just stay there. Well, I think that's a false choice. And I think that I appreciate it very much, Dr. Bandiera in the morning, telling us how they are expanding this vision. And I think that's just the beginning of how we can create new knowledge and not only understand the effects of health disparities and the causes of health disparities. We are very focused on moving on to interventions and creation of new knowledge. So I think it's a false choice that one has to understand either the individual factors or collective factors. I think that the mitigating the risk of dementia and its outcomes is not an either or solution. I think researchers and the broader community, we should be attacking both individual and collective causes, because it is every single study says that individual characteristics, individual experiences, individual outcomes are impacted by the collective factors as well. And that's why we decided to initiate a place-based approach in the Rio Grande Valley. What is it? Many of you know, but I didn't know before I actually got into this. So the focus on place and therefore on groups of people connected by geography, instead of a focus on specific issues or separate individuals, is most effective when addressing a spatially concentrated problem. Place is an efficient platform for delivery, and there is a potential to spill over to others in the community. So these studies are not looking to generalize or to include as much as possible. It's focused on going deeper and trying to understand and then envisioning what kind of interventions can we able to generate. So it's focused on a whole set of issues that the community faces and tackles issues in tandem, seeks to improve comprehensive results, and takes advantage of the synergy achieved by addressing multiple issues at once. So questions are very important, like, so what place to target? How to leverage the city resources already present in those areas? And of course, develop and test tier interventions. And that's what we have been doing through the community core of our Alzheimer's disease RECMAR. So the key elements of the theory of action for place-based work is, of course, engagement of the community through it, at least the minimum is asset mapping and needs assessment. Develop a focus on clear results and develop shared data tools. Integrate the existing programs, build the core capacities of the organizations and communities. We have to break down silos, and we need to capture what we do and share the learning. What is the role of a higher university, higher education institution, a Hispanic serving institution, the only officially bilingual in the nation? Be the anchor organization. We built a senior coalition. We are the anchor, provided dedicated staff, and lead processes with them. Build the processes like common agenda, develop and feed share metrics, continuous communication, implement mutually reinforcing activities, and using clear results and data to improve outcomes. And this is our most, this is the traditional work, and we take that, clear results and data. So this work, I think it's going to be expanded later, shows that concentration of Alzheimer's disease in the nation, and you see the very black at the bottom of the country, and in the middle of the country, that's where Rio Grande Valley is. We started looking at, publicly available information like longevity, for example. We look, this is our area, and you can see at the bottom in the brown, yellow and brown, where Alzheimer's is concentrated, and in the other blue, where the Social Security beneficiaries are. And you see this, there is not a great match. And we started looking at, maybe people leave because of, Coco's work and the Hispanic paradox. Maybe people live longer in this area, and then maybe that's why we have more Alzheimer's. So we start looking at longevity. It's not apparent that that's the case. We look at area deprivation index, and that also wasn't a good match. We look at physical inactivity, and basically it's everywhere. So in this area, so it wasn't. And so started to think about, and we say, well, first of all, is this population a good, this is a good place for a place-based? Aren't they just enter the country and migrate? And when we look at how long people stay or how much they move after they have grown up in the area, well, the Valley is one of the areas in the country where people is born and stay. So we focus on neighborhood disorder, which is the observed or perceived physical and social features of neighborhoods that may signal breakdown of order and social control. And the concept of neighborhood disorder is influenced by the broken windows theory, which states that visible signs of disorder and misbehavior encourage further disorder and misbehavior. Not gonna really go into what mechanisms, but there are some, very serious theory about it. So we decided to assess neighborhood physical disorder. And we decided to try to see if we can do this virtually using Google Street Views. There are different ways of doing this. We selected this with the help of our colleagues at Drexel University and set up a whole team for virtual audits using Google Street Views. We generated a manual, tested, include more than 79 different categories. And then we were able to narrow down using studying the psychometric properties and consistency and reliability, and explore different ways of selecting areas around the point and different paradigms. And these are basically our preliminary results. I'm finishing, but I want to tell you. So we basically assessed 700 points in the Valley. We look to see the spatial autocorrelation, because if they are closer to each other, they tend to be the same. So we wanted to see if this was what we expected, and it was. We look at the rater interreliability, which we found out some were almost perfect, some were fair. We deleted the poor, and we found out how they were related to the previous residents' experience. We look at specific items in different cities generating this. But also because we were using Google Street Views, we could assess how was the neighborhood, for example, 10 years ago, and see how the neighborhood physical disorder changed over time. So we can explore questions like that. This is a figure that reflects, and that's why one number about neighborhood physical disorder is not enough. I think generating the visual maps, for example, the top first is Brownsville, where you can see the brown is very low, meaning very high neighborhood physical disorder. So the conditions there, and 2/3 of the city are very bad, but still you have, because it's a very segregated area, rich and poor, whites and Hispanics, you see very dark areas, and you see very dark, like in the third one, which is Harlingen, for example, that the top at the corner where you see a lot of green, that's where our Institute of Neurosciences and a lot of medical institutions are. So the question is not what you look at, but what you see. So in summary, we think that place-based research opens opportunity for community action, refinement of gene-environment interactions, and opens new ways to identify novel pathways for mitigation of dementia. Virtual audits are a feasible tool, and we are looking forward to explore more towns, more cities. We've done Mexico City, Rio de Janeiro, Belo Horizonte, Santiago de Chile, and Philadelphia, Manhattan, and we just concluded San Antonio. So if we might be able to work with you if you are interested. Neighborhoods matter at a very granular level. We don't believe just a census tract is good enough to assess the impact of neighborhoods. And I think that we found that omics researchers are well suited to analyze the data because they are very much used to working with hundreds of contradicting genes, variables, and things like that. So thank you.
Sorry, no, that's all right. I'll leave everyone there for you.
Awesome. All right, thank you. Thank you for all those presentations. And I had to say, like, you'll hear this theme around today. I was an emerging scholar when I started here. I was brought into, I will say, the community that is Dr. Martinez, Dr. Angel, and my mentor, Ben Shaw, that is here when he was at Albany with me and introduced me to this cadre of people that are doing amazing work when it comes to Latino health. And I know we can go Latinx, Latino, Latina. I prefer Latina because I'm old. And I think for older people, it just makes more sense. But those of you that are new generation, go ahead and continue doing that. But when I was asked to come here, like I started as an emerging scholar, and now I'm full circle. I'm a discussant. I'm like, I'm grown up. So, and I want to say that I'm reading through the papers and looking at the depth of methodologies that were expressed in this particular panel, we had to be aware that there are so many other issues that arise, not just when we think about stress in the paper with Munoz and thinking about why does the perception of stress changes as you get older? What are some of those factors that we need to continue looking at? And then we would move to brain health with the paper by Aguilar, and she's looking at this brain health and looking that not all the variables and all the methods are there to evaluate those issues. And I actually was in awe of the biological age paper because that's the paper that I've been wanting to write for like 10 years. And to see that we come together at this level and we can make these predictions and move the field forward. And it's not just thinking about the paradoxes or the bilingual paradox that was thrown in the first section or the acculturation, but it's thinking about more broadly because Latinos are going to represent a big proportion of the aging population and we do not have those specific measures. So most of the measures for cognitive function, for age have been done in other populations. And what does that bring to the table? What do we try to bring in? And finalizing with this neighborhood environment and context by Dr. Maestri, it's incredible because she actually said most of the things that I wanted to say when it comes to do we look at individual level or do we look at contextual factors? And as an epidemiologist, it's challenging. It's very, very challenging. We cannot think of aging as, I don't know if you saw that whole thing that aging is now an ICD-10 code. And you think about it, it's not a disease, it's a process, it's a continuum. And just thinking about how we get about it and how we need all these different pieces and components to really explain the direction of aging long-term. And I had to say that I want to hear the questions, so I'm going to stop right here. I'm usually long-winded, but I'm going to stop. And I just want to say that we have a lot of work ahead of us. And not just thinking about what measures are needed, but also as how do we interpret those measurements and how we move away from this expectation that Latinos live longer just because we have this context of familialism. But there are so many other variables that need to be represented in our equations and our modeling. So I'll stop there. Questions? Yeah. Yeah, go for it.
Yes, a great job, everybody. Fantastic panel. My question is for Liz. Really great work with discrimination. I wanted to pick your brain if you could explain a little bit about how education may play a role in your findings, because from what I remember, you mentioned, right, that the people who were tested in Spanish, women, and born in Mexico were the ones that had the low and stable discrimination, right? And from at least from work that I know that from people in our group and others, we've seen this weird thing with education and discrimination where we see higher education is associated with more discrimination. And then it gets complicated with cognition because then we have higher education is better cognition. So we have some weird associations there. And some of the thing I know my colleagues have been thinking is that because the higher education, you're more likely to be in more predominantly white spaces, that then that's why you're experiencing more discrimination. So I'm wondering, given with the group that you mentioned, Spanish women born in Mexico, more likely to have low education, reporting low discrimination. What are your thoughts on that?
So we didn't find differences in, we didn't find significant differences in education between the two groups. But that effect that we had with the high discrimination group having worse cognitive functioning, that effect went away after accounting for education. Possibly because high discrimination takes away motivation to pursue education or kind of limits educational attainment that leads to worse cognitive function. In this group in particular, the Mexican American parents in the California Families Project. So I'm not sure if that will be the same for other groups of individuals. In the second paper, the second analyses, though, we do see that higher acculturation groups have more stress, which kind of goes into that idea that the more integrated you are in the majority culture, the American culture, then you're exposed to more stress, and then that could be bad for you. So yeah, it's really perplexing, and I think it's really dependent on the samples, and yeah, and then thinking about how this looks also biologically, right? Because this is just behavioral data. But yeah, I agree with you based on the data, more like epidemiological data with education, and looking at the diminished returns of education too with African Americans who are highly educated, but that benefit of high education doesn't translate over to cognition too, possibly because of this idea that they're occupying more white spaces and experiencing more discrimination in those spaces as well. So anyone else have a question? Oh yeah, sorry.
I would like to comment on this, and I appreciate very much. I think we need to study those environments. I think we need to study operation. If we keep talking about health disparities, health outcomes, but the root cause we know is oppression. And how many studies of oppression? And this is, we're not talking about billionaires, few, the ones that are benefiting from what's going on. So in terms of language and acculturation and stress, and even biological aging, I suggest we study oppression in those environments where people was at the critical windows, and now we can, and what we have now, I don't think that has changed substantially, I think. So that's my proposal.
Hi, everyone. I am an older physician now getting my MPH. And in the very first week of my MPH, we talked about the evils of segregation. And I wanted to raise my hand and say, but aren't there some protective benefits to, as I did growing up in Pilsen, a Mexican-American neighborhood, where I could roll out of bed and speak Spanish all day long, eat the food that my parents prepared anywhere in my neighborhood, and engage with people who look like me and not experience oppression. And I wonder if that study is somewhere coming.
Who wants to take this one?
Thank you for your comment and question, and hopefully so. I think that the geographical differences at the border of Mexico and the United States provide a great opportunity because the segregation is quite high. And because so we can clearly establish where the different exposures are, and you can trace individuals where they have been and what they do and their perception of the oppression. And I think that all these factors that have been mentioned today, they are not ahistorical. They are rooted in history and in place as concepts. So I think we need to, and I will say I enjoy very much the metaphor of the river. I will add that the geological image of what's happening is also very important. There are many layers underneath that earthquake that we are seeing in disparities. So hopefully we can put together our brains and develop some interventions so we can learn more.
Just have one more comment. That I think this also calls for, this highlights the need for longitudinal data because in midlife, maybe this could be beneficial, but as the individuals age and they don't have access to resources, that could become a problem. So tracking that over time could also be important.
Just one final comment regarding this cooperation that was mentioned within public health, in particular in social epidemiology. There has been more recently the focus on structural factors that we call, and those structural factors include race and racism, along the lines of what has been common now with the critical race theory that comes basically from law, School of Law, in how certain laws are being passed to benefit certain groups. The typical one that you reminded me with your comments of growing up in this particular neighborhood is redlining. So that's a typical example of how these structural factors had an impact on how these neighborhoods were shaped. They were not just randomly put in that place. It's not random that you have a concentration of certain race ethnic groups with particular income distributions in those neighborhoods, and it goes back to the redlining areas, which have to do a lot with these structural factors.
Sure. Dr. Sanchez, I had a question about your biological age measurement, especially with regard to Latinos and sort of the Hispanic paradox. So do you get any sense that this biological age measurement is operating differently on the mortality outcomes differently by race and ethnicity?
It is, definitely it is. And something that I did not spend a lot of time on, but the way we're conceptualizing this idea of biological age is not a snapshot. What we think it is the accumulation of all the past experiences that have led up to the point at which we are measuring those indicators. So it is indeed the case that you have these disadvantaged populations like Latinos that have gone through all these experiences. It would be more likely that they'll be disadvantaged and more likely to have physical dysfunctioning or dysregulation in certain markers. So it is not a coincidence that among Latino populations, the metabolic conditions are highly prevalent because of the experiences that they have gone through, which in a few years we also will have perhaps cardiovascular conditions. So yeah, I definitely expect those differences to emerge. And what is interesting, I think, with this underlying biological age is that it's not a disease. What we're trying to get is this underlying physiological deterioration that might or might not have manifested yet into a condition.
Well, thank you all for your presentations. So I actually have two questions for Iram. So one of them is thinking about biological and chronological age, and your presentation that you discussed with us previously. How do you think your findings can be applied, let's say in the clinical setting, or out in the real world? And then also, I'm wondering if the methods that you used, that's my second question, the methods that you used, do you perhaps see them as be potential avenues for application when it comes to thinking about other ways of conceptualizing aging? So you talked about chronological and biological aging, but what about like subjective aging or other ways of defining aging? Do you think that the structural, basically the methods that you used, whether you think that that would be appropriate for that as well?
Right, yeah, thank you for your questions. Yes, I think with regards to the first question, how one can use this, for example, the genetic clocks, the ones that I just briefly mentioned towards the end, some of those clocks are actually now being used clinically. There are some companies that have been now using those that get a blood sample from which they get these epigenetic CPGs regions, and then they try to estimate what the genetic age of these individuals might be. What's the usefulness of that? I'm not sure, because it's not been pointing to any particular physiological system or disease. And that's what I'm trying to go with my approach. My approach, what I did so far, is to put all the biomarkers together and link them to mortality. But with this type of approach, you can collapse biomarkers into, say, indicators that are more prone to metabolic conditions. Those are more distinct to cardiovascular conditions. Those who are more distinct to, say, immune function. And then you can see how biologically might be sensitive to some of those mechanisms, to some of those particular physiological systems. The second step would be, to the extent that I were able to identify individuals who could potentially be biologically older in this particular mechanism, then the next question is there anything we could do to try to ameliorate that? One of the typical examples is medication. So for example, metabolic conditions or like lipid levels, now we have some medications that might control lipid levels. If that were to be the case, that perhaps one route, but yeah, it is possible.
Well, I mostly just want to praise presentations here, and I have a couple of methodological suggestions, and maybe you've already done these methodologies, and perhaps you could just point the rest of us to where we can find more information if it has already been done. But first of all, on this very important topic of oppression, I think that really the complexity, the depth of that topic needs to be explored qualitatively. And so I'm going to recommend that we do some future research on this whole topic of oppression and how it is perceived. Look at the narrative of those individuals who have survived the different forms of oppression, how they have used that as a method of resilience or as an additional stressor. And then specifically, I really want to praise Hiram's looking at non-linear models. I think that's where we really need to go in terms of the quantitative methodology. And what popped into my mind, and maybe you've already looked at this, was maybe some sort of Bayesian sequential analysis in order to get rid of maybe the extreme heteroskedasticity that you might have in these kind of data. I'm just wondering, have you discussed this particular data set with someone like Sudipto Banerjee, who may be able to give you some ideas about the Bayesian sequential analysis? So that's all. Great job.
Thank you for those questions and suggestions. And yet, well, I haven't talked to Sudipto yet, but yes, indeed, once we start going in this path, there are so many ways one can take. I want to describe one using kind of physiological systems for which we could have different latent constructs. So right now, I just have a single latent construct from all the biomarkers. You might as well get as many latent constructs as physiological systems you are putting in the data, from which you're going to start testing the sensitivity. That's one way to go. The second, which is what I'm already doing, is moving this forward with longitudinal studies, because what I just did in here was a cross-section. But then with the HRS, one has several ways in which we could be estimating these values as people age. And again, with the idea that this biological age measures the accumulation of these experiences, the question is how fast this biological age is progressing as the individual ages. So we are really capturing kind of this accumulation of experiences. I haven't gone to the area of Bayesian approach, but that's probably what I end up doing, either that one or the more general
growth curve approach to try to get at these trajectories over time. Yes, thank you.
It sounds like we have to wrap it up. I just want to say this is amazing. And you can see the intersectionality with all these levels of public health and the methods, the context. So this has been a great panel, and I appreciate the questions, and stay because there's more to come. So it's going to be awesome. Thank you.
That's okay. I was thinking that I should have been moving around because you've been moving
No,
around
it's
morning
fine.
and all of that.
It's fine.
Yeah, that's
That,
good
that
stuff.
microphone's not working properly. And so if that one was working, we would have been okay.
Tracy, thank you so much.
It's good. That microphone's not working properly. And so I've asked Omar if he has, oh, there he is. So all we need is one, so that when there's question and answer, they can answer the questions over there.
Okay.
So there's usually 4 of them sitting and they can just pass it between them and then we can hear it on the speaker.
No, it's going to come out of this speaker.
Okay, well, that's fine too.
Yeah,
Yeah,
we have 2 inputs first.
That's okay.
Oh my God.
Yeah.
No, I'm just
Okay.
So this is you, right?
Yeah, that's me.
Okay. I'm not going to touch it. We'll get the paper from the building to do it because it's electronic and I don't want to go lost. I'm going to touch it. I'll send them a message.
Like, you know, when you talk about that, yeah, we're going to think about like that.
Don't worry, I'm not trying.
good on that. Sorry to be.
They're in the back. The actual on the paper. That's it. Something's in Texas, like the notebook. They're in my room. Okay, so I can go upstairs. Okay, I'll clean it. Okay, the actual books in the back. Photograph. Yeah. Okay. Okay. Okay.
Hello, everyone. I know it's hard to go back after lunch, but we have a whole afternoon of adventures and knowledge ahead of you. I'm so glad that we had some time to chat, and especially after this last 2 years that we did so much over Zoom. So it's with great pleasure that now I open the session 3, Contextual Factors in Resilience. I would like to invite the chair, Benjamin Shaw from the University of Illinois, Chicago, to chair the session. Thank you.
Hello, everybody, and welcome to Chicago. Really honored to be part of this group, which I haven't been part of before, but I thank you to Flavia for the invitation. And really excited to introduce you to this next session on contextual factors and resilience. We have 4 great speakers, and beginning with Arturo Vargas Bustamante, a professor of health policy and management at UCLA. He'll be talking about older undocumented immigrants. Then we will turn to Stipika Mudraja from the Urban Institute, Senior Research Associate at the Urban Institute, who will be talking about the role of place in Alzheimer's disease among communities of color. Then we'll turn to Lisette Piedra, Associate Professor, School of Social Work at UIUC, talking about caregiving and its influence on social networks over time. And then finally, Mariana Lopez Ortega, researcher in medical sciences from the Institute of Nacional de Geriatria, talking about the experience and the costs of family caregiving. And then to round it all out, we have a great discussant. Since I've been hearing so many stories about the days of being emerging scholars, I'm going to just share one quick one of my own, which was probably my first GSA over 20 years ago. And I remember sitting in the lobby with my mentor, Neil Krause, and a couple others, kind of late at night. And Dr. Martinez, we didn't know each other, approaches and says, hey, does anybody want to go out for a nightcap? And without even thinking, I just raised my hand. But then I looked around and nobody else was raising their hands. None of my mentors, they were all too tired. So Dr. Martinez and I, he went out, just the two of us, for a nightcap in San Francisco. And it was so memorable. And just sure, I'll always be thankful for how generous Dr. Martinez is in his time with junior scholars, and what a role model he is to the field. So I really look forward to hearing him as well as a discussant. So anyway, first up, Arturo.
So good afternoon, everyone. I think I was the lucky one to keep you awake after lunch for the next 15 minutes. I hope that this topic will be interesting enough for you to be mentally sharp. So first, thank you very much for being here. Thank you very much for the invitation. And today I'm going to be talking about the state of older undocumented immigrants and their health. I'll do like. Which one? This one?
Yep. So, but wait, let me click out of it now. Sorry to be.
No worries.
I'll make this. Oh no, it should disappear, and then you should just be able to.
Oh yeah,
like
great.
that, and then ignore those. I'll be in charge.
Okay. Sounds good. So I will present in two parts. The first part of my presentation will summarize some basic facts about undocumented immigrants in the US. Particularly, I'm going to be focusing on the aging process of undocumented immigrants and what are going to be the consequences in terms of health and healthcare coverage. And in the second part of my presentation, I'm going to be focusing in California, the state where almost 1/4 of all undocumented immigrants in the US lives, because it has been an interesting case study on how to expand coverage to the undocumented. More recently, with the expansion of Medi-Cal, that is a Medicaid program in California, to undocumented immigrants 50 years of age and older, with projections to include everyone. And I will conclude my presentation showing some projections about the uninsured by the year 2024. So if I want you to get something from this presentation, it's going to be like 4 things. And the first one is the knowledge that undocumented immigrants in the US are actually kind of, like the number is kind of stable, if not declining. The population of undocumented immigrants reached a peak just 15 years ago in 2007, when it reached a maximum of 12.2 million people. However, since then, after the Great Recession, the number it declined sharply, and then it remained kind of stable, if not trending down. And by 2018, that is an estimate that is like the most reliable recent. It has been estimated between 10 and 11 million people, depending on the on the technique that you use to estimate this population. So undocumented immigrants in the US represent approximately 23% of all US immigrants. And then the second fact that I want you to get from this presentation is that the way that they concentrate geographically is very important for us to understand. First, because they tend to concentrate in few states. Almost 63% of undocumented immigrants live in 6 states only: California, Texas, Florida, New York, New Jersey, and Illinois. And 81% lives in 171 counties. Yes, still the majority of undocumented immigrants in the US are from Mexico, 43%. However, it has been almost a decade since the number of Mexican undocumented immigrants has been trending down. Number one, because of immigration enforcement, increased deportations. And number two, because of demographic changes in Mexico. Not that many Mexicans are available to migrate. So the new arrivals of undocumented immigrants in the US have been likely to be more for Central America and also Asian countries. Another very important fact that I want you to get from this presentation is that in the last 15 years, the population of undocumented immigrants in the US has been more likely to be longer stay. What do I mean by longer stay? Well, those undocumented immigrants that have lived in the US for more than 10 years. You can see in this chart how in 2005, pretty much the population of undocumented immigrants that was have lived in the US for more than 10 years or 5 years or less was kind of like comparable, 38 versus 36%. But since then until now, it has the longer stay population has almost doubled, reaching 66% of the undocumented immigrant population just by the year 2018. So, but why is this happening? Well, there are two trends that explain this divergence. The first one is that net immigration to the US is actually going down. In spite of what you see in the news, immigration in the US is declining, particularly sharply since 2016. We know because of home, right? And then the second one is that in the early 2000s, after September 11, immigration enforcement increased in the border. So this essentially brought circular migration down rapidly. What do I mean by circular migration? Well, in the past, immigrants used to come to the US, they worked many years, and then sometimes they went back. Many times, actually, they went back to their home countries when they were old or when they got sick. So this essentially eased the pressure of aging undocumented immigrants in the US healthcare system. However, now that circular migration has declined sharply, undocumented immigrants have by far more incentives to stay in their country and to grow old, to settle here, and they will need help, and they will need healthcare. So right now, the problem is not too obvious. Only about 10% of undocumented immigrants are either 55 and above. However, this population is aging rapidly. And even though they are not yet in that cohort of older undocumented immigrants, the undocumented right now in, let's say, like a middle-aged state are also at higher risk of having worse health. I recently did some data analysis with a California health interview survey, and I found that twice as many undocumented immigrants, 33%, ages 65 and older, reported fair or poor health compared to US-born citizens. And only 29.3% reported very good or excellent health compared to 54.2% for citizens. And this is, this population, again, is not more likely to be older right now, but it will be. And right now is also less likely to have health insurance. About 44.6% of undocumented immigrants lack health insurance in California, compared to 9.2% of US-born citizens. And this is not exclusive of undocumented immigrants. It's, on average, all immigrants in the US are aging. And I like to show this graph because it compares the cumulative percentage change of the US-born and the foreign-born population. And you can see that, yes, population aging is happening in both the native and the foreign-born population. However, for those cohorts that are 50 years of age and older, the population growth is by far much faster among the immigrant population. So what's going to happen in the next decades in the US if present trends continue? If we don't increase the number of young migrants coming to the US, well, the US healthcare system will be pretty much unprepared to deal with that population of aging immigrants. And this is, the healthcare system will be really pretty much unable to deliver optimal care, not only to undocumented, but also documented immigrants, because a lot of actually legally present immigrants do not accrue the 10 years that are needed of Social Security contributions to be eligible for Medicare. Also, and undocumented immigrants have been excluded from Medicare nationwide and from Medicaid in most US states. So for these immigrants that won't be able to get access to Medicare or Medicaid, poor access to care will continue to exacerbate health inequities. So what can we do to address this situation? Well, since the 1990s, when the federal government pretty much said, I'm not going to take care of immigrants, they essentially shifted the responsibility to the states and local safety net providers to expand coverage to this population. And California, that is home of a quarter of all undocumented immigrants in the US, started to innovate in different ways of expanding coverage to this population. It began with some limited health plans like Healthy San Francisco, or by shifting safety net safety net providers into medical homes for the uninsured, just like My Health LA. And more recently, California was one of the first states to expand full scope coverage to low-income undocumented immigrants under the age of 26 in the year 2020. This year, actually, it expanded it also to just a few months ago to older undocumented, low-income undocumented immigrants, those who are 50 years of age and older. And if the plans continue as right now are expected to happen, next year, 2023, all the remaining ages that are not yet eligible will become eligible, those who are 26 years of age to 49 years of age. If this budget appropriation that is right now being discussed and approved by California's Congress, if this happens, then by the year 2024, all low-income undocumented immigrants will be eligible for full scope medical. So what are like the main changes that are going to happen after 2024? Well, we expect that California will see further reductions in the number of the uninsured population. You can see in this graph that just after the approval of the ACA, the number of the share of the uninsured dropped drastically from 13.8% in 2013. It went down to about 7.4% in 2016, and it has remained relatively stable there. But those who remain as uninsured adults in California are mostly Latino. And among this population, my colleagues at the UCLA Center for Health Policy Research have found that it's mostly undocumented, and those who are ineligible, who are eligible but do not enroll in medical employer-sponsored coverage or the exchanges. So the projections are if the state ultimately is able to expand full scope medical coverage to all undocumented immigrants, it's estimated that the number of the uninsured will drop from 3 million people this year up to 2.3 million people by 2024. However, it is important to state that this is not necessarily going to close the coverage gap. This is, again, it's a great achievement to cover low-income undocumented immigrants, but some research that I have done recently has estimated that about 1 in 4 undocumented immigrants will remain above the coverage threshold. So undocumented immigrants, not everyone is under the 138% federal poverty level. So for those who are above the federal poverty level, they will continue to struggle to get coverage. But they are more likely to have employer-provided health insurance and health coverage from a relative, for example. They will continue to lack options to get affordable health insurance coverage. So for this population, the state will need to continue to find ways of including them and finally be able to reach universal health coverage in the state. Well, that's all that I have for you. I hope that we have a conversation during the Q&A. Thank you.
Things a little bit slow. Let me just change. So you just need to go to the next slide by pressing that one, and then you go back by pressing that one.
Okay, hello everyone. If Arturo successfully kept you awake, I don't know if I'll be able to follow in his footsteps. I may just put you all to sleep, but then again, maybe some of you like to sleep a little bit after the lunch. I would like to thank the organizers for inviting me to talk about this topic today. We've already heard a bunch of great presentations in the morning sessions, and there are many more to come later in the day and tomorrow. The one I'm going to be focusing on is the topic of the role of place for brain health equities among communities of color. And this study was really meant to be just a first step, laying some groundwork for the work that is to follow, and some of which is ongoing. So what you're going to see is some very basic descriptive results that hopefully will still be somewhat insightful. So to start with, we know that there are millions of people in the United States who live with Alzheimer's disease and related dementias, and their number is projected to grow substantially over the next few decades. African Americans, as well as Latinos, are more likely to develop Alzheimer's disease and related dementias than non-Latino whites. So when this is combined with the fact that the population of older African Americans is expected to double and older Latinos more than triple by mid-century, that tells you it's pretty easy to do the math how explosively the number of older people of color with Alzheimer's disease is going to be in the coming decades. We also know that where people live is anything but random. But the research, with some exceptions, some of which we heard about, examples of which we heard about in the previous sessions before the lunch, this research has been relatively limited. So in this analysis, the focus was really at looking how social determinants of health are related with Alzheimer's disease and related dementias at the county level. A little bit of a background, we know that social determinants of health, things like education, income, food, insecurity, state of physical environment, are among the key influences of dementia risk. There is a growing evidence that dementia risk can be modified by brain healthy behaviors. And so it's been already mentioned that the findings from the Lancet Commission, for example, suggest that managing certain risk factors, things like hypertension, diabetes, obesity, could prevent or delay about 40% of dementia cases. And from some data that was mentioned by Dr. Vega, this also seems to be potentially a conservative estimate. This number may be even higher, or at least higher in some societies. So in this analysis, I used data from Medicare fee for service data, supplemented with the data from the census, as well as county health rankings, which is basically this. Can think of it as repository of a lot of data from various sources at county level. Admittedly, the sample was arbitrarily chosen as top 25 and bottom 25 counties with respect to highest and lowest prevalence of Alzheimer's disease for Latinos, non-Latino, African Americans, and whites, even though the sample was arbitrarily cut at 25. Once the same analysis was repeated with top 10 counties or expanding to top 50 counties, it didn't really move the results one way or another. As I said, the analysis was descriptive in nature, looking at demographic and health profiles of counties with the highest and lowest prevalence among racial and ethnic groups of interest. Now, demographic and health profiles, I won't be showing them today. I'm going to focus in the interest of time on modifiable risk factors and socioeconomic correlates of Alzheimer's disease. So here are some results. So when we look at the what I call lifestyle-related modifiable risk factors, so things like diabetes, obesity, physical inactivity, smoking, insufficient sleep, we can see that African Americans, that's the left figure here, we can see pretty clear differences in the prevalence of diabetes, obesity, physical inactivity, smoking, and a little bit less so insufficient sleep in counties with the highest prevalence of Alzheimer's disease for African Americans, as opposed to those with the lowest prevalence. For Latinos, the trends are the same, but the differences are smaller. Switching to environmental modifiable risk factors, what is really dramatic is the difference in the access to exercise opportunities, especially for African Americans, but for Latinos, almost the same. So huge differences in the proportion of people who have access to exercise opportunities. That means, parks, built environment that is providing opportunities for people to have some physical activity. Also some difference in the food environment, basically availability and accessibility of food. So we are talking about the concepts such as food deserts, who lives in food deserts, who can afford healthy foods, etc. But arguably, the most dramatic difference in the socioeconomic profile of counties with the highest and lowest prevalence of Alzheimer's for African Americans and Latinos. We see that with respect to levels of education, but also all other indicators, household incomes, percentage of families living in poverty, those lacking health insurance. So pretty drastic difference for both African Americans and Latinos. Now, turning to non-Latino whites, how do they in a way compare? First, when we look at lifestyle-related factors, we see that whites also, those who live in the areas with the highest prevalence of ADRD, also are much more likely to have to report higher rates of diabetes, obesity, physical inactivity, insufficient sleep. So not that dissimilar, from other groups from people of color, but then. Other than, we already see with environmental modifiable risk factors that the difference in the access to exercise opportunities is smaller between the areas with the highest and lowest prevalence of Alzheimer's. There is admittedly, somewhat higher difference when it comes to air pollution. And then most interestingly, other than educational attainment, there is much. Other than educational attainment, there is actually much less difference in the socioeconomic profiles of the counties with the highest and lowest prevalence of ADRD among non-Latino whites. So basically, what other research shows and what this preliminary descriptive research tentatively supports is this notion that where people live matters. Among African Americans and Latinos, what we find as some of the most important factors are lower levels of educational attainment, lower median household incomes, lower rates of physical activity, less access to locations for exercise. In comparison, among non-Latino whites, the most important factors seem to be related with higher rates of diabetes, obesity, and then physical inactivity, sort of a common element, as well as to some extent the educational attainment. So those are some of the common factors for across all groups. Furthermore, as we've seen, research does suggest the importance of modifiable risk factors in curbing Alzheimer's disease and related dementias. And so there are a bunch of recommendations, things that we could and should do based on this and other findings. And that is to contextualize Alzheimer's data with social determinants of health data to be able to better target solutions where they're needed most, to improve the surveillance of Alzheimer's disease and monitoring efforts with a focus on geographic hotspots and high-risk populations, including many of the areas where people of color live, to invest in economic opportunity to promote brain health equity, but not only directly as it relates to health-related infrastructure, but also more broadly with respect to economic supports to disadvantaged communities, and something that is sort of near and dear to my heart, given that a lot of my research is dedicated to caregiving, to promote policies that support economic opportunity and resiliency in communities, such as paid family and medical leave, because we need to be aware that in addition to rightfully focusing on people who suffer from Alzheimer's disease, it is also their family members, their spouses, children, and other family members who carry that burden with them. So finally, I already hinted at some of the next steps. So we've been working on getting some additional high quality local level data, especially those that are that have been less used previously, including those on the availability of various health services and even nonprofit organizations that provide health-related supports at local level. And also, we are currently making some efforts to combine or to use this data alongside the individual level data from surveys such as the HRS in particular. First of all, because HRS already has some interesting measures of Alzheimer's disease, including some developed by Melinda Power and her lab that is adjusting for racial and ethnic differences, and also to focus on some of the less studied issues, including prodromal and or preclinical Alzheimer's disease, and how it may differ by geography and by race and ethnicity. And with that, I'm gonna conclude. So thank you.
Okay. Oh, let me just go get my USB with your PowerPoint on it. 1 second. You have it on a USB? Let's try this one and see if it. I have it on a USB too, but it's always. No, it seems to not. It seems to say it's. If you have yours, then let's try yours instead of mine. Oops. Sorry. Sure, I deleted that. Oh, yes, I think I did. Thanks.
Sorry about this. I had it there ready to go. Doesn't seem to be opening. Which one is it?
It's the top one. Yeah.
That one. Excellent. So I'll just share my screen. And then we want to do this, don't we? Oh, I'm pressing. Where is it? Oh. All right, so just to move forward, you're going to use the arrows like that. So that one's forward and that one's back. I'll move that out of the way. Thanks.
Okay, all right.
All right, thank you for your patience. We had technical difficulties. My name is Lisette Piedra, and I am so happy to be here. Thank you for inviting me to talk about social networks. This study came out of a diversity supplement that I have with the National Social Life, Health, and Aging Project. They were very interested in taking what is a very well-known study for older adults. It's a longitudinal study, and beginning to ask questions about how can we learn more about the minority populations. Usually they're something that you control for in the analysis. And so mine was to look at specifically Latinos. I want to just thank my collaborators, James Evanuk and Linda Wade, who have been very instrumental in encouraging me to do this kind of work. So I'm just going to give you background that you already know. We know that Latinos 65 and older are growing. They're going to expect them to grow to be 15 million. Compared to other groups, they have longer longevity, but they also live greater periods with diminished health. You know this. This is actually really bugs me. It bugs me for two reasons. One, because I do believe that this is completely modifiable. And it's not modifiable through medicine, it's actually modifiable through what we do in our environment. But the other piece that really is troubling is that so many people who work with Latino older adults, whether they're the community health workers, whether they're the older adults themselves, are not aware of this. So when I mention it to them, they oftentimes are surprised. What, really? It's like, yes. So there's a greater need for caregiving resources, but a lot of the caregiving takes place within the family context, within these networks. So what are social networks? So one of the first things I did was sort of just learn about this sociological part of the literature. And I have a social work background, so this was really foreign to me. Social networks are everybody who we're surrounded with, it's our family, it's our friends, it's the people we work with. You watch somebody on tenure track and who they choose to be with and how their social networks are constraining and shaping their behavior. And so we're very much creatures of context in this. So here's a picture of Latino social networks. The analysis that have been done with them is that those networks tend to be dense. They tend to be very family-centric, but there's also data that's beginning to show that as you get later in the life course, that Latinos are actually interested in having relationships with their neighbors, with their communities, and so they actually become less family-centric over time. But in the aggregate, it looks pretty traditional and family-centric. When I looked in the literature, and I'm like, well, who's done research on social networks and Latinos? There really wasn't a whole lot. I came across two studies. One is the Feinberg and Hammer study, which they looked at 48 Latino older adults, and they did one day they interviewed them on one day, and they said to them, okay, who do you interact with today? And who are your people that you talk to today? And so that gave them a sense of the size of their network, people they talked to, who helped them with their groceries, who they saw down the street. And then they looked at, how much reciprocity was in it and how much interconnection there was within the people. And what they found was that the stronger their network was, the more it was linked to whether or not they had medical needs. So people who had stronger networks were less likely to have medical need. And so this is one of the few studies that begin to look at that the networks that you're embedded in actually seems to make a difference. This study took place in the Upper East Side in New York. And what was interesting to me about it was that this is a pretty homogeneous sample. So you've got people from a particular community, similar ethnic backgrounds, similar age group, but you're having this variation of health outcomes that's related to their network. So I'll give you a little bit of social context, of history of the social context and how it relates to resiliency. So a lot of, for the sociologists in the room, a lot of the interest in social context really started when disengagement theory came up with the idea that as you get older, you become more socially isolated and disengaged. That was Cummings and Henry. And people were like, well, wait, that makes no sense. You're stripping aging from the social context, and it loses the question of, well, what makes people resilient and connected as they age. And so you had people becoming much more interested in continuity theory and activities. It's the activities and the way you continue your identity as you transition over the life course. And that grew into people becoming interested to what extent are you integrated in society and remain integrated as you get older, and its associations to health. And that eventually became part of this idea of looking at people's social networks. If you revisit the Hammer and Freudenberg's study, denser networks are more efficient. There's a lot more opportunity to have membership surveillance with somebody. If you have contact with your neighbor and you see that all of a sudden your neighbor's not there, or you might be inclined to knock on their door, so you have more access to surveillance. However, there's a flip side to that. It might interfere with privacy and support. So there's usually, but there are a lot of good things, there's usually a flip side to it. And so I say this because there's a lot of ways of measuring social networks. And so as I got into this literature, I thought, oh my God, my head's gonna explode from all the different caveats that contribute to social networks. And so I sort of settled on this literature. It's not new literature, it's been around, but Howard Littman and a lot of his colleagues said, well, wait a minute. It's not just these different aspects of social networks that are important, but it's actually the sum of these things, the constellation of these things that tend to serve as sort of resource worlds. And so they there's a series of studies that they did in the United States, partly with MSHAP, partly with other, but they've also done stuff in Europe. And so there's been a lot of international studies, and they tend to settle on about 3 to 5 network types. So the idea is that they take sort of these different aspects of networks, and they try to figure out, well, what sort of category of network do people fall under? And so one is that it's a restricted one. So you're just connected to the people that you know very closely. They tend to be family. You're not really involved in the community. You don't have a whole lot of friends. And the restricted type tends to be a lot more, having a lot more health problems. They're restricted. They have less access to resources because these networks serve as conduits of resources. And then they found sort of a series of enriched networks. So networks in which you have lots of friends, or you might have lots of family, but you're involved with different family members. And, or you have an enriched network with its congregates. It's sort of been based in a religious community. The fifth one was a diverse network. And a diverse network is where you have lots and lots of different kinds of relationships with different kinds of people. And the diverse networks were associated with greater health, cognitive health, longevity, all kinds of really good things. And so if you think about it in the range of like restricted being the one that seemed to be associated with more problematic people versus the diverse range, I started to wonder, well, I wonder what it looks like with Latinos, because there doesn't seem to be a whole lot about that. And so I also started to see that there's, networks can change over time. Our networks change as we change. And there's two sort of theories in sociology that sort of speaks to that. One is the convoy, that we have a group of people, and as we change, that convoy changes. And so that as we get older, a lot of times we become, our close ties become a lot very family centric. They get to be smaller. The other one is the social emotional theory, which is the idea that you also begin to develop, their ties are smaller, but they also tend to be more meaningful. And so these are two theories that suggest that as people get older, we can expect that their social networks will change. So, so this study, we decided, well, let's explore whether the social network groupings change by race or ethnicity and how they vary for caregivers. And we wanted to see, well, what is the characteristics of these networks? What are the characteristics of our participants? Do they change? And does being a caregiver make a difference in these networks? The methods that we used data from 3 rounds of the National Social Life, Health and Aging Project, NCHAP. We had 6,489 respondents. We used the latent class analysis to identify groupings of social relational characteristics. And we used the multinomial logic to predict class membership. Can you see that? We can. We used 3, oh no, really? She just told me I had 5 minutes. Okay, so I'm gonna speed this up. We used 3 measures of networks, their structure, their function, and their quality. The structure, we looked at, they have an important matters name generator, which helps us get a sense of who there is in their network and how that functions. We used, whether there's social strain and how often they're interacting with people, and then whether or not they experience loneliness as a sense of, well, what's the quality of it? Doesn't matter how wonderfully structured and high functioning your network is, if you feel lonely in the midst of it, there's not really a whole lot of quality there. Across all the rounds, it was pretty, the numbers were pretty similar, which we expected to find. We looked at sort of the characteristics, and again, we were just looking to see, are these numbers pretty similar from one round to the other? I just want to speed up to find our results. We came up with a 3-class solution. We found, a restricted class with overall low social connectivity, an enriched class, and a diverse class. And so these were just sort of what they were pretty much in the same number of people, and we had moderate stability. So people tended to be in the same group. More than half were from round 1 to round 3. What we found is that the likelihood of being an enriched class, which is sort of the in-between one, if you were a caregiver, that was more likely to be the case. The other thing I would like to bring your attention to is that, and I forgot to highlight the one for African Americans, but you were less likely to be in an enriched class if you were African American, and more likely to be in an enriched class if you were Hispanic. When we looked at change of class composition over time, we found that whites were most stable. Black respondents went from 51% in the enriched class in round 1 to 37% in round 3. So what you have is a decrease. Representation in the other two classes increased. Hispanic respondents go from 26 in the diverse class to 40% of representation in other classes declines. This is actually for Hispanics, it's actually a good thing. And for African Americans, it's actually almost what I expect. What I didn't expect to see was, I didn't expect to see this with Latinos as well. I mean, to see the opposite with Latinos. These are vulnerable populations that are clearly being responsive to their context in a way that other groups might not be. And when we looked at class composition by whether the respondent is a caregiver, we found that they were more likely to be an enriched class. And so the question really becomes, because there is movement in these classes, what is it that we can do, at the community within these networks to help them move into a more diverse, that gives you much more resources. But the fact that they're in an enriched class, being a caregiver in and of itself does not mean there will be a compromise in your network, which we found interesting. Over time, context-specific factors may be contributing to network resiliency among Hispanics and network vulnerability among African Americans. A better understanding of these network shifts would facilitate the development of policies and interventions for aging populations. And I have a limitation slide. Because as we were and this is very exploratory for us, we were just trying to come up, take a look at what how does these networks work for this population? And to my disappointment, the Latino sample was too small to consider like specifically Latino caregivers. And the other piece that that came out is that oftentimes when you look at social networks, you don't have a sense of how people themselves are navigating those networks. You don't get a sense of their personal agency. But you also, at least with this data set, you don't have consideration of the diversity of Latinos. And in particular, at the very basic, you don't have the inclusion of language. And this was actually really hair-raising to me and my colleague when we realized that what MSHAC has done is when you look at Hispanic, you're really looking at both groups put together. There is no control for Spanish language, and the Spanish language variable had not been made publicly accessible. This actually mattered because we were doing another study where we, because when you don't make something publicly accessible, it's not brought to the attention of scrutiny, or it's not subject to scrutiny. And so it's easy to miss problems. And so this is one of those missed problems. So when he and I looked at cognitive scores among Latino caregivers, not everybody, just caregivers, we found that Latino Spanish speakers were about 5 points lower than whites. And it was hair-raising because that's an artifact of being a problem with the measure and how it was translated. And so one of the things that we oftentimes don't think about is our measures, how were they translated? Were they in this kind of back translated type of thing, or were they actually checked for meaning? And how do they work when you are actually using them at the grassroots level? And so these are things that sort of come up as limitations when we think through the study. And that is it. Thank you again for being here and to letting me present here.
There, isn't it? Sorry, I always think it's just with this. Yeah, I'll just move that out of the way. And then we'll share the screen. Oh. Yeah, so you just go.
Hi, everyone. So I don't know if the first one of the presentations is the hardest one of the last one on the panel. So hopefully everyone is still sort of eyes open and not too tired. So I was thinking, for the past presentations, trying to remember the first ICA meeting that I attended. And I think it was right before I started a postdoc with Vil Vega at USC, so almost 10 years ago, and I don't know if I want to say it, but just to say thank you, Jackie, Cocos, Vil, everyone here. I think I've gone through poster presentation, early scholar, organizing meetings, I don't know how many things, and I really appreciate all of them. And I think one of the best things, at least for me, and I say it with these research collaborations and when you do a postgraduate program, the best part of thing is the people you meet. And I think for a lot of us, well, for me at least, it feels now like a family, not just like a research collaboration or a conference or something. So thanks. And of course, Flavia, for the opportunity to present here today. This is work that's qualitative, really different. So first, I have acknowledgements at the end, but first I want to thank Emily Freeman at the London School of Economics and Rosa Farres at the Mexican Federation, Alzheimer's Federation, because we're doing this work, in particular the work about the pathways of care with them. So I just want to take a couple of minutes to talk about this project. It's called STRIDE, which is Strengthening Responses to Dementia in Developing Countries. This was a 4-year project, where we had 7 countries participating, including Mexico, 2018 to 2021, but we had a 3-month extension because of COVID, which made life really hard to do fieldwork. The main objective of this very large project, 4-year project, was to contribute to improving care and support systems so that people living with dementia can live well, and that the family carers do not face excessive costs, risk falling into poverty, or compromise their own health. And this project in the 7 countries was carried out in collaboration with the Alzheimer's Disease International Association, and with Alzheimer's and other dementias associations in each country. In Mexico, as I said, it was in here where I work. I was a PI with the Mexican Alzheimer's Federation. And this is very important because from day one, we had that contact with people living with dementia and their carers, of course, and what we call stakeholders, like a national advisory group of public, federal and local level institutions that have been with us together in all the process. And this makes sort of research for us with a policy background much more sort of, you see where you want it to go. So this, as I was saying, this was a very large project with very different activities, very diverse, from what we call desk reviews, situational analysis on dementia care, which included like, do we have policies, do we do not, what are our services, national level, a SWOT analysis on what, if we want policies, what that could be, but also like field work, and in terms of one I'm presenting in terms of what about care, pathways and costs, the impact of caring for someone living with dementia as an unpaid carer, and also, for example, trying to figure out issues around stigma and knowledge about dementia in our country. So it was very diverse. And just to go right into the presentation, what I want to talk to you about today. It's one of the components, a working package of the project, which was, you cannot see that, but it says costs and impact of dementia care. So this part was, the study aims was to understand the costs of providing unpaid care work for family members with dementia in Mexico, and try to understand the associated economic, social, and health consequences of this unpaid care. So fieldwork included in-depth interviews with people who care or have cared for a family member with dementia, first in person, but of course, when we started, it was 2019. Then we had COVID coming in. We stopped for a while and then realized we cannot stop. So we continued remotely, doing either video, phone calls, WhatsApp calls, whatever the participant felt was better. So in total, we have 50 interviews with 23 participants. We had 1 participant lost to follow up, and 2 family members of the participants we interviewed that died, but not of COVID. We did this in 3 localities, Mexico City and Toluca. So because we were doing this in person at first, it was only sort of restricted to that area that we could have time and budget to go. So it was these 2 cities. And then when we went to virtual interviews or online, we were able to do some interviews in the state of Chiapas, which is southern state, much more disadvantaged. So we have 2 urban and 1 semi-urban, because it wasn't even in the capital of the state. So it was very interesting to have this diversity. We have multiple interviews with each participant, couple of hours or more, 3-4 hours, because it was different, as I was saying, different interviews, and of course, a wide range of topics. And sort of, I don't know if many of you have done qualitative. I was more of a quantitative person, but doing qualitative lately, and 50 interviews is years of analysis. But so here is some preliminary results. First, at the person, we have like two, been dividing these preliminary results in two levels. First, a personal level, what we call the personal level, and we have some emerging concepts. And first, I want to talk to you about an emerging concept of feeling trapped. For the participants, that the beginning of intensive care provision for someone with dementia is an event that divides one's life narrative into a before and an after. The after signals the end of freedom to direct one's life. There are no meaningful breaks in caregiving, and there is no way out. So caregiving responsibility is seen or felt as relentless. For example, one participant talks about the constant care for her father. Anytime he's at the day center, then she's cleaning and getting things ready for him. So even when he's not there, he's still doing things that are related to his care. Her siblings don't provide care because he doesn't want to go with anyone else. He just wants her to take care of him. Another participant talks about being in a cycle of caregiving, giving her dinner, getting her in bed, going to see her 2-3 times at night. When she gets up and in the morning, give her breakfast, change her, give lunch, do the housework, dinner, and they refer to, it's like when I was caring for a baby, everything. This same participant, for example, tells us it is very difficult to accept that this is your life. I mean, that everything spins around this, around Alzheimer's, and that even if you have lots of money and you have enough to pay someone to take care of her, or for you and everything, you're always going to be in charge of her, right? It is accepting that your social life has ended, your life, your tranquility. And for example, if you don't get on with your spouse, you say, no, that's not my life. I don't want to do this or live this way. So you separate. But here, there is no way to separate myself. I have to go on here. There is no way to go. Another emerging concept that we've seen in quite a few of the interviews is that of restructured lives. Being the main carer of a family member with dementia transforms lives and plans which have to be changed and restructured. There are no alternatives or no preferred alternatives, and so changes have to be made, even if they bring high opportunity costs and have negative social and economic impacts, as well as an impact on their health and well-being. An example, for example, in Mexico City, this is a participant, he's divorced and he has a teenage son that lives with him. They are from another state in the southeast of the country where his mother and sister lived. However, after not being able to find specialized care for diagnosis or management of his mother's condition, they decided to have his mother move with him to Mexico City and with his son. So besides the changes in having an additional family member at home, infrastructure, organizational changes that have been made, he also mentioned that had to leave a directive position for another one where he did very well, to another one that's much less challenging, significantly lower paid, but gives him the flexibility that he requires to take care of his mother. Another participant that lives with her mother until recently, she had a full-time job and a business, a restaurant bar in the city where she lives. But given the care responsibilities, he had to quit her full-time job. She only had the business, but however, with COVID, she had to close. So now she doesn't have that main income. So in this emerging concept, of course, there is an important number, as I was saying, of the participants that have to restructure their life, whereas that means leaving or changing the city where they live, their job or employment situation, their living arrangements, either they move or having the parent moving with them, but also personal habits that are transformed and that can potentially have a negative effect on participants' health and well-being. For example, all this talk about all this reference to sleep. So even when they manage full nights of sleep, they always refer to, but I'm always sort of, trying to see if I hear a noise. So, it can be sleep, but not restful sleep. They have to be alert all the time. So at the structural level, what have we learned so far? In most of these cases, it's long care trajectories, around 10 years, with a general lack of knowledge about, these family members, about what dementia is, what does it mean, what does it entitle, what can I expect in 1, 2, 5, 10 years. Normalization of cognitive decline as part of aging, and stigma, very related to that, where people do not externalize changes. Even if they see things are changing, they don't want to talk about it. They prohibit, their or rest of the family members to talk about the condition or associated problems. This generates a great delay in the search for care, and consequently, when people go and sort of seek some at least healthcare or diagnosis or tell me what's happening, there's little margin to act from the clinical aspect of it. And when there is a diagnosis, there's most of the times little or no explanation by health professionals about possible changes or behavior. So, okay, you have a diagnosis, but nothing else. And of course, all these psychosocial factors are really important, but people really don't know even that they could expect them to happen, much less how to manage them. So knowledge and learning or attention seeking is usually obtained post-event. And we also saw, especially in Mexico City and Toluca, a lot of self-learning strategies, such as support groups, going in the internet, trying to find information from Alzheimer's and other dementia associations, from other countries, especially Spanish-speaking countries like Spain or Argentina, South America. Also, a very high impact on family members that have to stop work or change their job, as I was saying. And really now, another part of the project is trying to give this, give it a value. How much is it costing in terms of time and job, either because they stop working or everything that they have to spend on doing all this rearranging in the home context. For example, also for those that had a day center as a support resource, they refer to the pandemic as a relevant negative impact, because now there's no moment of respite. So it has been 2+ years of it was very extreme, and now it's even more. Changes in home arrangements and life course, as I was saying, people migrating to the capital or other places, and the impact on life dynamics. And it has been also very interesting, not even very happy, whenever I think a bit sad way, for many participants, that they express that in retrospect, I've been doing this 6, 8 more years. There were a lot of things that we could have done. Like, if I knew this was going to happen, we could be better prepared. Or if I had known, I would have made things different. So I just want, before I finish, because I already saw the 1 minute. So just to thank, this project was for the 7 countries, but was funded by the UK's Research and Innovations Global Challenges Fund, and the project was administered by the London School of Economics. So thanks for that. Of course, to all the participants that agreed to take part in the study, and our immense gratitude for opening up to us, because it's really hard. And I was in some interviews and listened to all of them, and some of them are really like heartbreaking. To our fieldwork members, Janira, Jessica, and Rocio, that helped me with the interviews, and the twin translators, because as I was saying, this was based at the London School of Economics, and I'm doing the analysis with a English-speaking researcher. So everything had to be transcribed, translated, read by me again to check Spanish and English, and then the analysis. So if this takes long, doing it in both languages is even longer. So our translators too. To our Strike Mexico National Advisory Group, as I was saying, this group of stakeholders that have been with us for the 4 years, trying to see how to the future, how do we do we put these research results into practice or translating it to something? And to all the Strike Dementia project in the 7 countries and the London School of Economics, because this has been an astounding learning, all the learning and collaboration experiences. So thank you very much.
No, I'm just going to do this so that we can see everyone there. We need to.
Well, hello. I enjoyed the presentations very much, and the whole day has been really fantastic. And I've been part of this conference with Jackie and others from the beginning. And the last couple of years, we were not able to meet in person. So it's really nice to be in person and see all the energy of the group. So I feel inspired, and I hope you are too. I must say that there's a person that is missing, which is my good friend, Steve Wallace, who was always part of our group. He was a very close friend of mine, and I'm just glad to honor him this week by sending to press for the Journal of Aging and Health a special issue honoring his legacy and his work, which will be published probably by January and or February. So anyway, he's been missed really, and very much part of the RICMA world. There's directed the coordinating center there, and definitely missing. So first of all, the undocumented paper was what a wonderful new thing that we've been maybe ignoring forever. And you know, I mentioned to Arturo that I got contacted by USA Today on Monday. What do you know about undocumented baby boomers? And I said, I really don't. I've studied thousands of people over the years, Mexican Americans, but we never asked them about their legal status. But I said, I know a guy you can talk to, Arturo, and hopefully you'll be able to really talk to him and maybe just influence the press to do a piece on this. USA Today, I don't know how many people read it, but it's a lot of people. So anyways, the thing about undocumented aging, we talk about immigrants coming in healthy and then they get they lose their advantage over time because of behavioral changes, but also because of structural factors and hardships they face. Then you think about people who are undocumented, well, they face a lot more hardships and barriers to their lives. So if you're able to follow them over time, you're going to see that they really decline much faster than other immigrants. And of course, that's something that we need to study more, and it's just hard to do, of course, because of data limitations, but you're doing a great job there. Stipikas, focusing on place and Alzheimer's disease. Well, you know, we've been focusing on place and all kinds of well-being in older people. It wasn't really until the 90s when gerontologists and others in epidemiology began paying attention to neighborhoods and the social context. It's amazing how recently that is. Now, social scientists, sociologists, very much talked about the ecological, human ecology systems and so on, but they weren't talking about health outcomes. And so it is a very recent one. It's kind of challenging. You have ecological fallacy problems. Stipikas approach is kind of different, looking at specific areas based on the percentage of Alzheimer's disease in different populations. and he finds some, I thought, interesting findings. The challenge with what he's doing and what others are doing is to go beyond what an individual study can do to contribute and convince us that the context has an impact over and above individuals. And you mentioned toward the end that one way to do what you've been doing and maybe more appropriately is to have a large data set like the health and retirement study and follow people over time and look at incidence of dementia in neighborhoods and populations. Again, it's a very challenging field, but it's something that we do with all outcomes, and it's kind of like creative in a sense what you're doing in that looking at Alzheimer's disease in neighborhood, which is it hasn't really been done very much. We've done mortality, we've done depression, we've done disability, and very other things. I want to move to one thing I want to talk about. Where do these people live? I mean, you talk about Blacks and Hispanics and so on. And then I was thinking, you know, with the Blacks and Alzheimer's disease, are we talking about the Deep South? I mean, the stroke belt. Where possibly some of these Black people live, and maybe even the white people too, who do poorly. So having a map maybe where the people live in your study or a follow-up study, really. And I think you and I talked, this is kind of the beginning of maybe different studies that you can follow from this. So very innovative. Also innovative in is Lisette's study of caregiving. And we think of social networks, the social factors that's really contributing to caregiving and so on. Now you're talking about how the caregiving process leads to changes in the networks. And I thought that was really interesting. And then you show, of course, that the Latino population is very family-centric and does not benefit from outside networks as much. Now, about caregiving, I just want to say a couple of things about caregiving. Back in the 80s, we were saying that do we need another study of caregiving to prove to the world that it is stressful for individuals. Steve Zarek, the caregiving guru in many ways, wrote a paper. And then there was kind of like a decline and loss of interest in caregiving in the 80s and maybe even in the 90s. And then what happened after that? Well, you know, Alzheimer's disease came into the picture. And NIA started funding, still funding in a big way, studies of Alzheimer's disease and related dementia. And if you do that, then, you know, one way of dealing with it, because we're not really finding solutions to the problem, what we're doing is caregiving. People have to take care of their families. And so from the negative perspective on caregiving in the 80s, we're seeing people, you know, focusing on the positive aspects of caregiving in all populations, not just Hispanics, which we kind of saw in our recent data with the Hispanic EPIs, but in the general population too, there are a lot of positive aspects of caregiving. And so I know we're talking about resilience, and you know, when we think about the Latino population, the Hispanic, the population of Mexico that are familistic cultures, right? We think of maybe family resilience as something that is a good thing. And then we do not really want to overemphasize that. And the reason I say that is because you overemphasize the strengths of the family. You may deprive people of services that they may need. And I think that your presentation makes that point very well. And Mariana, last but not least, Mexico. There are a lot of people here who know a lot more about Mexico than I do, but I just say a few things about your work. The richness of qualitative data. Really, we ignore qualitative work in many of us in gerontology, but like when I just saw some of the statements up there, how rich that is. And you know, each of those statements is like a hypothesis that can be tested in a larger study. What about Mexico? Well, Mexico is got high life expectancy rising. I don't mean during the pandemic, we all have seen drops. But the other thing about Mexico, obesity is really high too, maybe higher than the US, right? They say diabetes, all of these risk factors for Alzheimer's disease, and also poverty in many people. And so I just want to repeat again the issue of caregiving and the positive aspects, but also what happens to familistic cultures, which is a negative thing, the opportunity cost where family members, like you mentioned, family members, women especially, they have to quit their jobs sometimes to take care of people with Alzheimer's disease in their families. And that is a huge thing. It's happening with the Mexican-American population too. And it's happening with the non-Hispanic white population. But they can deal with it better because they have the resources, more so than the Hispanics of the United States or Mexico. I just want to end by saying that thank you, tremendous work. There's a lot more to be done. And resilience is a nice concept. Again, I kind of want not to overemphasize resilience because we might deprive people of the services they really need. So thank you again. Very nice.
We have time for a few questions if someone wants to come up here and ask a question. Don't be shy. We all had lunch together.
So I don't know, it's maybe a little bit unorthodox, but I'll ask a couple of questions of my co-panelists. First, one of the graphs that you showed early on from Pew showed the difference in how long people stay in the United States and how it changed over time. So there are two things there. First, the numbers are not getting up 100. So is it that we don't notice the length of stay for the rest of the people?
Yeah, maybe it's not like it was like less than 5 and more than 5.
Okay. Yeah. And then the other thing is that the total we're getting up early on to more like 70, 75, and in more recent years to 80, 85. So I was wondering whether that was sort of a systematic difference or is that basically just accounted by the in-between? And then for the set, I just had a quick question. So especially when you mentioned the research done by Hal Litwin and his colleagues, and they've done a lot of cross-national work. But I was wondering, so do the implications of belonging to a certain group differ by society? In other words, being in a, let's say, a restricted network in a country like Denmark, where maybe the people are in such network, or there's a better healthcare system, and more so, people are more expecting other people to be in that kind of network. They're more accepting of that state of affairs. Is that different from being in such network in a country like Italy, where there's more of the expectation that we would have larger family, that we would be more with friends, and where not having those things can get more of psychological weight on individuals that sort of feel that they're failing in some way by so is there any research by how to provide something?
No, not that I know of, but I do know that because they're doing it within context, within the country context, so they're preparing people already in that context. And that some context, you'll see more movement than in others. That we're looking at, and that's already in context. But we don't know the psychological underpinnings. Is that causing feedback?
No, I just like everyone to be able to hear you.
Oh.
Sorry.
So we don't know if we don't know what's the agency behind it. It's something that in Mexico where everybody had sort of expectations. You still had a group within there that even though they were being critical of family, they were much more because they were so constrained to the family. It's the constrainment that they were more likely to have functional dependency. We don't know if one caused the other. We just know that they seem to go together. And so there's a lot we don't know about those things. So we do know that we are embedded and that they are types and we seem to have overarching impact.
All right, well, thank you all for your presentations. So the last presentation actually got me thinking, and I think the question might be relevant to all of you perhaps. So we talked about qualitative data and English and Spanish interviews and focus groups, and how do we account for the indigenous groups in Mexico, for example, or even outside of Mexico, and the detection of Alzheimer's and dementia-related conditions there as well. So if you all could perhaps say a few words about how do we also consider indigeneity in the work that we're doing, whether it's qualitative or quantitative.
So, well, just to clarify, all the interviews were done in Spanish, but then we had to translate it, and then I had to read the English so to make sure it made sense. Because sometimes you do verbatim translations, and you read it in Spanish, Mexican Spanish, and it's great, and you read it in English, and say like, what?
Right. I noticed that one of the. Sorry, go ahead.
But then just go to the indigenous. I mean, we do not just because part of this project, the whole project, part of it was going into trying to figure out stigma, and we did some. We have some information on sort of how not all the country, but some in some states what the views are about dementia, and and there are some indigenous communities that don't even have a term, of course. I think in work done by the Mexican Alzheimer's Federation, for example, that's not part of this project, but they have been doing things, for example, for a report of the Alzheimer's Disease International and other things. It's what you're saying is very true. I mean, that's cities and probably more, I don't know, urbanized places in Mexico do know the term dementia or probably Alzheimer's, and but they and just related to memory loss. But then in some indigenous communities, the things it's happening, of course. But then people say even more so than in urban places, probably refer it as the person is crazy. You did something bad in your life, so that's you feel bad and something's happening. So we do need to do much more research if we want to have programs or some policy or something in Mexico, not just with this, with everything. It's sort of, we are so diverse that it's really hard to just refer to one place and then trying to transform.
Thank you to all four of you for your presentations. It was four, right? I'm sorry, I have a headache, so I'm like, okay, let's see how this goes. I really appreciated the nuance you were providing, Mariana, on just very quickly on the way in which caregivers have adjusted their lives. So that was very interesting and tough to see, right? To learn about more and how it may differ from caregiving approaches here in the U.S. Or be similar in some ways. It was very interesting to see that the education basically was a major, ecological difference and not relative to income, for example. So that's kind of a point for the people that think that there's some educational true effect of education on cognition at the ecological level, but still it's interesting and consistent evidence with that, I suppose. But I had two questions, one for quick ones, I hope, one for Lisette and one for Arturo. One, Lisette, maybe asking question about basically not exactly the paper you presented, but something that is kind of prior, because you said yourself there's so little work on these kinds of measures. It's super interesting. So I was interested in understanding, you can say a little more about how the network, how the three types of networks were created. Sorry, you mentioned it briefly, but I missed a little bit of it to understand how basically the Latino versus African American versus white populations differ, to understand that better, and whether you've looked at how those are related to health outcomes, right? Because they're supposed to, the idea is that protection, sociocultural protection that relates in part to the advantage or the Hispanic health paradox is driven through things like this, through social support. So understanding network structure would be interesting from that perspective. And reminds me of not only the honoring the late Steve Wallace, but also the late Eta Virrell Fuentes here from UIC, right, that did some work on this, for example. And Arturo, the quick question was embedded in your projections. There's some sort of understanding of how the undocumented population is aging differently from potentially the native population or the documented population. So could you say a little bit more about? I assume it's much more rapid than other populations, but if you say something a little bit about that, it would be really interesting. Thank you.
Sure. Those are great questions. I'm just trying to they're complicated questions. I'm sorry. Thank you. So we did a late class analysis, and there is lots of literature that shows that there is a connection with health. There's lots of studies that were done, and they usually are looking at the networks controlling for Hispanics and Latinos, and then coming up and making the associations with health. So what we did in this one was we controlled for those health outcomes. We know that they're there. We know that we just wanted to see, are these networks coming up, and by using race and ethnicity as sort of our primary thing that we're looking at, as it changed from one round to the other. And so when we saw the shifts, what we're seeing is that, what he did was, what my colleague James did the analysis, so he ran the statistics. What he did was he took round and race, and he did an interaction variable, and he put that in. And so what we found is that the likelihood for African Americans in round 3 compared to baseline was that they were going to be less likely to be in a diverse, and that they will be more likely to be in a restricted network. And restricted, if you look at the literature, they are associated with more problematic health outcomes across the nations and in the United States. So, and then for Hispanics, it turned out that, and actually, I'll be honest with you, I was sort of expecting to see that they would be like African Americans, more restricted, but it turned out that they actually become more diverse. And becoming a caregiver, I had this, it's a bias, it's a social bias. When you think of a caregiver and you think of all of these stories and how constrained your world becomes, but that doesn't necessarily affect their networks. The subjective experience might be that they're constrained, but there are these networks that are sort of embedded in. And the question becomes, how can we harness these networks so that when they have something that dominates the before and after, that they're still able to maintain those ties that give them the resources and the help that they need.
Thank you. Great question. I totally agree with you. I think it's important for us to start looking at the underrepresented immigrant population as a age and how different the aging process works for them compared to documented immigrants and response citizens. But right now, as I showed, we don't have that many observations in a sample to be able to do a very strong and robust comparison. We also don't have that many people in the different age cohorts, because 65 at the end of the day is kind of like an arbitrary threshold, right? That's why I think that it was part of the inspiration for the policy in California to expand it to 50 and older, because we know that the aging process works differently for different individuals. So I think that was a the right choice, because a lot of the type of jobs that underprivileged immigrants have are dangerous, are strenuous, and they experience very poor access to healthcare. When they do have insurance, they face unstable insurance or very limited coverage. So by the time that the underprivileged immigrants age, when they actually need more health coverage, the needs are higher, their health outcomes are, I would hypothesize, worse. And I think that based on that very preliminary descriptive analysis that I have done, it suggests that that's the case. Like, you see what are like the main reported measures of health among the undocumented. They, as I summarize my presentation, they are likely to be much worse reported health than the U.S. citizen population. So once we start to like build up in that research, in the nuance to see what type of different comorbidities, how they treat these comorbidities, how they react to uncontrolled chronic conditions, then we will be able to characterize better how different the aging process works between the U.S. citizens. But right now, I think we're just at the onset of this new like wave of research. As I mentioned in my presentation, if these present trends continue and we start to see immigrants age, as particularly documented, we will definitely need the information to inform clinicians, to inform administrators, and to inform policymakers. Sure.
I just wanted to make a comment, especially my Dan's paper, where there's this sort of underlying theme about size, population size, sample size, but there's also this underlying theme about the translation piece, the language piece. And one of the challenges about doing stuff with, working in another language, whether it's Spanish or an indigenous population, is that you bump up against the labor that's involved with translating, and the mistaken notion that a translation that is tossed into Google Translate and you get like word for word translation, it's not exactly capturing meanings. And so a lot of our measures that we're using, that we're taking for granted, are sort of that, it used to be that you have a measure and you translate it, and ideally back translate it. You throw something into Google and you throw it back and you get the same thing, but it doesn't necessarily capture the meaning when it goes from one language medium to another. And so we're using measures around cognition, and some of them have been validated in Spanish, and some of them are adapted and not necessarily adapted or been validated and are being used because they're being used as the translations. So it raises a lot of questions. And you're in a nation that really does not understand the complexity of dealing with one language in the context of a very English dominant. And so I understand, I can imagine what your that was going, and I really appreciate it.
Just very quick, I can actually provide some example for that whole fraction. I actually once I did a study personal grant about the Leuven social isolation scale. It's something similar to social isolation. And yeah, when I did the score just translated, the understanding of what I was asking was so different to when I actually did a proper validation of the Leuven social isolation score. So it's very important when we even do that research to see whether the different surveys were just translated or actually validated to be culturally appropriate, because results tend to be very dramatic.
Thank you, everybody.
Wasn't looking where I was going. Okay, opening presentations now. Also, Gutierrez.
Sylvia, maybe you can put it back already.
Yeah, I'll just get it ready. Just get that ready.
Yes, good. Excellent.
We lost this,
I'm just gonna leave it now.
I'm going to keep the wing. So Fernando's going to do it or Jack's going to do it? Okay. So Fernando, take it away.
Only set is here.
Oh.
Okay, sorry, I was
Sorry.
You need a, just a quick thing.
Jackie, you want to do the first one?
Hello, everyone. Do you want to get a gift? If yes, pay attention here.
Jackie, you want to do the first one? No, you do. All right. As you can see, we have a couple of, can people hear me in the back? Yeah, okay. Sorry, I can't hear myself. I guess this will help. So we have a few, we're going to do a kind of we have some gifts. We have a gift bag for someone that, you know, normally we do the ICAs around a particular time of the year. So there are a couple of right answers to this question, but you know, about a celebration of different things around now. So if people want to raise their hand and say, what are we celebrating around this time of the year, this day or tomorrow, you'll get a prize. Yes. Yes. Mexican Independence Day is right. Congratulations. And on the other side of the border, relatedly, another celebration around this time of the year. Yes, we have a second winner. Ding, 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 ding. All right. The lady sitting behind Miguel Arce, I'm sorry, I don't know your name. Okay, and then yes, and then we have one more. No, she answered the answered the second one. Yes. All right. Okay. Thank you for the intermission. Now we're back to regular programming.
We moved from one lightning round to another lightning round. So those of you who've been a part of ICA over the past decade or so, you know that one of the things that makes ICA special is our commitment to mentoring the next generation of scholars. And this shouldn't be surprising. It's already been commented on. If you look around at the leaders of this conference series, you see some of the best mentors that you will ever see. People that are committed to building dynasties and supporting the next generation of scholars. So I know everyone's getting tired, but I want to encourage you over the next couple of hours to embrace this sacred commitment to the next generation of scholars and listen and support the next generation of scholars in this next paper session. And when you visit the posters in the background, let's be supportive and encouraging, you know, of our junior scholars, and that's what I wanted to say. So let's get started with our lightning presentations here. Before I do that, I did want to acknowledge briefly the people that were involved in reviewing the poster submissions and developing the lightning round. First and foremost, Adriana Reyes was the main leader of the mentoring sessions this year. Thank you very much, Adriana. Emma Aguilar was also very helpful, USC, and David Martinez. Thank you very much for your service this year. Thank you. And so I will introduce the first speaker, Angela Gutierrez. Please join me up here.
Good afternoon. Can you hear me? Awesome. Buenas tardes, everybody. So my name is Angela Gutierrez, and today I'll be giving a talk on rural-urban healthcare cost differences among Latinx adults with and without dementia, implications for resilience. So the Latinx population is the largest ethnic minoritized group in the US, and since 2010, also the largest ethnic minoritized group in rural America. And yet there's a dearth of research on Latinx adults in rural America. So what do we know among this population? We know that Latinx adults in rural America relative to non-Latinx whites are less likely to have access to medical care and health insurance, also have fewer physician visits, and they tend to have more emergency department visits, which ultimately leads to higher costs in the long term. And now thinking about rurality and dementia status among Latinx adults, and how specifically in rural counties, we see that the incidence of dementia is higher, yet the prevalence of dementia is lower than urban areas. And we also see that among rural residents, they tend to be diagnosed with dementia at younger ages, and they tend to have a shorter time to death, about 6 months after dementia diagnosis relative to their urban counterparts. And given that Latinx adults have a greater risk of developing dementia and have an earlier onset of dementia about 7 years earlier than non-Hispanic whites, we see that this can be a serious problem when it comes to looking at the intersection between Latinx adults who live in rural areas. So overall, I've seen 3 key gaps in the literature. The first is that rural-urban differences in healthcare costs are unclear. Overall, research in this area has generally looked at rural-urban differences in access to care. And so that research has been really important in documenting distinct barriers for accessing needed care. However, when it comes to looking at rural-urban differences in healthcare costs, that is an area that's been understudied. And in particular, it's been understudied among the Latinx population. So prior research in this area has generally controlled for race and ethnicity. And once again, if we control for race and ethnicity, we're likely obscuring several important patterns, just like we see within and across group differences for distinct health outcomes. There may be some interesting patterns that are being masked when it comes to healthcare cost. And the third gap is that data over time and across the US are needed. And in particular, research in this area has typically used cross-sectional or regional data. And although these have been able to provide unique insights in their own, by using data over time and by looking at a sample across the US, that would provide additional insights. And so with these gaps in mind, we developed 2 research questions. The first is, are there rural-urban healthcare cost differences among Latinx adults in the US? And what we hypothesize is that rural residents would have higher total and out-of-pocket cost than their urban counterparts. The second question that we raised was, does the geographic context healthcare relationship vary between those with and without dementia? In other words, is dementia status an effect modifier in this focal relationship? And so we hypothesize that rural residents with dementia would have the highest healthcare costs. So now thinking about what we actually did, our methods. We used data from the Health and Retirement Study, and in particular, we used the 2006 to 2018 waves, and we restricted analyses to Latinx adults who are 51 years and older, which resulted in an analytic sample of about 15,567 adults. So drawing on Lawton's theory of ecology on aging, we looked at the direct association between geographic context and healthcare cost. And specifically for healthcare cost, we differentiated between total healthcare cost and out-of-pocket healthcare cost. We then looked at whether dementia status was an effect modifier in this focal relationship. And to assess geographic context, we used the bio-rural-urban continuum codes to classify as either urban or rural. For healthcare costs, we use the Consumer Price Index to inflate all dollar amounts to 2021 values. And for dementia status, we use the Lang-Aware classification. And in particular, we combine those who are cognitively normal and those who have cognitively impaired non-dementia with, and ended up comparing those with persons with dementia. For all analyses, we went ahead and controlled for socio-demographic and health characteristics. And now in terms of the actual analysis, we used multivariable generalized linear regression models. And to address the repeated measures in our pooled cross-sectional data, we used GEE with a participant year unit. And because there was a large proportion of participants who had not incurred any healthcare cost, we used a binomial distribution for those who had no healthcare cost. And we used a gamma distribution for those who did have healthcare cost. So now jumping into the results and starting off with participant characteristics. Over half the sample were female. Almost 2/3 were born in the US. And the majority lived in urban areas. That should say like 89%, I believe, were urban. And so as a reminder, back to research question number 1. Are there rural-urban healthcare cost differences among Latinx adults in the US? And we found evidence that yes, there were significant differences. So here is, we're depicting the total healthcare cost between rural and urban areas. And rural residents have statistically significant higher total healthcare cost than their urban counterparts. And specifically, they paid about $850 more annually. And overall, we saw the same pattern when we looked at out-of-pocket cost in this slide now. And so rural residents overall paid an estimated $870 more than their urban counterparts in out-of-pocket cost. And so now jumping into the second research question, which was basically looking at the interaction between geographic context and dementia status. And overall, we found no evidence of any statistically significant interactions between the two. Even then, I still want to show you a graph here just for illustrating some of the trends that we saw. And here are the out-of-pocket cost of care by geographic context and dementia status. And once again, these are not statistically significant results, but interestingly, we see that there was a trend where those who live in rural areas and do not have dementia had incurred the most out-of-pocket cost. So now thinking about the key takeaways of the study. The first is that rural residents have higher total healthcare costs than their urban counterparts. And overall, this diverges from prior research. Prior research has typically not found significant rural-urban differences in healthcare cost. When we look at research that has been done in this area, we see that in some of their initial models, you'll see significant differences. And once they control for several other factors, those are diminished. But once again, these studies controlled for racial ethnicity. And so our study differs in that we're looking specifically among Latinx adults in rural and urban settings. Another key takeaway is that rural residents also had higher out-of-pocket costs than their urban counterparts. And this is consistent with prior research among privately insured US residents. So given that there's very limited research in this area, we did find a study among privately insured US residents. And what was interesting about the study is that they compared rural residents who were furthest from urban areas and compared that with rural residents who were close to urban areas, and then those who are in urban areas. And overall, they found that rural residents who are furthest away from urban areas had the highest out-of-pocket cost, which again just underscores the particular disadvantage and high burden of these costs for those who are in rural and isolated areas. And finally, the key takeaway is that there were no statistically significant interactions between geographic context and dementia status on healthcare cost. We were surprised to see this, as it's not what we had hypothesized. And prior research shows that individuals with dementia incur higher healthcare costs than those without dementia. And also keeping in mind that dementia costs are not consistent over the years. Generally, they're highest the first year after dementia diagnosis. But then when we're thinking about our population at hand, Latinx adults, we see that Latinx adults tend to develop dementia earlier than non-Hispanic whites, and also they tend to live longer with dementia than non-Hispanic whites. So just thinking about how in our study, we're looking at a population who likely has a very different health profile than non-Hispanic whites, for example. And something that we didn't tap into that is a limitation and something to consider is the unmet needs of these folks. And in particular, we see that rural residents with dementia, they did not incur the highest healthcare cost. And interestingly, that brings to mind literature that talks about rural residents being geographically isolated, having fewer specialty services, and having higher rates of poverty. And so the interaction of these and how they potentially are barriers for these individuals accessing the care that they need. So overall, this study is able to document the disproportionately high burden of healthcare among rural relative to urban Latinx adults. And findings also underscore the larger geographic context in shaping opportunities and/or constraints for resilience and healthy aging. So when we think of resilience research, many times we can focus on psychosocial factors, interpersonal factors, but also keeping in mind how the larger structural factors and geographic context, how they also importantly shape resilience opportunities. And finally, this research looks at basically the intersection of three groups who are generally understudied and overlooked in research. Those rural residents, persons with dementia, and the Latinx population. And findings clarify how rurality confers healthcare disadvantage for Latinx adults. In terms of next steps, it would be important to look at the heterogeneity of rural areas, to look at unmet needs of rural residents and persons with dementia, and to look at variations across Latinx subgroups. And I just want to say thank you to the Michigan Center for Contextual Factors on Alzheimer's Disease and the folks here at the International Conference on Aging in the Americas, and happy to chat here or through email. Thank you.
Sorry. Just get the next please. I have to. Wondering why I have two presentations there. Just need to right click to go to the next slide.
And our next speaker is Felipe Antequera.
Thank you very much. Okay, our research, it's about the impact of ethnic enclaves on the life space mobility for the oldest Mexican Americans. I want to begin acknowledging and thanking and giving a thank you to the team that was part of this research, Dr. Phil Cantu, who supervised and collaborated on all this research from University of Texas Medical Branch at Galveston, Dr. Jackie Angel from the University of Texas at Austin, and Dr. Soham Alsni, also from the University of Texas Medical Branch at Galveston. And also I want to thank and I want to acknowledge that this work was supported by the National Institute of Aging project grants that are mentioned there. Okay, so the motivation for this research to start, we know that mobility limitation can be related to social isolation. And this is a risk factor related to higher mortality levels, to depression, to healthcare use, and other consequences. We also know that ethnic enclaves are a protective, community for health among all the Latinos. Just a reminder, the ethnic enclaves, right, are the geographic areas with a high concentration of ethnic population, right? And they are usually, they present a very particular cultural identity. And we know also that high concentration of poverty is related to lower life space mobility levels. So we know all this, but there is little known about the role that ethnic enclaves have in the relationship between the poverty and the life space mobility. Before we move on, I want to explain what is life space mobility, right? Maybe some of you are familiar with the concept. For those who are not, life space mobility, or LSM, it's a concept for assessing the older person's capacity and ability and patterns of functional mobility, okay? How a person is able to move outside their bedroom, within their house, outside their house, around their neighborhood, around their city, and outside their cities. The instrument, the most important instrument developed to assess, to measure life space mobility is the life space assessment instrument, which measures the level, these different levels that we see here, the frequency and the level of assistance that a person needs to move around, okay? This was developed by the University of Alabama at Birmingham. And we have research that shows that life space assessment instruments can accurately predict morbidity, mortality, and healthcare use. But again, as I said before, there's no research or very little research today that has examined the role of ethnic enclaves in the life space mobility of older adults. So our proposition is that based on previous research that we know that there is a negative relationship between life space mobility and poverty. And we also know that there is a positive relationship between general health and ethnic enclaves. So using census tract percentage of Mexican American population as a proxy for ethnic enclaves, we expect to find that the higher concentrations of Mexican American population in a census tract will mitigate, will have an effect in the relationship between poverty and life space mobility. What is the data that we use? First of all, we use the census data from 2010 to collect the census percentage track of poverty, and also to collect the percentage of Mexican American. And also we use the EPSI, the Hispanic Established Populations for the Epidemiologic Study of the Elderly, wave number 7, also from year 2010 and 11, with a number of 1,078 participants between 75 and 102 years old. Also from the EPSI, we have all the questions to calculate the life space assessment. We have the socio-demographic characteristics and the medical conditions of all the participants in this wave. For the analysis, we started calculating the life space assessment total score, which was not provided, but we had all the information to compute this, so it was the basic and first step. Then we classified the percentage, the participants by quintiles, percentage of poverty quintiles and percentage of Mexican American quintiles. We calculated covariance distribution by quintiles of poverty and Mexican American populations. I'm going to show you that in the next slide, if I'm not wrong. And we perform ANOVA and chi-square tests to test the independence of all the covariates and these two variables, the percentage of poverty and the percentage of Mexican Americans. And finally, we did multiple regression to see the relationship between poverty and life space assessment and see how the inclusion in the models of percentage of Mexican American can influence this relation. So for the results, we have here the graphs that show the demographic and the health characteristic by poverty quintiles. So we see here 5 poverty quintiles, right? And some of the demographic characteristics, like age, we divided the people into group age, younger than 85 and older or equal than 85 years old. We see the gender, the marital status, and the language of interview. And this is the distribution for each of the quintiles, okay? So we see, for example, if we see the yellow bars, we see that most of the people, sorry, not most of the people, around 30% of the people are married, right? And we wanted to show here that those variables are independent from the percentage of poverty. So we want to see some kind of even distribution. The only one that was not that even is the blue one that you see that is like a slight increment, right? And we did the same for the health conditions per poverty quintile. I'm not showing all the results because, you know, there were too much, but also we see the quintiles and we see the distribution of activities of daily living in the blue bars. The orange shows the depression, right? And we see like some kind of even distribution among each quintile, which is what we expect, so they can be independent. Same analysis for the percentage of Mexican American population quintiles. And we see, again, similar trends. There is not much variation and a similar distribution among the different quintiles of the socio-demographic characteristics and also for the health conditions, okay? Of course, the quintiles change, and these are indicated in the axis. Oh, that is very blurry, but you can trust me. That's it. We can share that. It's on the website. As for the regression results, so we conducted 5 models regressing life space assessment on poverty, and then we included the social demographic, the health characteristics, the percentage of Mexican American, which was, you know, our interest. Here I'm presenting part of the results. I bet this is too small to watch, so I'm gonna mention. The first one is the percentage of poverty, our main variable, right? Used to regress a life space assessment. And we are comparing model 3, which includes, on the left is model 3, the social demographic and the health covariates. And then in the model 4, we included the percentage of Mexican American. So that was our important comparison here. What happens once we include the Mexican American percentage in our model? The most important result here is that the percentage of poverty was affected, and it was from significant, it went to be non-significant, and also was reduced by more than 40%. The age, for example, it didn't change much. And this is another graph just because the scale was kind of different. I presented in 2 parts, but it's the same comparison. Model 3 before including percentage of Mexican American, and model 4 when we include it. And we see here some of the health covariates, like activities of daily living, depressive symptoms, cognitive impairment, and the physical performance. And none of these variables change dramatically. Most of them presented changes lower than 5%. The only one that changed, and as we expected, was the percentage of poverty. So for the discussion, first of all, we see that we are confirming here results of other studies that show that high concentration of poverty is negatively associated with the life space assessment. So we are providing additional evidence for previous studies. And also what I just mentioned, that all other covariates present a minimum variation when we adding the percentage of Mexican American. And this is additional evidence for the positive effect of the protective network that represents the social dynamics among Mexican American population in ethnic enclaves. Also, what are the policy implications of these results? The policy implications are related to the promotion and the construction of stronger networks and provide services via organizations and other institutions that are focused in the older populations to take advantage of this positive and the protective effect of health among older Latino populations living in ethnic enclaves. So when we identify ethnic enclaves, we know that we can provide, additional policies and support to these enclaves. And finally, we are contributing to the Age-Friendly Cities and Communities Initiative. This is a program that is part of the Age-Friendly Initiative, Age-Friendly Agenda that is promoted for the World Health Organization that aims to integrate the older populations into the broader community. And also we are providing, an additional contribution to understand and to expand the concept of aging in place, which maybe most of you are familiar with this term that is widely used in aging policy. And it relates that with the promotion of a connection and the feelings of security and the familiarity between older populations and their families and their houses. Well, that is my presentation. Thank you so much.
Our last presentation for the lightning presentation will be delivered by Jennifer Archuleta.
Hi, everyone. Good afternoon. My name is Jennifer, and I'm a fourth-year PhD student from UCLA. And I'm here to present a project that I worked on with my collaborator. Esmeralda is one of them who's in the audience here with us today. And I'd also like to recognize our mentor, Iram Beltran Sanchez, for his mentorship and support with this and many other projects. I would also like to dedicate this to Professor Steve Wallace. He was one of my professors at UCLA and one of my inspirations to pursue this field. And I miss him very much and hope that whatever work that I move forward in his honor will help future generations of aging adults. And second, I would also like to dedicate this work to my grandma Viola Rivera, who unfortunately passed away from complications due to dementia. And it's a very important topic that I've been further inspired to hear all of you talk about in your important work, because it's a very tough disease to deal with on the front lines. So thank you again for all of your work and contribution to this field. Just some background and formal definition of dementia. It's a disease that's characterized by cognitive impairment that affects memory, communication, behavior, and affects activities of daily living. It's experienced by about 8.8% of individuals aged 65 and older in the US. However, the Latinx population is expected to experience the largest increase in the next 40 years, about a 6-fold increase in dementia cases. And this is a particular concern since Latinx older adults have limited access already to quality healthcare and formal support for dementia, and that can impact future diagnosis and follow-up healthcare utilization. And given that COVID-19 pandemic has happened relatively recently, little is known about its effect on healthcare use among Latinx older adults with a dementia diagnosis. Therefore, we have 2 research aims. The first is to describe dementia trends in 2019 among Latinx older adults, and the second is to describe differences in their access to healthcare during the coronavirus pandemic. We use data from the National Health and Aging Trends Study, or NHATS. We've first used the 2019 sample, which had about 35,000 participants. And in 2020, they introduced a COVID-19 supplement that discussed questions directly related to the experience of healthcare during the COVID-19 pandemic. And there were about 4,000 participants in that sample. One thing to note is that this sample includes only Medicare beneficiaries age 65 and older. So we do recognize that we miss out on a considerable portion of the population that don't, of older adults that do not have Medicare for some reason. And we also restricted our sample to community dwelling older adults as opposed to those who live in nursing home facilities. I gave a brief definition of dementia, but how we operationalized it in this study is we acquired self-reported questions and cognitive tests from NHATS to come up with 3 categories that people were placed in for our analysis. So they were either considered as having normal cognition, possible dementia, and probable dementia. In our linear regression analysis, we focused on the population that responded to having possible or probable dementia. And for the interest of time, I won't go too much into the measures, but they were based off of test scores in 3 domains, which included executive functioning, orientation, and memory. The first step in our analytic approach was to create descriptive data in terms of sociodemographics in the 2019 data set and in the 2020 data set. And then we used weighted F tests to analyze differences between Latinx older adults and white participants. Last, we used linear probability models to estimate probability of 3 different variables related to healthcare utilization, which I'll discuss in a future slide. And covariates we used were age, gender, race, ethnicity, marital status, and income. Here are 3 outcome variables. The first, well, they were all binary variables in response to yes or no questions. The first asked participants whether they had put off care or whether they had intended to seek care but had put it off during the COVID-19 pandemic. The second asked whether they used help from a caregiver and within their social network to communicate with or visit a provider. And the third asked whether or not they had a hospital stay within the past 12 months. Really briefly, the results from each survey in terms of racial composition and dementia prevalence showed that they were pretty much the same, even though the sample sizes differed significantly. It was 35,000 versus 4,000, but they were about the same, with the sample consisting of about 7% Latinx, 9% Black, and 82% white. As far as the breakdown for dementia status, we see that about 83% had normal cognition, while 10% had possible dementia and 6% had probable dementia. When we stratified by race ethnicity in the 2019 descriptives, we found that relative to the white participants, there were more Latinx participants that had lower income, and they were also more likely to have a past year hospital visit, and they also had a higher likelihood of probable and possible dementia by quite a bit. It was about 3 times as many Latinx adults with probable dementia compared to, so about 17% compared to about 5% of white adults in our sample. And similar with possible dementia, with 24% versus 8%. And in 2020, when we looked at our descriptive stratified analyses between Latinx and white adults, we find similar trends where Latinx have lower income and higher likelihood of having probable and possible dementia. In this table, we show our 3 outcome variables and the descriptive breakdown of that, also stratified by race ethnicity. And we see overall, there's only significant differences by having help with from a caregiver with visiting a provider. So that difference was about 38% for Latinx older adults and 15% amongst non-Latinx white adults with dementia. And as far as putting off care during COVID-19, both groups respond about 40% to having that issue, whereas about 17-18% of the overall group reported having a hospital visit in the past 12 months during the COVID-19 pandemic. And finally, here are linear regression results. And each column represents each of our variables that we were modeling. So first, when we look at adults that had put off care due to the pandemic, we see significant results by Latinx and Black participants that shows that they were most likely to put off care compared to their white counterparts during the pandemic. In terms of having some caregiver help with seeing a provider during the pandemic, we find that Latinx and by older age group, there are significant differences in receiving help, and also having a hospital stay in the past 12 months was only significant by older age groups. This is a continuation of the previous table, but looks at marital status and income. There weren't very many significant results, except really we see that widows have a lower likelihood of putting off care compared to married participants. And then just to summarize key findings for interest of time, we saw that when we compare the 2020 versus the 2019 composition, they were both similar in terms of demographics, and overall about 17% of adults reported having possible or probable dementia. And when we compare differences by Latinx and white older adults, we saw that Latinx had lower income, higher rates of dementia, more hospital stays only in the 2019 sample, and they also received more help with visiting a provider. Finally, in our regression models, we saw that Latinx older adults with dementia were the group that were most likely to both put off care while receiving more help from a caregiver with seeing providers. And last of all, older age was associated with both receiving help with the provider and having a past year hospital stay during 2020. In conclusion, we would need to obtain more information, hopefully outside of just Medicare beneficiaries, in order to understand why older adults are putting off care. And this is an important issue, as we can see that the Latinx population relies a lot on caregivers for receiving support with visiting and communicating with their providers. And as we've heard in previous presentations, caregiver health is also important within the Latinx population, as they're a very integral part of the entire healthcare of aging adults. And last, as the population of older Latinx adults is increasing in this country, it's important to address for a future increase in demand for dementia-related services and the increasing costs of care. Thank you so much for your time.
We have time for a couple of questions for our lighting panel. If the authors want to come up, the last presenters would come up here. Thank you. Questions from the audience? Make them come up here for no reason. Come on.
I have a good question.
All right, please. It's your show.
First, this is the most exciting part of the event because this is the mentoring part of the event. And I remember me sitting there. So it's it's good to see how things move in our careers and lives. So first, congratulations on your great work, all of the three of you. But I have a question for Josefina. Do you have any variable that is if someone in the household had COVID? Because when you think about the results that you have, for example, they had help to go see a provider, but they put off care. right? So like maybe they had to seek if there was someone in the house. So I was wondering if you can include, or if there is a variable, something like that.
Yeah, that's a good question. Also, Josefina is the first author, but
Sorry.
the second author, Jennifer.
Sorry, Jennifer.
No, it's fine. So, yeah, I think that would have been an interesting variable to control for. I haven't looked too much in depth in the whole COVID 2020 supplement for that year, but if they did ask, or if they did not ask a question on whether or not someone in the household had COVID, I would be very surprised, because I'm sure that would play a great role in whether or not someone's able to visit their older adult relative, given that it's a contagious disease and they're at high risk of contracting the illness. So that would decrease their level of support. So I have to go back and look in the supplement to see if they asked that. But if they did, I think that would be an excellent variable to control for in future analysis.
Thank you so much, Jennifer.
Thank you.
Thank you so much for fantastic presentations. I have a question for you. I don't remember your name yet. Yeah, Felipe. It's about, you presented fantastic work on LSA, and I wonder whether you had the opportunity or have given any thoughts about potential association or correlation between LSA and MCR, this motoric cognitive risk concept. This idea that, I don't know, are you familiar with it?
I'm not familiar, so if you can describe.
Yeah, it's like, so MCR is motoric cognitive risk, and it's when individuals have low gait speed and subjective cognitive complaints. So when you were presenting, the first thing that came to my mind was, well, perhaps there's something there that you can look into how these two concepts may relate or may be associated, or
yeah,
so,
I mean, for sure. We included several health coverages, and I think one alternative could be like including that also, because we saw how activities of daily living, for example, have an impact, but then when we control and when we added the percentage of Mexican American, that didn't change. So it's interesting to see, this new variable and how it's going to be their behavior after we include in our model the percentage of Mexican American. For sure, that is a great follow-up study into, I think it shouldn't be very hard after what we develop, because we have very clear models. So including this variable, maybe individually or within the group of health coverages, will be a great follow-up.
I think that if you have the data to derive MCR, then you can easily go.
Yeah, and for sure, I think what we could expect is that it's going to have a negative impact, and it's going to reduce the ability of people in their mobility assessment. Yeah.
Fantastic.
Okay.
Thank you.
Hi, thank you for a great set of presentations. I found, Angela, your talk very interesting. And I was wondering if for the results of rural versus urban, did you have any information of the number of chronic conditions that individuals had, and if that differed by rural and urban? And I was thinking maybe that could potentially contribute to the differential costs of healthcare use.
Thank you. Can you hear me? Yes, okay, thank you. So we did actually include like a whole discussion on that in the discussion section. We're trying to speculate why is it that we found these results. And off the top of my head, I'm not remembering what the patterns of health conditions look like between the two groups, but I do know that generally those in rural areas have poor health outcomes than those in urban areas. So I would expect that we're seeing patterns like that. We did control for several, what was available. So we looked at the 10 leading causes of death among Latinx adults, and of those available in the HRS, we controlled for them, but there are several that we didn't control for, which made it favorable.
Yeah, that's very interesting. And I was having a conversation with a colleague, and he was talking about the living conditions too are so different, and there's not a lot of oversight into keeping housing up to code in rural versus urban, and how that can contribute to more exposures to toxic things. I don't know. So yeah, that's interesting. Thank you.
And even just thinking about what it means to be in a rural area, and so it isn't always to operationalize it. It can be just by designations using like the field border continuum. It can also be looking at the percentage living in rural areas of the county, and so. And even then, just like we saw in one study that differentiated between rural areas who are furthest from urban areas versus not. So there's a lot of nuances.
Yeah, definitely. Thank you.
Great presentation. So I just wanted to say first, congratulations. It is very exciting, as I was some years ago also part of a similar panel. So it's great to see that you guys are doing excellent work. So I really like all your presentations. A quick question also for Jennifer. In your models, what I saw in the data that you had, I didn't see any indicators of a household composition. And from what we know and what we have heard today, some of the healthcare usually happens within the family. And this is perhaps important for dementia or this type of cognitive decline. In the particular case that you're studying with Latino populations, I would imagine these older adults perhaps might live in extended family households, which would be quite different from non-Latinx whites. So I just wonder if you have given any thought of adding or have thought about it, perhaps including something along those lines.
Thank you for your question. That's an excellent question. I think that originally our idea for this project was going towards more of the caregiver route, so that would include following certain participants that lived within the same household as the older adult participant. However, that data was confidential and would take some time to acquire, but we did consider it would have just been more time consuming to access that private data. But they do have indicators not only on the number of household members, but also variables related to their health status too. So yeah, if anyone's interested in the NHAPS survey, it was really helpful if you're interested specifically with regard to caregiving. But yeah, I agree that composition is very important with these adoption.
Great. I think we have time for just one more question, and I'm going to ask the question. Angela, I saw that interaction didn't work out the way you expected it. If you could do it over again, if you could do your study over again, do you think you would have pursued that? Have you, after you've seen the analysis, have you maybe rethought, the model that you pursued in any way? Because this happens to us all. Sometimes we pursue models, they don't work out, and then we rethink our models. Have you had any thoughts, had time to think about that?
I think the finding that we didn't see any significant interaction itself is important to just try and understand, well, what are the factors and what is the difference between incurring these different costs versus unmet needs, right? And so I think it was helpful in just thinking through the bigger picture, which is, well, how can we actually move towards capturing and addressing the needs of these individuals? And so we do definitely have some future work that does want to tap into now, looking at the needs of rural Latinx adults and capturing some of these very specific nuances. And we could basically picture this as a first step. Thank you.
Thank you all. 2 quick announcements. We're about to enter into our next break. After our break, I just wanted to please invite you to join our poster session where we'll have an award ceremony. Please walk around and give constructive feedback to our junior scholars. For those of you who are viewing online, you can see all the posters, on the online platform. So please, if you're joining us virtually, to also take a look at these wonderful posters, and I think there's an ability for you to leave comments, for that. So thank you. I think we have one more. I think we have Flavia has something to tell you before we let you go.
I actually have a couple of announcements. The first one is that one we are going to have the poster session. So indeed, it's very, very important for you to stay around. But after that, we also have the Alzheimer's Association research initiatives. And we're going to have a presenter from the Alzheimer's Association talking about funding, particularly for emerging scholars. So it's your time to be here to really learn about all the opportunities, but it's going to be broadly to everyone, but focused on emerging scholars. Right after, we have the mentoring session starting at 5:45. So for those of you that are mentors that have been invited to the mentoring session and emerging scholars, please make sure to stay in this room so we can work on the mentoring session. Finally, for emerging scholars dinner, those who are presenters in this program have been invited to the emerging scholars dinner. Please join us in the lobby at 6:30 to 6:40. We expect to get the bus leaving from the front door at 6:50. So if you're not there, you're going to have to walk, which maybe is what you want. So thank you so much. You can get some water, some coffee, and we'll see in the back of the room for the poster session.
Okay. Okay, add it to the thing, add it to the email and say, I think the assignments might not be working on this template very well, but this is the most up-to-date one. I think that's like the, sorry, I'm trying to figure out which slide I'm supposed to be showing next. Yeah, so just send it around and say, I think this is the most up-to-date one. Sorry, I'm distracted. Which one is it? Oh, his name is Alexander, but he goes by Sandy. So maybe, yes. Email him and say, if you would like me to change your name to Sandy on the certificate, let me know. Like email him, dear Sandy, I put Alex on your certificate, maybe. Like, because I know his formal name is Alex, but I've actually spoken to him and he's like, my name's Sandy.
Yeah, I tried to his bio out, so like.
Okay. Yeah, put that on, and then just write dear Alex, and then if it's wrong, we'll let you know. Yeah. I think that's fine. Yeah, sorry, I'm just looking for something.
What are the answers? So we can have the same Thank you so much. No, it's the wonderful. Really? Do you like it? After my scholar, I see that it's out. It's very close when it's No, if you can have the one
We'll go like that. They can't.
Oh, here we go.
Sorry about this. I'll go back. Can I go back? Maybe. There you go. So I would like to first thank the organizing committee for inviting the Alzheimer Association to come talk about our research opportunities for early career researchers. So the Alzheimer Association vision is to see a world without Alzheimer and other dementia. If you are not aware, we are based here in Chicago. We have chapters all over the country. We fund globally, but we also have a hotline for families that are caring for an individual with Alzheimer and other dementia that's 24/7, 365 days of the year. And the phone number is 1-800-272-3900. And you can all find resources about the disease at alz.org. But focusing on research, our research strategy is based on seed, speed, and scale. So we want to fund ideas that were not funded elsewhere. Pilot studies, something that it's not necessarily you have preliminary data. You don't need preliminary data to apply to our funding mechanisms. We want to develop new therapies. So we want to seed those new ideas, and we want to accelerate the rate of discovery of them. So we want to fund dynamic, multidimensional, and multifaceted research. We want to focus in not only Alzheimer's, but all other dementia. Currently, we are the largest nonprofit funder of AD and other dementia throughout all over the world. We have over $310 million actively funding over 950 projects in 48 countries. So you do not need to be an American citizen. You do not need to have a green card. You don't need to be in the United States to be funded by the Alzheimer Association. Our portfolio is very vast. The main, like you can see it on the slide, 42% is we focus on biology of AD and other dementia, but we focus on dementia care, translational research, clinical interventions. So we want to tackle the disease in every possible way. You can see here that throughout the last 6 years, we actually increased significantly our funding. We have never funded this much. We increased it in over 180% in dollars and 138% in projects. So we want to fund you, you need to apply. And after this talk, if you have any questions, happy to answer any of them. So I'm gonna go through what we call the core programs. So they're focusing early career. One of them is for, there's not a timeline, a terminal degree limit, but all of this, it's opens twice a year. So the next one is gonna open in January, February 23. We are actually currently under review for this, it closed in September 1st. The website is alz.org/grants. All the information is there. You can download the program announcement, the RFA there. And if you come across any questions that you have, always reach out to us at grants@alz.org. I have people in the audience that also are in my team, and we will respond to you, I guarantee, in 24 hours. You can send an email on Grants app, and someone from the team will respond. So do not, if you are anyway, am I eligible for this or not, do reach out to us. So sorry about this. So we have 4 that I will go through specifically in the details. So we have fellowships for clinician scientists, we have research fellowships, we have research grants, and we have research grants new to the field, people that are coming from other fields to apply their knowledge in Alzheimer's and dementia. All our programs have the promote diversity component, and this is the diversity of the applicant, not of the application. So we follow the NIH guidelines for that. And we also, if you are born in countries that are low and middle income countries, but you are doing research in the United States, and it is in the list of the World Economics, you are eligible to apply to these programs. We also have this throughout the year, several other mechanisms of funding. We have ones focused on clinical trials. So these are some that are under review right now, some that will open. So we have one that's focusing in Tau. So it's called the TPAP. It's a partnership with the Tau Consortium and the Rainwater Charitable Foundation. We have one that's focus on care, that's called ARCON, that's in partner with LinkAD from the NIH. We have one that's going to be opening soon, that it's going to be focused on sex and gender, and one focused on health disparities. So I always recommend you checking the website, because constantly we are either partnering with other foundations or opening programs that you might be eligible for. All our programs are pretty straightforward on the process of applying and review. So you will have to apply submit a letter of intent. So the letter of intent, pretty quickly, you will put all the details there. I'll go through those in a little bit. And then if you are invited, those are going to be reviewed. And if you are invited for a full application, then you need to put the whole work plan, the details, everything on it. The full application is also going to be reviewed. We have over 7,000 reviewers throughout the world. They're experts in the field. If you are interested in becoming a reviewer for the Alzheimer's Association, you can also volunteer and send us an email. So we gather after the review, the online review, as a panel, like the study sections from the NIH. So we have committee calls, and we go through those applications. We have an international research grant council that will recommend the merit of those rankings to the medical and scientific advisory group. And those will make their final recommendation to the Alzheimer's Association. If we have enough funds to fund all the recommended applications, we will definitely fund. So the letter of intent, as I mentioned, all programs have that. It's through the system that we use to manage our grants. If maybe some of you are familiar with the Proposal Central, it's pretty straightforward. You don't need to do any attachments besides maybe the biosketch and the nonprofit of your institution, but you write right there on 1,000 characters, the summary, the methodology, innovation, the novelty of your project, and the impact. We want to see what your study is bringing to the field. For the programs new to the field, you will have to include a transition statement. What are you bringing from the area that you are an expert, maybe oncology, maybe bioinformatics, any other field that is not necessarily neuroscience? What are you bringing to the field? What are you of Alzheimer's and dementia? The criteria for the letter of intent is the reviewers will look into the innovation, the methodology rigor, if you are addressing the question in a proper way, if you're in line with the research priorities of the Alzheimer's Association, and something they will take a look into if you're doing studies in individuals, clinical studies, are you having power analysis, all that, statistics, it's appropriate. So the rigor of your application. And the new to the field, as I mentioned, what are you bringing? Your transition to the area of Alzheimer's and dementia, why are you doing that? And how is it gonna elevate the field? So once you're invited, so this is the letter of intent for the core programs. So we have in details here, so we have the research fellowship. That's for anyone that finished their PhD. So it can be a postdoc or instructor level up to an assistant professor level, as long as you've defended your thesis, your terminal degree in the last 13 years. If you ever applied to the association, you can see we did do some changes due to the pandemic. It used to be 10 years. We changed it to 3, we added 3 years. It might be that this will continue on. It might be that we will go back to 10 years. So if you're thinking about applying, this might be a great time to do it, because it might be that you are still eligible. We also increased the amount of funding. So now the research fellowships are $200,000 to 2 to 3 years. You can use $7,500 towards traveling. And at the end, if you do all the reporting, mentor evaluation, scientific evaluation, everything is okay and approved by the association, the PI, so the fellow, and the mentor will receive $10,000 each. It is not $10,000 for you to go to Bahamas, but it is for you to advance your research and maybe use for publishing a paper or doing professional development or starting a new project and maybe applying those data to the following step of your career. And that might be an AARG, a research grant. We fund in all programs of this set, the core programs, is all full spectrum of science. So you might do animal work, you might do in vitro in a cell, or you might do clinical work, you might do care. So any spectrum of a full spectrum of science. So we also have the Clinician Scientist Fellowship. It's exactly the same as the Research Fellowship. The main difference is that you need to do clinical service. So you need to see patients and you need to have a license to see patients. So an MD, DO, nursing practitioners, we had physical therapists, and it is focused up to assistant professor level. So assistant professors can apply to Clinician Scientist Fellowship as long as they are within 18 years of their terminal degree. Everything else, 2 to 3 years, you get the stipend, but it also has a little bit more of funding. It's $250,000. So you apply to the letter of intent, you're called for a full application, then the fellows will have to provide, the fellowship applicants will have to provide a statement of mentorship. And I do want to highlight, if you are thinking about applying to the fellowships, it is taking into consideration highly the training plan. It is 30% of your applications. When we sit in committee calls, we do see that the reviewers are very serious on how this fellowship is going to move you to your independent career. What are you going to do the next? What is the professional development during your career? What is the fellowship bringing to you? So do take time to write with your mentor and talk and discuss the mentorship statement. You need to write your own statement of commitment, and then you need to do the usual area of research where you state specific aims, the hypothesis, etc. As I said, the criteria, the mentoring plan, we've seen we actually updated now the guidelines for it because it has been a very heavy weight on the review process. We've seen applications that the science is good, but the mentoring plan is not good and they have not been invited to be funded. The reviewers will also look into the impact and risk of the application. And all programs of this set, the core programs, we allow resubmission. So if during the letter of intent portion, you don't get review comments, but on the full application, you will get the reviewer comments. So if you, by any chance, you're not invited, we recommend you to try again and address the comments. You may do it as a resubmission. You will need to submit a letter of intent again. And if you are invited at that stage of the full application, you will have a resubmission statement. So it's kind of a response to a paper. You will have one page to address all the comments of the reviewers. You may do it as a resubmission, or some applicants decide, no, I'm just going to do it again as a new application. That's a choice of yours. We don't have limits for resubmission. So if you, let's suppose we open twice a year, the programs, we have one that usually opens in the winter, January, February, and one that opens in the summer, July, August, August, September. So if you don't get funded in one round, you can apply the next, or maybe skip, think about it a little bit and do on the following cycle. Once we've had a lot of folks that were funded by the research fellowship, and then they moved into their independent careers and applied to become research grants, because this mechanism is focused for newly independent investigators. So folks that are assistant or associate professor level that are within 18 years of their terminal degree. So also if you've applied in the past, it used to be 15. So now it's 18. We've added 3 years to all programs. And this program is $200,000, 2 to 3 years as well. You have a travel stipend of the same $7,500. You don't have the mentorship component because you're already an independent investigator yourself, but we do we fund all spectrum of science as well. The new to the field, we don't have a limit of the terminal degree because we want to bring people that are maybe full professors and did their careers in something else. We've funded people of researchers that were doing research their careers in oncology, bioinformatics, even engineering, that they come and they see on their own field of expertise that this, whatever molecule or assay or something might be applicable for Alzheimer's and dementia and other dementia. So they apply to the new to the field. And it's $200,000, 2 to 3 years as well. And so definitely full spectrum of science. This is a program that's been growing constantly in the last few years. And this is something that we are very proud to fund because it is, we want to bring more people to study and tackle Alzheimer's and dementia. The peer process, this is for all, for the research grants. You don't have, as I said, the mentorship component, so you will have the statement, the work plan, specific aims, hypothesis, and the new to the field, the transition statement. What are you bringing? That's different. As other review process, you're going to the reviewers will take into account your application, your applicant, your biosketch, your career, your CV as well. The quality of the work, the methodology, is it well done, well performed, impact risk, and as I said, resubmission are allowed. For every program, so the research fellowship, the clinician scientist, the research grant, and new to the field, if you are recruiting individuals for your study, you need to provide a recruitment plan. The Alzheimer's Association we are strong believers of diversity in the studies, diverse population. So we do take into account the population you will be recruiting for your study. Also the available resources and the budget justification, obviously, as it's common for all grants. Biosketches of the applicant, biosketches of the mentor, biosketch, you may add biosketches of key personnel as well. And we strongly believe in data sharing. So what is your plan of data sharing? Is it through open access? Are you providing data in open data sharing online if you're doing biological research? And if you're doing a resubmission, the resubmission statement. And then you have references, citations. So this is just a pretty much just a summary of it all. You can find this on the RFA as well. Just basically saying everything that I just said, what the eligibility. And we always like to talk with any one of us that give these talks. It's like, I give you all tips of success. First of all, please read the program announcement and the RFA carefully. And why do I say this? Because we constantly update it. So if you've maybe applied last cycle and you go apply now, some things might have changed. Allowable costs, like for the research fellowships, I will give you an example. We used to allow 3 pages of letters of support. Now it's 1 page long. So make sure to check that list and see if everything that you are submitting to us makes sense. And carefully read everything that's on your portion of the program announcement. And this is not only for the Alzheimer's Association, obviously it's for all funding agencies. So as I said, the letter of intent is reviewed. So we don't guarantee you're going to be invited for a full application, but we do tend in average to invite around 40 to 50% of the letters of intent that are submitted, depending on the cycle. As I mentioned, the eligibility criteria, it's very specific to each program. So make sure you are applying to the program you are eligible for. If you have any questions, reach out, send us an email. We are very responsive. If you are unsure, just write to us and someone will reply to you. And this is something that we highly recommend. Get someone to read your application that it's not necessarily in your area or maybe around lab or your research group. get someone else to read it, because sometimes the people around you are so used to that the reviewers, sometimes it's not clear for the reviewers. We do get a lot of issues that applications are not funded, and we have meetings with the applicants, and then we talk to them about the review. It's not clear to the reviewer what you wrote. It might be very clear to you as a scientist, as a researcher, but unfortunately for the reviewer, it's not. We try to match as much as possible the reviewers that are going to read your application to have the expertise to review your study. We have 3 reviewers per application, so that do take into account as well, and then the committee call. But always get an extra pair of eyes, typos, everything. Always think that maybe you are a reviewer yourself. You are not going to review only one application. Most likely reviewers are reviewing 4, 5, 10 applications. So if they go through and there are typos and things that are not clear, obviously as a reviewer, you lose attention to that. And we do allow you to identify reviewers that you want to include and reviewers that you want to exclude to evaluate your application. We will for sure and absolutely exclude the ones you put in. However, we do not guarantee that we will give to the applicant, to the reviewers that you want us to include. We will try, but it's not guaranteed due to availability as well of the reviewer. If you are doing a resubmission, make sure to read the comments and address them as much as you can, and use that space of resubmission statement. You have a whole page to address that. So make sure to use that, and it's your benefit for it. The next cycle, that if it is a resubmission, not necessarily the same reviewers are going to get your application, but they will have access to the previous application, and they will have access to see if you addressed the comments properly, if you change the application properly. And as I mentioned, call us, email us. We are there. We want to fund you. We want to help you. There's only so much we can control, but there's so much we can answer as well. So please write to us. This is something I always say in my talks. We all want to be millionaire. We all want to win the lottery. Not everyone buys a ticket. Everyone wants to be funded by the Alzheimer Association. So please apply. You may apply. Some people, sometimes they don't even know they're eligible. We had some folks in the last cycle, they did not know they were eligible. They heard a talk or went to a conference, saw the eligibility, they applied and they were funded. So give it a try and good luck. But also on that sense, throughout the funding mechanism, as I said, the pair of eyes, the extra pair of eyes that we want. Another way to find those eyes outside your own network, it's becoming a member of the Alzheimer Association International Society to Advance Alzheimer's Research and Treatment, iStart. So iStart is a society of the association. We have over 7,000 researchers that are brought together to pursue knowledge, collaboration, and breakthroughs. It is currently, we actually changed the fees. So any student, grad student, it's free of charge. And folks that are in low and middle income countries are also free of charge. Postdocs are $65 a year and professionals are $130. There are lots of benefits of becoming an iStart member, including not only having access to all the journals, but the main and career center, but also the main thing is actually that you have access to the professional interested areas, the PIAs. The PIAs are, we have currently 29 of them actually, and they have all subjects. So it's a group of people that will meet and discuss different subjects, and you can find your future collaborators, future people that will read your applications. Papers came out of PIAs, so, we have PIAs that are for Down syndrome, for clinical trials, for women in science, for the diversity and disparities. So we have all sorts of PIAs. You might participate in one. Sorry, I don't know, it's going automatically here. You might join one, or you may want to join 29. but you are welcome to join, and it is a great networking event, networking opportunity. Also, the iStart has webinars, several journal clubs, guide to grants, guide to conferences. I don't know why it's going, sorry. There's actually a webinar that we recorded in the beginning of the year that is focused only to the grant. We interviewed people, reviewers, so that it was a 5-day series that I would highly recommend you taking a look. We interviewed reviewers, applicants, awardees from the association, current and past, and they shared their own experience of how to apply and their insights. So definitely take a look into those webinars if you're an iStart member. Also, with Alzheimer Association, we do host the biggest Alzheimer conference in the world, the AAIC, the Alzheimer Association International Conference. The last one was just 2 months ago in July in San Diego. We had over 10,000 attendees in person and virtual. All our conferences are virtual, are hybrid format. If you are an iStart member, the virtual component is always free. So we had actually 5,000 people in person in San Diego, but we also had over 5,000 people all over the world. We had actually more attendees that were women, 60% were women. We had over 700 presentations, over almost 3,000 posters. It was a blast. Everyone was happy to actually be in a conference for the first time after 3 years. And the next one is actually in Amsterdam, July 2023. So if you have funding or opportunity to go, make sure to put it in your calendars. But we also have other conferences until the next AAIC. We have just around the corner, the SANCON, the Southeastern Neurodegenerative Disease Conference, that's gonna happen in Bonita Springs in Florida. We also have one that's gonna happen in Kenya with our partners of the Global Brain Health Institute and other partners like University of Texas. That's gonna be focused on brain aging in low and middle income countries. We have one that's going to happen only focused on APOE and immunity in March. We have one focused only on advancements of immunity. And also we have one that's called AAC Neuroscience Next, that it's focused on grad students, postdocs very early on their careers. So make sure to take note, ALS.org scientific meetings. We always update, there's always meetings happening. So make sure to always keep an eye, not only on the grants, but also the scientific meetings. And I would be happy to answer any questions now. And if you come up to any other questions that maybe now you didn't think of, send us an email and we'll be happy to answer. Thank you. Any questions? No? So do make sure to check the website and make sure to send us an email. We will respond to you. Okay, we definitely fund from. So just one thing is some people will write to us. We do not have, sadly, any mechanism of funding for grad students. So you do need to have a terminal degree from PhD on. Okay, thank you.